whole blood group, and effect of survival are good, especially in severe trauma patients. So this published in JCS, that is American College of Surgeons. And in US, this group, Dr. Brian Cotton, they are working hard for last 5 years, where they say that low titer group O whole blood, LTOW, and they are promoting this, that is remerging role of whole blood. And as we know, this is a walking blood banks. People in military, they have the blood groups, they have a screen, they have already know the blood type, and they are the walking blood banks. So they have the resources, and military is using for Afghanistan, Iraq war, and all the war areas. That is, and we are also, and nowadays we are talking a lot that this country is against this, and things are going on, and it may increase. So whole blood based resuscitation by using cold stored low titer O units, that is also FDA approved now. So this can be used. Only question that it is universal versus type specific blood, RH whole blood versus RH negative blood, or we can use safely in children. The answer is that. Answer is yes. Whole blood resuscitation is safe in pediatric trauma patients. This multicentric study that says that it can be safely used in pediatric trauma patients, 0 to 17 years. And another study is low titer whole blood, truly a universal blood product. This answer is that it appears to be a safe product for universal use across all blood groups. Group B recipient arrives with worse physiological value in shock, and they receive whether this whole blood or component. So another evidences in 2021 in emerging blood transfusion for trauma patient with perioperative resuscitation standard of care. In 2021, whole blood transfusion is used especially in military scenarios, and is also becoming more and more popular in civilian world, although it is accompanied by a strong lack of evidence. And so we need more things to study and explore, so that the
last
God given
2
us,
minutes, please.
yeah. So the God gift can be used properly in saving life. Single institutions trial comparing whole blood versus balanced component. 50 years later, where we are, we saying that whole blood is better, and it has less in-hospital mortality, less ventilator days, and pulmonary edema and all that. A review in transfusion whole blood for trauma patient outcome at higher doses. So they say that we are now moving from 1:1 transfusions to the low titer group O whole blood transfusion, because the additives in the component therapy, they are also not increasing the oxygen carrying capacity, and they dilutes the coagulation factor. So lot of evidence. So in summary, by reviewing this 3 to 5 year recent evidences, whole blood used many years since its inception, that blood can be transfused in an human for saving lives without any harm. It proven time tested in military trauma. Thousands patients, hundreds of studies, and evidences also emerging in civilian trauma. Only thing is that everything in life has an advantage and disadvantage and risk. So same here with the component and the whole blood. Only thing that availability. If it is available, definitely, because in my residency in India, we have used this. Now, if it is available, I think most of you would like to use it as per the evidences, both in adult pediatric trauma patients and in civilian setting also. Thank you. Thank you so much.
Thank you. Thank you very much. That was a very holistic talk, if I may say. Thank you. Any questions at all, or shall we take them in the end? Right.
Okay.
Thank you.
Thanks.
Thank you very much. If anyone in the audience has any form of backache, headache, heartache, any of those things, please do not leave this hall. The next talk is on newer analgesic drugs by Dr. Rahul Balasubramaniam.
Good afternoon, everyone. First of all, I thank WASM team as well as EPAT team for giving me this opportunity to talk on the topic new analgesic drugs. So, overview of this discussion would be briefly described regarding the pain pathway, the changing landscape in pain management, mainly the CERTA strategy, evolving analgesic and pain ladder, brief description about traditional analgesics, characteristics of new generation analgesic, rather analgesia, and few examples of new analgesics. So, you all know pain is the root cause of main presentation, almost 75 to 80% of all complaints according to the present prevalence across the globe. So what are the challenges? Because delayed pain management is a routine in most of the busy ER, and another one is oligoanalgesia. So what do you think? The reason for oligoanalgesia is because of the fear of the side effects or the adverse effects because of the routinely used analgesics. And our aim is not to get a zero pain, but to have a practically reasonably good pain relief on reassessment, reduction of at least 40% of pain score. And in the background of opioid epidemic in all the developing countries, even in developed countries, we have a wide use of opioids, which leads to a scenario called opioid overuse or opioid epidemic and its side effects. So to conclude, or in short, we need to have a balanced analgesia. You all know the pain physiology, the pain pathway, which is by peripheral nervous system as well as central nervous system. Any nociceptive stimuli from periphery goes through the myelinated as well as unmyelinated fibers, reaches the dorsal column of spinal cord, and then to the brain and the higher centers. So as in the diagram, there are different levels of analgesics which can help decrease the pain. That can be both pharmacological as well as non-pharmacological. So my talk would be not only new analgesic drugs, rather analgesia. So it need not be always drugs which can decrease the pain. It can be some other non-pharmacological techniques too. So to review the pain ladder, so the conventional pain ladder, we have 3 steps to start with: mild, then moderate, and severe pain. Usually, we have the conventional drugs. To begin with, the most safest one is acetaminophen, paracetamol, or maybe NSAIDs. Then we move on to weak opioids and strong opioids. So what WHO has come up with is a new addition. In each step, it can be an integrative medicine therapy. And while you leap from step 2 to step 4, we have an additional one, that is minimal invasive intervention. So that can include, which we all know now, even after the advent of the ultrasound and easy availability of ultrasound, regional nerve blocks as well as plain blocks are being used, which can be used in order to get a balanced analgesia so that we can reduce the adverse effects of analgesics being used. So what is the armamentarium? We told that the integrative medicine therapy, which we can include in each and every steps of pain ladder, can be a non-pharmacological, which include physical like physiotherapy, osteopathic manipulation, mechanical support, or active mobilization, direct like heat or ice, acupuncture. All this have got even adequate evidences to use: transcutaneous electrical nerve stimulation, deep breathing, and ultrasound. Indirect like music therapy, aromatherapy, hypnosis, and even guided imagery, which can actually decrease the pain. Educational and physiological like cognitive behavioral therapy, which been using for psychiatric patients, verbal suggestions, and family support. So this can be integrated to any step of the pain ladder. So it has come to an extent that a virtual reality helped reducing the pain during labor. So there is a Frey and al. Showed in 27 unmedicated pregnant female could decrease the pain and anxiety. And in 2018, a systemic review by Scapin et al., which includes 34 studies, showed virtual reality can decrease pain while dressing changes, physical rehabilitation, and physiotherapy. Coming to this, what is CERTA approach? That is nothing new, but we all know what is written on the left-hand side of the table. That is nothing but different targets, the channel, enzymes, receptor targeted analgesia. So rather than shooting blindly, we'll narrow down it and nail it. So that's what the CERTA approach is all about. So according from the history and the pathophysiology or etiology which you know regarding the pain presentations, you can actually target or nail the exact cause. For example, for COX and COX-2 inhibitors, we usually use ibuprofen, diclofenac, naproxen. So you can exactly nail the causative inflammatory markers. So coming to a few drugs which are considered new, need not be a newly invented one, which was used previously for some other indications, now being used as a neuroanalgesic modality. So methoxyfluorine, known as green whistle, it is a halogenated volatile anesthetic. It is a non-opioid alternative to morphine that is used for acute pain relief. So usually, when I talked to some of my friends in UK yesterday, so they were telling they use it frequently in pre-hospital scenario when there is some fractures. So now this is being used widely in New Zealand as well as Australia, but it is banned in United States because of the nephrotoxicity, which was there when used in higher doses. So basically it is used with a puff. You can take 3 ml of the methoxyfluorine in a charcoal container and take the puff 1 or 2 times to decrease the pain. And it is marketed in UK as Penthrox. So the take home would be, you can use it, but be careful how many times you use it and how you use it, and be careful about the nephrotoxicity. And there are RCTs on this, like stop trial, Mediata. So it's not a new thing, but it's been using, but have to be careful while using methoxyfluorine. Next is dexmedetomidine, which again is not a new drug, but if it can be used intranasally also, which actually decrease the side effects. You all know that the side effect, it being an alpha-2 agonist, it can cause bradycardia and hypotension. So if you can use it intranasally, it can actually decrease the opioid use, which we use usually for post-operative patients. So concomitant dexmedetomidine in post-operative patients is a good option, along with regional blocks as well. Next is buprenorphine, used for treatment of withdrawal. It's an opioid receptor agonist, and it is being successfully used for neuropathic pain, cancer pain, as well as post-operative pain, and even in renal colic. So 4 milligram sublingual buprenorphine is an option for acute bone fractures. Next is a subdissociative dose of ketamine. It's a non-competitive NMDA receptor antagonist. And the main mechanism of action is decreasing the central sensitization and pain memory. And subdissociative doses, 0.1 to 0.4 milligram per kilogram. Again, this can be used intranasally at much lower doses. Early and rapid pain management and long-lasting analgesia is one of the advantage, and it bypasses the first-pass metabolism. So again, it helped in decreasing the side effects. Next is topical clonidine, which is classically used for refractory hypertension, especially in chronic kidney disease. So this can be used topically for painful diabetic neuropathy, and also being used as a topical agent, again decreases its adverse effects. So this table mainly enumerates few drugs which can be used intranasally, which we already discussed: dexmedetomidine, ketamine, fentanyl. Intranasal fentanyl is there in a lot of pediatric algorithms where you can't get an IV access. You can resort to intranasal fentanyl.
Last 2 minutes, please.
Yeah. Next is intravenous lidocaine, which has been, it can't be used routinely for a renal colic, but refractory to other drugs like diclofenac and opioids, you can consider giving intravenous lidocaine for renal colic too. Desmopressin in renal colic, again, its analgesic effect, it's due to its antidiuretic property. Decrease the renal pelvis pressure and it is causing decreased pain. Next is tapentadol, a synergistic mu opioid receptor agonist and noradrenaline reuptake inhibitor. Doesn't have an active metabolite, so the risk of accumulating and producing overdose or adverse effect is less, and is metabolized by cytochrome P450 enzyme. So it has got less side effects like nausea and vomiting compared to opioid, but be careful about respiratory depression when you're using it. So alternative to morphine and oxycodone. This remimazolam is not an analgesic as but it is used as a sedative, but can cause analgesia when used with other drugs. So this is the CERTA strategy. You can map the particular receptors to the pain presentation, and you can choose which drugs to be given to the patient. It's not a complete comprehensive list, but you need to have the assessment of the patient at the same time to look for any contraindication. So what is the challenges when you talk about a new drug or a new therapy? It is always the cost, the accessibility, as well as the potential side effects. So being said that, these are the challenges, we should work on it, and the future prospect. So we already discussed the pain pathway. The sensitization occur in the dorsal horn of spinal cord and the higher centers of the brain. So the future research or future analgesics which are being developed or are in pipeline is being addressed regarding the central sensitization and long-term potentiation. So take-home point should be limited newer analgesics are introduced recently. So older drugs used for other indications are being used for analgesia. Better we go for a channel enzyme receptor targeted analgesia rather than shooting blind, nailing it down. And there are non-pharmacological options. And finally, reduce doses, thereby optimizing safety and efficacy of analgesic regime. So our aim should not be a zero pain, but a balanced analgesia. So these are the references. Thank you. I'd be happy to take any questions.
Do we have any questions? Is anyone in any kind of pain? Okay, it's good to know. Superb. Thank you. Thank you. The next speaker is the last speaker and is talking about a topic that gives headache to patients and also gives headaches to emergency physicians, because we are seldom good at picking it up. Ladies and gentlemen, last speaker for this session, Dr. Soumya Nair, Management of Acute Glaucoma.
Thank you, Dr. Muthasa, and thank you, Dr. Rahul. Good afternoon, everyone. Am I audible? Yeah. Okay. So I would like to thank World Academic Congress of Emergency Medicine for giving me this opportunity. It's an honor and privilege to be on this stage. My topic for today, I'll just quickly introduce myself. I'm Dr. Soumya, Assistant Professor of Ophthalmology, Kasturba Medical College, Manipal Academy of Medical Sciences, Higher Education, Manipal, India. Slide change. Yeah, good. So, the topic of interest today is emergency management of acute glaucoma. Let me start with a clinical scenario. A 60-year-old female presented to the ED with complaints of acute onset diminution of vision in the right eye, which is painful, and was associated with severe headache and recurrent bouts of vomiting. She had other associated symptoms like redness, photophobia, and lacrimation. So what are the possible differentials you can think of? The first possible and the most important differential in this situation will be primary angle closure glaucoma. But you have to keep in mind other causes of acute glaucoma like traumatic, inflammatory glaucoma, lens-induced glaucoma, and drug-induced glaucoma. So what is the importance of primary angle closure? Primary angle closure glaucoma is a sight-threatening condition. As an acute care physician, saving the sight is one of your priorities, isn't it? And acute angle closure glaucoma is a great mimic too. It can mimic many of the emergencies that come into your ED, like neurosurgical emergencies, gastrointestinal emergencies, and tox emergencies. So how can you evaluate such a patient when he or she comes into the ED? So we can start with simple bedside evaluation of anterior segment, anterior chamber depth evaluation, and digital tonometry or applanation tonometry if there is a slit lamp in the ED. The anterior chamber depth evaluation can be done using a simple torchlight. Ask the patient to look straight, shine the light from the temporal side of the patient and look at the anterior chamber. Two things you have to look for. Is the anterior chamber well illuminated? And second, is the nasal iris of the patient seen properly? If the nasal iris is not seen properly and the nasal anterior chamber is in shadow, that indicates that the patient is having a shallow anterior chamber, just like the second picture there. Now, how can you assess the intraocular pressure bedside in the ED? A simple method called digital tonometry will help you. With the index finger, press on the upper lid on the eyeball of the patient. Ask the patient to look down and feel the pulsation on the other index finger. And if the pulsations are not felt and the eye appear rock hard, that means the intraocular pressure is very high. Now, is there a role for point of care ultrasound in case of acute angle closure glaucoma? Yes, there is. Why? Because often in cases of acute angle closure attacks, the patient will be having a cloudy cornea due to corneal edema. This will impair the visualization of the anterior chamber and the depth assessment. In such cases, we can rely on focus. So, we can assess the anterior chamber depth, the anterior chamber structures. Even we can look into other causes of acute glaucoma like phacolysis, phacomorphic, subluxation, hyphema, etc. Now, while doing focus of the eye, we have to use a linear probe, a high frequency linear probe, and it has to be kept transversely over the closed eyelid of the patient after applying a lubricant, and the pointer should be towards the temporal side of the patient. And we can see the whole globe, then the cornea. The anechoic area beneath the cornea is the anterior chamber, and then the anechoic area beneath the anterior chamber, this is the anterior chamber, and this is the lens, which is the anechoic area beneath the anterior chamber. And the line between these two anechoic area is the iris. And the large anechoic area beneath the lens area is the vitreous cavity. Now, coming to anterior chamber depth assessment, in the first image you can see that the anterior chamber is very deep and the angles are wide open. While in the second picture, the anterior chamber seems shallow and the angle seems narrower. Now, this image, the first image, shows the pupillary block. The iris is opposed to the lens at the pupil, and there is an iris bombe which is causing complete closure of the angle. The second image, you can see an anechoic lens, and above the anechoic lens in the anterior chamber, there are hyperechoic areas which is suggestive of a hyphema. We can also evaluate lens changes using focus. In the first picture, as you can see, the lens appears hyperechoic and bulging forwards, which is pushing the iris diaphragm forwards, shallowing the anterior chamber. This is suggestive of a phacomorphic glaucoma. While in the second image, I hope you can make out that the lens in one area is pushing upwards or subluxated anteriorly, and it is pushing the iris in that area only, causing a shallowing in that area, shallowing of the anterior chamber in that area. Now, coming to the treatment of acute angle closure glaucoma in the emergency department, what can we do? So, the first and foremost priority is to bring down the intraocular pressure immediately. As long as the IOP remains high, the more damage to the retinal nerve fiber layers happen and irreversible visual damage will occur. So, we have to prevent that. The drug of choice is always hyperosmotic agent mannitol. We can give 20% mannitol 100 ml IV over 30 minutes. Also add on IV antiemetic medication and stabilize the patient. Once the patient is stabilized, we can switch to oral anti-glaucoma medication such as acetazolamide, oral hyperosmotics such as sorbitrate or glycerol. When the patient is in the ED, avoid prone positioning because it will exacerbate the angle closure. Also, if there is a traumatic patient with high FEMA, advise head and proctor positioning. Avoid mydriatic cycloplegic medication, which will also worsen the angle closure. And in certain cases, we have to have a high index of suspicion for drug-induced angle closure as well. So my take-home message from this session would be, if a patient walks into your ED with headache, take a second to look into the eye of the patient. Clinically evaluate the patient in the ED and judicious use of POCUS if there is a suspicion of angle closure glaucoma. And immediate reduction of intraocular pressure should be done to prevent irreversible damage to the vision of the patient. So, say this lady walks into your ED. I hope you will keep these points in mind and you will be able to pick up the angle closure attack and manage to bring down the IOP at the earliest, so that the patient won't have a scotoma but will have a clear, good vision and a good quality of life in the future. I'll be happy to take questions. Thank you.
I think that was an eye-opening talk. Does anyone have any questions?
Yes.
I see some redness of eye in the audience. Where is that? Sorry, there. Yeah.
Yeah. Yeah, the digital tonometry. Yeah, it's a very simple test. Ask the patient to look down. Use the pulp of your 2 index fingers. Okay? Place the fingers above the tarsal plate, at the edge of the tarsal plate. Press with 1 finger so that you can feel the pulsation on the other finger. You can feel it on your eyes itself, can't you? So that is indicative of a normal intraocular pressure. Normal. If it is very high, the eye will appear rock hard and you won't be able to do these pulsations. Okay? Is that clear?
Yeah.
Thank you.
After this talk, you can meet her. She'll do a free examination for you.
I'll be happy to. Yeah. Any more questions? Thank you.
There's one more, sorry. There's one more from...
Thank you. I have a question,
Yes.
actually. The setup in your hospital, is it based on ophthalmology present in the ED or emergency physician providing the care for acute glaucoma?
Acute glaucoma, both actually. When the patient walks in, emergency physician can start the IV mannitol, but of course, ophthalmology team will be the ophthalmology team will be notified, and they will be taking over the patient at the earliest.
clarify,
Yes.
in-house or home?
Yes, sir.
The ophthalmologist will be in-house in the ED, or he will be called to come. So time is a factor here.
Yes, yes.
So what is actually the time factors that will require for ophthalmologist to be in-house to provide the care for this patient?
Yeah, so it will take at least 10 minutes for the ophthalmologist on duty to come, but we can save that time also if if we are trained to look into the eye and understand that this is an angle closure attack, then no need to wait for the ophthalmologist to reach. We can, that much amount of time can cause that much amount of damage to the retinal nerve fiber layer, so that can be prevented. Yes.
Okay. Thank you. Does anyone have any questions for the first two speakers? We rushed them because of keeping the interest of time in mind. Any questions for emergency transfusion in pregnant trauma patients? Dr. Indulata is still here. In pregnant trauma patients, emergency transfusions. Any questions on whole blood transfusion?
Yes.
The question on whole blood transfusion. So, Dr. Sandeep Sahu is here.
Yeah, if it's okay, Dr. Sandeep, I have a question regarding actually your protocol. You said in your hospital you do have whole blood transfusion. So what is the setup and how this impacts on massive transfusion protocols?
It's around 18 years back in India when I was doing residency. At my hospital that time we don't have the component therapy. So we are using the whole blood for gunshot and all the laparotomies. But nowadays, in other emergency, definitely emergency medicine, we have component therapy nowadays. But I am especially being my primary specialty in anesthesia, and I am seeing day and night massive blood transfusion and severe hemorrhagic shock in the ORs and ICU. And anyhow, I am thankful to my transfusion medicine department. We have to take component, but we have to do massive transfusions. And after all that thing, the only problem that I have, that patient need go in overload. So, and it's again rethinking with the evidences, because I have given task to what is the recent trends. So recent trend is coming back, and even in the wars, that is Afghanistan and Iran war, and even the things are going in disaster worldwide, the blood bank is not available, Dr. Althani, everywhere. And I think if we got the opportunity to have this whole blood, I would like to use, because I have used this during my residency days. So I have that not hesitancy, and you can say the new thing to use, whether it will work and will not work. So sorry, but nowadays in my hospital we are not having whole blood. But definitely I would like to have, especially it's good for severe polytrauma and hemorrhagic shock. Thank you, Dr. Althani. So what's your say, sir? Because you are a trauma surgeon, I know, and you work in ED, and we have seen your hospital. So what's your thought? I would like to add on this.
We've got about 1.5 minutes, so it's not bad.
Thank you. Regarding actually whole blood, the resistance comes usually from the blood bank and hematology. And in our setting, we managed to have whole blood, but that actually has two sides to it. One, you have to have availability of point of care. So in the trauma setting, we have point of care for all actually the point of care required. So we have TAG, ROTAM, INR within the trauma recess in our setting. We have a fridge also, which we have one shipment of massive transfusion plus whole blood sitting in the fridge in the recess. In the OR, we have also a fridge which is connected to the blood bank, and we have this whole setup. The issue is the algorithm that required to run these protocols. And we are actually cautious in these patients because they have, to be taken in consideration their reaction in the future and so on. But we currently have it, and we are discussing this on a regular basis with also a pre-hospital setting possible to have whole blood for this patient. Thank you.
Ladies and gentlemen, just like many commercial flights, we have landed our session 8 minutes before time. So I'd like Dr. Behshat, if he's got anything to say in conclusion. Okay, I think the conclusion is this is concluded. Thank you very much. Thank you.
Microphone long here, please.
Thank you very, very much indeed for your kind invitation again to this World Congress, and many thanks for these very kind words that certainly please me and honor me very much. I like to speak about one of my favorite topics, sepsis, a terrible problem. And you know that we define it, we have always defined it as a bad infection, as a life-threatening organ dysfunction caused by a dysregulated host response to an infection. That's what it is. For a scientific publication, one could use a score to determine the severity of organ dysfunction. But for our everyday practice, we don't need any score. And that's the same in children. So if you look at the pyramid of severity, starting from colonization, an infection will be characterized by some host response, usually fever, an abnormal white blood cell count. When it is sepsis, there is more. There is organ dysfunction. And if there is septic shock, there is an alteration in tissue perfusion and an increase in blood lactate levels, typically above 2 milliequivalents per liter. So sometimes we identify sepsis in a patient having an infection complicated by organ dysfunction. But we must keep in mind, and this is very true in the emergency department, that sometimes patients come with some degree of organ dysfunction and it's not so clear why they have it. It may be sepsis. There may be a severe infection. And when we speak about organ dysfunction, we need to consider 6 organs: circulatory, respiratory, renal, neurological, hepatic, hematological. And these are the 6 items included in the SOFA score to evaluate organ dysfunction. But I'll focus on management this afternoon, and I will look at the 3 components: infection control, hemodynamic stabilization, and modulation of the host response. So if you think that antibiotics work, then we should start antibiotic therapy without delay. And we should give the right antibiotic, right? That is particularly important in severe cases, that is in septic shock. So the timing is an issue. We should not waste time when the situation is severe. So if I go back to my pyramid, it's particularly true in septic shock, when there is an alteration in tissue perfusion. And we know that sometimes we waste a little bit of time in the administration of antibiotic therapy. This is a nice recent study emphasizing at the bottom of the slide that this is particularly true in patients with septic shock. Now, hopefully, when there are signs of infection, the antibiotic administration is usually relatively rapid. So you can see when there is hypotension or when there is fever. But still, sometimes we waste time. Sometimes in the administration of antibiotics, we order the antibiotics, but the nurse is very busy with other things, and the antibiotic administration is delayed. So it's not only in the hands of doctors, it is in the hands of the team. Some people may say that we sometimes overuse the antibiotics. In the United States in particular, where there may be some medical legal aspects, give antibiotics to all patients with fever right away. That could facilitate the development of resistant organisms. So today we look at this like this, as disease severity versus degree of certainty. So if we are not sure about septic shock, but if it's septic shock, the severity is there, we should not hesitate too much before giving antibiotics. But if it's not too bad, we may have time for additional tests if it's not septic shock. Remember these important studies showing that sometimes we admit patients in the intensive care unit for likely sepsis, but actually this is doubtful at the end. When we have all the elements, we may think, after all, it was not septic shock. Or here in an emergency department in Boston, they found the same thing. Sometimes we think it's septic shock, but it's not. It may be cardiogenic pulmonary edema. It may be a drug effect. It may be some malignancy. So sometimes we give antibiotics for some patients who may not need them. We must accept it. But the choice is important too. I like this paper published recently, where they showed that if you don't give the right antibiotic, prognosis is worse than if you give the right antibiotics. Okay. But this is very interesting. If you give wide spectrum antibiotics to patients who do not need it, the outcome may be worse. Perhaps because there is a selection of resistant organisms. So the message is, too narrow spectrum may be harmful, but too wide spectrum may also be harmful for the patient. And we should never forget that the antibiotic administration can be reassessed later. So give antibiotics as soon as possible. The more severe the presentation, the more urgent the antibiotic administration. And antibiotic therapy should cover all likely pathogens, not less, but not more. And of course, source control is very important. And here also, we need to motivate the team, the nurses, the surgeons, if there is a need for laparotomy, for instance, the radiologists before that, the anesthesiologist, a team effort. But let's move to the hemodynamic management. My mentor, my teacher, was Dr. Weil in Los Angeles. And Dr. Weil was saying every patient is a VIP. Ventilate, infuse, pump. Ventilate, well, we have good ways to use non-invasive mechanical ventilation today. But in shock, we should not wait too long before endotracheal intubation if required. If we wait for too long, there may be respiratory arrest. So what are the things to look at? With my colleagues at the Surviving Sepsis Campaign guidelines, I said we need to give recommendations to the doctor about when to intubate the trachea. And they said, oh, Jean-Louis, there is no randomized controlled trial on this. I know, but we need to give some guidance. So would it be the degree of hypoxemia, the neurological status, sometimes the PCO2, the hemodynamic status, the muscle function? Are there plans for major surgery? It could be a combination of those. We need to help the doctors. So my recommendation, actually it's not mine, I found it on internet. It is to ask the patient to pronounce metoprolol. If the patient cannot pronounce metoprolol, it's the right time to put the tube in the trachea. Infuse. Every patient with sepsis will need fluids. Not too much, but not too little. Not too little. And we cannot go by formula. Because a patient with pneumonia may require less fluids than a patient with peritonitis. There may be a little bit of vasodilation or much vasodilation. There may be more capillary leak with unavoidable edema formation. And we may need to bring cardiac output to a supranormal level to bring enough oxygen to the cells. So some years ago, a couple of years ago, people were discussing restricted liberal fluid administration. This is over because these trials randomizing patients for more or less fluids showed no difference in outcome because some patients may benefit from one strategy, but some others may be harmed, and vice versa in the other group. Look at this recent paper published this year in the New England Journal of Medicine, comparing more fluids with less fluids but more vasopressors. Well, if anything, the patients who were in a restrictive fluid therapy were worse than the others. They were more likely to need a stay in the intensive care unit. Clearly, fluid restriction is dangerous. There will be some edema formation. We don't like it, I agree. But that's the price to pay to have a sufficient cardiac output. We may need vasopressors, I will go to that in just a moment. But vasoconstriction is really to avoid. So we need to navigate between the two. We all know that. Maybe artificial intelligence will help us in the future to decide whether we should give more fluids or more vasopressors. But to stay with simple things, an edematous patient may be hypovolemic. Sometimes there is a doctor coming and say, oh, there is some edema here. Oh, stop giving fluids. That doesn't make sense. No, we don't know. Because in sepsis, there is always some edema formation. So let's be careful about the word fluid overload. Because sometimes we say the patient is in fluid overload when there is edema. But edema does not exclude hypovolemia, especially if there is hypoalbuminemia, which is associated. So let's be careful. Likewise, the fluid balance doesn't help very much. The patient may still need fluids even when the fluid balance is positive. So we all agree now that we need individualized therapy. Initially, in the salvage phase, when the patient arrives in the emergency department, we could just pour fluids initially, and we try to bring a monitoring system at the same time. You cannot do without a monitoring system. The studies in Zambia or in countries where they couldn't get any monitoring system failed. But hopefully today we have echocardiography that could help, at least initially. We don't need to be experts in echocardiography. In every single emergency department, there must be an echography machine available, not only for a septic shock, but also for trauma, for heart failure, for other problems. So that helps us to go into the optimization phase, where any single variable taken alone will never tell us if the patient needs fluids or not. We actually need to combine variables. We need a dynamic approach. In the operating room, when the patient is anesthetized, we could look at the effects of mechanical ventilation on the blood pressure tracing, on the pulse pressure variation over time. That would indicate that the patient is still responding to fluids. But in the emergency department, no, because we want to avoid sedative agents in shock. Sedative agents today are better avoided because they can decrease vascular tone, decrease the myocardial contractility, increase the risk of delirium, and they induce long-term weaknesses. So today we try the ECASH concept. We try to explain to the patient what's going on when we can. Of course, we control pain with analgesia, but the patient may not need sedation. And of course, the basis for our evaluation of the response to fluid remains the fluid challenge, where we look at an improvement in tissue perfusion and the risk of edema formation. This is based on the Frank-Starling relationship. Every patient is represented by one of these dots and is on one of these lines. So we need to give a bit of fluids and see if cardiac output increases or not. And if we want to assess the risk, we want to have a central venous pressure measurement. Oh, that's invasive! I know, but the central venous catheter can also help to have access to the central venous oxygen saturation, SVO2. It can also help to give fluids quickly. It can also help to give vasopressors safely. Oh, vasopressors can be given by an intravenous peripheral line. Yeah. But one single complication would be terrible. So, the fluid challenge is not the fluid loading, right? It is a technique in which we give a bit of fluids and we assess the patient's response. Sometimes people do it over a too long period of time. I'll try to give fluid for half an hour. That's much too long, because so many things could happen in half an hour. And in the emergency department, the patient may have to go to the X-ray for a CT scan, and we lose that information. So it's 5-10 minutes. In the operating room, it will be 1 minute, because so many things happen in the operating room. But if we return to the emergency department, the studies have shown that giving about 250 cc's in 5-10 minutes is sufficient. So give 200 cc's in 5-10 minutes. If the patient seems to respond, seems to benefit, you repeat it. And during these 5-10 minutes, if you want to assess the patient's response, you should not do anything. Don't touch the patient for 5-10 minutes. What shall we check? Heart rate? Well, maybe, but it's not perfect. The blood pressure? Not really, because the patients in septic shock may respond to fluids by an increase in cardiac output, and yet the blood pressure may not increase much because there is decreased vascular tone. We showed it many years ago. So optimally, we should actually assess cardiac output and see if cardiac output increases with fluids or not. We could use the technique we like. We just reviewed it for critical care medicine, if you like to look at the various systems available. But again, if you are good in echo, you could just use the velocity time integral to reflect cardiac output, stroke volume, and thus cardiac output. Today, it can even be done automatically. There are some softwares available now that can measure it for you. So that's the fluid challenge technique. You can go to that publication if you want to see the graph. It's quite easy, but we need to pay attention to some simple elements. And the most important one is that if the patient does not benefit, we stop giving fluids. The fluid challenge does not encourage to give more fluids. It does encourage to stop giving fluids when the patient does not benefit. Internal fluid challenge can be obtained by passive leg raising, but it's a bit more difficult to do actually, because the changes in cardiac output will be very transient and very mild. If you like, we did a neat chat, you can find it on the internet, with Dr. Monet, who is a world expert in this, asking him, how do you do this? But to go back to simple things, ChatGPT says, The goal of fluid resuscitation in sepsis is to restore perfusion to vital organs and tissues and to prevent organ failure. The appropriate amount of fluids will depend on the individual needs of the person with sepsis and should be determined by a healthcare provider. It is important to monitor the person's vital signs and response to treatment. And it's only then, when the patient is stabilized, that we can think at the stabilization phase and the de-escalation phase with diuretics, with ultrafiltration, if the patient does not have urine output. If you like, we just reviewed it in this paper, the various phases: salvage, optimization, stabilization, de-escalation. Very important to look at which phase we are in. Very briefly, there was a discussion until recently about the type of fluids, the amount of chloride we could put in the IV fluid. That was a question which was overstated, because we know that saline solutions include a lot of chloride. We know that during surgery, the chloride levels will increase after 2 hours if you give only saline. We know balanced solutions include other electrolytes than chloride, and hyperchloremia cannot be good. Any abnormality is associated with a worse outcome. It has been known for many years that hyperchloremia is not good for the kidneys. So I don't know why we need to do prospective randomized trials with saline versus... If there is hyperchloremia, there is more renal dysfunction. But we knew it from the beginning. So we said it's not even ethical to allow hyperchloremia to develop in some patients. Oh, so we should no longer use saline solutions? I didn't say that. I said we need to monitor chloride. Look at that, 112 as a mean value in these prospective randomized controlled trials. More major adverse kidney events. This was expected. So is it so difficult to look at chloride levels? And if they are, let's say, above 110, if it's a neurological patient, we should not give Ringer's lactate solutions, which are somewhat hypotonic, very bad for the damaged brain. But otherwise, Ringer's lactate solution would be a valuable one. And there may be a place for some albumin as well, some colloids, when the patient has lots of edema associated with hypoalbuminemia. But let's move on. Let's emphasize that severe hypotension must be treated right away, because it's too bad to be severely hypotensive. So don't wait for the response to fluids. If hypotension is severe, we need to give vasopressors right away. Studies of large databases have shown that severe hypotension for 1 hour or 2 may be very harmful for the patient. In this, there have been several studies on this, also on renal function. We could even perhaps propose the administration of vasopressors in the ambulance before getting to the hospital. So VIP, the 3 elements, must be managed concurrently. And we know noradrenaline is the first agent of choice. Adrenaline should not be a first agent. This is a small study, quite old now, showing that the trend is going in the wrong direction. Mortality is somewhat going up when you go for adrenaline. And if you go at the target, we usually say that it's 65 as a mean value. But this is a mean value initially. The trials where they randomized patients for a higher or lower target, of course, showed no difference in mortality. But look at the targets, it was even 75 versus 85. Oh-ho. That's how it is. When we target the blood pressure, we tend to overshoot. And yet, in patients with chronic hypertension, 75 was not sufficient. So let's go to a higher mean arterial pressure, right? Well, some patients maybe. But then you have this other trial where they allowed in patients to be below 65, and there was no difference in mortality. So does blood pressure not matter? Of course it matters, but we need individualization. That's physiology, autoregulation of blood flow to the organs, well known. Now, the most recent recommendations of the Surviving Sepsis campaign rightly state we recommend an initial mean arterial pressure of 65. That's correct. But what thereafter? What should we do thereafter? And people drop the word initial. In our previous guidelines, we wrote, if initiated, vasopressor dosing should be titrated to an endpoint reflecting perfusion. And this sentence disappeared, unfortunately, in the most recent guidelines. So we said in this paper, wait a minute, we need to individualize this. We need to look at the patient. We cannot assume that one single blood pressure level will be good for all patients. Let's look at diuresis, consciousness, skin perfusion. That's what we call the noradrenaline challenge. With vasopressors, we need to be very careful about the risks of vasoconstriction. It's easy to increase blood pressure. We have a number of agents to do that. But the problem is when we increase vascular tone, cardiac output may go down. And that's actually the main reason why noradrenaline is our agent of choice. Because it has a little bit of inotropic effect. It can maintain cardiac output to some extent. There is a lesser risk of decrease in cardiac output. Because if there is a low blood flow, then vasoconstriction can become very harmful. The vasopressor therapy could harm. Maybe good to look at the diastolic blood pressure. If it's very low, maybe there is less risks than when the diastolic pressure is already high. And of course, we can look at peripheral perfusion. We can look at skin perfusion, because there are other options if the patient is vasoconstricted. We could look at it by the capillary refill time. I'm not sure we need to spend much time on this, but let's examine the extremities of the fingers. We may not need a particular device for this. In the past, we were measuring the toe temperature with Dr. Weil. Now, with our team, we look at laser Doppler to evaluate peripheral perfusion. The point is that if the patient is too vasoconstricted, it may be hypovolemia, it may be a poor myocardial function. We can look at it by echo. We can look at it by measurement of central venous oxygen saturation. Remember, in the emergency department, of Detroit in the US, Dr. Rivers showed that when the SCVO2 is low, we could give more fluid, transfusion, or dobutamine. And this action may result in lower mortality rate. 3 studies subsequently were negative. They could not confirm it, but the patients were already resuscitated. They didn't have a low SVO2. So the point is that when SVO2 is low, it could be good to do something else to increase oxygen delivery to the tissues. Fluid, dobutamine, perhaps a transfusion. We can even look at the veno-arterial PCO2 gap, but the time is running. I will skip these slides. You could read it. This is our paper in Chest showing that if the patient does not improve quickly, we could actually find valuable therapeutic interventions to increase flow. Patient says tachycardia, pacemaker. No, we cannot afford vasodilating agents in patients who are already vasodilated naturally. So it's either fluids or inotropic agents. That's the dobutamine challenge. We could give a little bit of dobutamine in addition to the noradrenaline to try to improve blood flow to the periphery, and this is quite safe in septic shock. We have known it for many, many years. Oh, dobutamine induces tachycardia. Yes, it does. Because any inotropic agent that we know will increase heart rate if it increases the myocardial contractility. Wait a minute. Tachycardia may be bad. Perhaps in some patients we should use beta blockade in septic shock. What do you think? Well, you could find this paper from Dr. Morelli and collaborators 10 years ago now with very surprising results. A reduction in mortality rate with beta-blocking agents. But the control group has a mortality rate of 80%. 80% in the control group. So we and others wrote letters saying, you know, no. Last week, in the latest issue of the JAMA, you can find this paper where they used the same approach and they had to stop because it was harmful. But wait a minute, they looked only at heart rate, nothing else? I actually went to the microphone and I said, you know, this is unacceptable. Okay, it's published, okay, it's randomized, controlled. But when you have a tachycardia in your patient, you need to think at why this heart rate is fast. And if it's because the stroke volume is too low, because there is hypovolemia, cardiac pump problem, or maybe an obstruction, giving a beta-blocking agent may be very, very harmful. It's only when you have a supranormal cardiac output that you could do that. That's individualized medicine. So that's something of importance. We spoke about transfusions earlier on, and there may be a place for blood transfusions in patients who do not improve, but my time is really, now I'm reaching the end. Lactate levels in the emergency department, yes, of course. It's not a sepsis marker, no. It's a marker of altered tissue perfusion. Any form of shock will be associated with a high lactate level, typically above 2 milliequivalents per liter. And we can now measure it everywhere in the world. If you cannot do it, go to your hospital manager and say that in Antalya they said we need to have a lactate analyzer. And we could repeat the measurements. After 1 hour, the changes in lactate levels are relatively slow. But the idea is that we would like to see the lactate levels going down with time, not going up. Can it guide therapy? Well, it depends what you mean by guide. It helps to tell us whether we are in the right direction or not. But that's all. We should not wait for the next lactate level to decide what to do. Lactate levels change slowly. I will skip the part on vasopressin, which is not another vasopressor agent. We don't know really when to use it, but it's hormone therapy. Vasopressin is a hormone, right? So there are some interesting effects, limiting edema formation, helping the kidney. So there are some arguments to give low doses of vasopressin early on in septic shock, early on. But we must make sure that cardiac output is normal or high. Once again, beware of vasoconstriction. So maybe if you are sure that cardiac output is not significantly reduced, you use small doses, especially if you are concerned about kidney function, especially if you are concerned about edema formation. Hopefully the doses are fixed. We should not really titrate the doses. Angiotensin II is also coming up. Maybe it will have some beneficial effects on the kidney, but it's very costly. It costs about 1,000 euros a day. So we need to have more evidence for this. Last minute, hydrocortisone. Should we give it already in the emergency department? Rarely. Only if shock is very, very severe. We have one study from Australia showing no improvement in survival, but we don't know much about the patients. Many patients were not in septic shock. We don't know the lactate levels, we don't know the degree of organ dysfunction. And we have a study from France showing that in patients who have severe septic shock with a high lactate level, multiple organ failure, yes, corticosteroids can decrease mortality. So if you put the two studies together, you can see a benefit in the sickest patients, in the patient with the most severe form of septic shock. That's where we are now. We should find some better biomarkers. Right now, it's only the severity. So at the end, fluids, vasopressors, inotropic agents if we fear that the cardiac function is altered. Let's look at skin perfusion, urine output, mental status, the three windows of acute circulatory failure, respecting the four phases: salvage, optimization, stabilization, and then de-escalation. And for this, it's quite a bit to do. Infection control, hemodynamic stabilization, modulation of the sepsis response. In trauma, we have a trauma team, right? With a trauma leader giving orders here and there. There is the captain giving orders. There are many things to be done. Insert catheters, call the surgeon, call the radiologist, etc. But in sepsis, it's the same thing. We also need the 5 tubes, the diagnostic techniques, the blood tests, microbiology, monitoring, noradrenaline, other agents, antibiotics. Yeah, antibiotics. Don't forget the antibiotics. Oh, there are so many things to be done. I agree. That's why we need sepsis team at 3 o'clock in the morning as well as at 11 in the morning. In our emergency rooms, we need to have teams taking care of these patients for whom time is essential, when every minute counts. It's the same team, perhaps, for sepsis and trauma and myocardial infarction. Okay, but we need to have these people ready 24 hours a day, thinking at these three parts of the sepsis management that must be conducted together. And that's how we can save our patients with this terrible problem of sepsis. Thank you very much.
Thank you so much, Mr. Vincent. And first of all, I want to say I want to revise my sepsis information after following this presentation. So maybe some of our friends needs to ask you some questions. Dear audience, could you please ask? Okay, could you please?
Dear Professor, thank you very much for this great and wonderful and excellent presentation. You explained and summarized the topic in a very short way, and you made me to love this topic. Thank you very much. I'm very grateful about it. My question is about that. I listened to you 10 years ago or 12 years ago. If I listened to you 20 years ago in 2020, perhaps, I may listen different thing. So it seems that in recent years, there are so many changes. My question is that, 20 years later, what kind of change do you expect to be done 20 years later? Thank you very much.
Ooh, thank you very much for this question, which is an excellent one, but it's another talk. If you give me another 40 minutes, I can discuss it. But, you know, I think that we would like to be less invasive, but at the same time, we want to be accurate. So at least for some years to come, we will continue to be invasive. The arterial catheter, the central venous catheter, will continue to use it for a while, but maybe not in 10 years or 15 years from now. Echocardiography will be automated, as I say it, with AI programs, with artificial intelligence programs. We will see the heart on the screen and the variables being displayed on the screen, and that will help us to treat the patient in a better way. We will have better methods to identify the microorganism more rapidly, and this will help to orient the antibiotic therapy from the very beginning. And even sepsis itself will be better identified by biomarkers. We already have the C-reactive protein, the CRP. We already have the procalcitonin, the PCT. I think what we will do is first to bring other biomarkers, but also to combine them so that we will have a more accurate recognition of sepsis in our patients. I believe that we will have a better understanding of the type of fluids to be given, in particular when to give albumin, when to give red blood cells. Because right now we are in an era where we say, no transfusion, no. But, you know, if the patient has alteration in perfusion, the cells need oxygen. And oxygen is provided by the red blood cells. You cannot change it. So that will be another development. And of course, there will be many developments in surgery, radiology, better antibiotics or newer antibiotics, etc. We will benefit from the progress made in other fields. And above all of this, artificial intelligence or augmented intelligence, AI, in any case, AI will help us to better identify the problem and better treat it. We will remain in charge. We will not be replaced by an AI system, but the AI system will provide a very effective help to the team. I'll stop here.
Thank you so much for this. Could you please bring the microphone here, the second line here.
Prabhat Nanekar from Amsterdam. Thank you very much for this inspiring talk. But I just wonder, most of the patient who comes with systemic infection does not end up at the ICU. They stay at the ED and go to normal wards. And in the Western world, at least, the sepsis is a disease of the elderly. They have no fever, they have hypothermia, they have no tachycardia, they have normal blood pressure, they have no low pulse rates and all that. This aggressive approach, do you think we should adopt our protocols to the elderly, because that's going to be the problem? Sepsis is a disease of the elderly, I think, and it will get more and more and more. I just wonder what you think about that.
Yeah, it's a very important question, absolutely. But it leads us into the ethics, because what you imply, to some degree at least, is that we may have some therapeutic limitations in some of these elderly patients, so that we don't want to admit them in the ICU. But the treatment may be much less effective on the ward than in the intensive care unit. You know, if you want to do everything you can for the patient, you need to admit this patient in the ICU. And there is always beds available in an ICU, always. You may have to make difficult choices, as we had during COVID-19. We may have to say, no, I will not take this patient, but I will take that patient, what they call triage. It's a terrible word, but that's what it is. So we could have triage, but if we want to treat a patient with sepsis effectively, we need to bring this patient in the ICU. Now, there are some patients for whom we say, okay, we'll just give antibiotics and that's it. Or at the middle, we could have patients for whom we do what we call the ICU test. We are the ones who proposed the ICU test about 20 years ago. That's a test in which we admit the patient in the ICU for a limited period of time, and we appreciate how the patient will respond to full therapy. But we decide in advance, and this is in accord with the relatives, that after 3 days we will reevaluate. And if the patient is not improving after 3 days, then we will decide to give up. So this kind of trials could represent a way to admit a patient in the ICU when we are not so sure that this will be very beneficial for the patient. Again, we could continue and discuss it for much longer, but our time, I suppose, is limited.
Okay, I know and I believe there are more questions about that subject, because it is very important, and our guest is very strong in the subject. So please continue to ask the questions in break time. Now we have second speaker instead of you. Please don't. There's no stage over there. So we have. Now, a reflection on 20 years of practice. David Kerr will tell us about that subject. Please go ahead.
Okay, everyone take a breath in I'm not going to teach you anything clinical. That was clinical. This is not clinical. I want to start with just asking a question. How many people in the room have been practicing for less than 5 years? Put up your hand. You got to raise your hands high and tall. How many have been practicing for less than 10 years? How many of you have been practicing between 10 and 20 years? 20 and 30 years. The people in the front are starting to get embarrassed. 30 and 40 years. Has anyone here been practicing more than 40 years? Okay, so this is 20 years of my practice. This is year 20 for me, and I designed this talk to tell you what I've learned. The stories, the patients that have shaped my career, and this is not clinical. It's just what I've learned. And when I started working, I work in a large academic center in Toronto, Canada. Things were really easy. We didn't see patients in hallways. We used to get sleep on overnight shifts. And now we see patients in waiting rooms. And things have changed so much in the last 20 years. And when I was starting, about 10 years ago, I approached one of my colleagues and I said, Joel, things are getting bad. And he looked at me, he was older, he's probably about 80 years old now, and he said, David, until I'm dead, you're screwed. You're gonna need to take care of this generation of baby boomers. And 10 years ago, Joel couldn't have been more correct. And I think whether you practice in Turkey, in India, in Singapore, in Canada, we are seeing this effect now. So what I want to do is to take you through my first shift to my last shift and to tell you what I've learned. So I remember my first shift. Does everyone remember their first time doing a night shift alone? Like totally. And I remember that shift so clearly because I was waiting for that last person to leave and thinking about how many hours I would be stuck by myself and hoping nothing bad would happen. And what was amazing was I was killing it. I was doing so well. It's 7 in the morning and my shift ends at 8 and there's no one to be seen. There's no one to hand over. And I have to say, I was feeling really good about myself. I knew I was good, I just didn't realize how good I was. And at 7:15, a patient was wheeled in, and I remember thinking to myself, crap, the board's not perfect, but you know, he's not going to be registered for till 7:30, 7:40. I don't really need to do anything. I can leave it for the morning guy. I said to the nurse, as I was just cleaning up some stuff, what's he here anyways? Is there anything wrong? Oh no, he was here last week with DKA. He's been vomiting. He's back. Don't worry about it. And I looked at him from the distance. I had no intention of seeing him. I was handing over a near perfect board. And then I get called to his room stat. Oh, crap, I don't really want to see another patient. I'm super tired. It's now 7:40. My shift ends at 8. And I go to see him, and he's unconscious. He's 21 years old. He's a type 1 diabetic. So what do you think? You have a 21-year-old who's difficult to rouse. What do you think? So I start to think maybe he's hypoglycemic. I can fix this in 20 minutes. What's his sugar? Oh, we don't have a sugar yet. Okay, well, do his sugar. Okay, I just sit there, just, you know, twiddling my thumbs, point of care sugar, and it says high. And I said, crap. And I said, check his pulse, and he's PA. So it's 2003. And I start CPR. And CPR in 2003 is different. I gave him all these amazing drugs. I got him into PA, and then he went into VF. I gave him amiodarone, I gave him lidocaine, I gave him magnesium, I gave him beryllium. Anyone remember that drug? I gave him procainamide. I put in a central line, a triple lumen catheter, because that's what we were doing. I intubated him. I put in an art line. I gave him some bicarb. I gave him some insulin. And 40 minutes later, he's still got no pulse. And I get his gas back. And he's hyperkalemic. And I give him some calcium, and I pronounced him dead. And I remember after that case, I felt gutted. How could I have not given calcium right out the gate? And I spoke to my friends, and they said, oh, Dave, you gave him beryllium, amiodarone, lidocaine, you intubated him, you did everything right. But in my mind, and I know what this guy looks like today, I know there's something I needed to do that I didn't do. And I learned that day two things. I learned that when I started practice, I used to be afraid of what walked in the door that would scare me. Throughout my journey, I've learned that the more important thing to get comfortable with is to get comfortable with those who walk out the door and not be afraid of them. But I also learned the most important lesson that day, and it's why I'm here today. If you want to save lives in the emergency department, teach. You don't save lives sewing up a drunk on a Saturday night. You save lives by teaching things that you missed, because you know others will go down that same pathway. And this was the first thing for me that had inspired me as an academic to want to make a difference, to say, you know what? I only used to think about calcium for dialysis patients. Maybe I should be more broad in who I give it to in an arrest state. The other thing I've learned in my 20 years is to listen. The average emergency physician will let a patient speak for 7 seconds before interrupting them. Are you average? I'm certainly below average. I'm more like a 3-second. And when the person starts with, in 1983, I developed this pain, and you're just like, just stop talking. We don't listen to people. And that's a challenge, and I want to talk to you about the art of listening. About 10 years ago, a 65-year-old man was brought into the emergency department by his 2 sons who were 18 years old, and they carried him to the waiting room from the car into a wheelchair, unresponsive. This was the family who didn't call an ambulance, despite the fact that their dad was GCS3 and unresponsive. These are rare birds. And here was his story. On Christmas Day, he had had a cardiac arrest. He suffered from hypoxic brain injury, and 3 months later, he went home. This was his first night at home. And he went to bed with his wife. At 7 in the morning, he was still sleeping. She went to make some tea. At 10 in the morning, she's still sleeping. At noon, he's still sleeping, and she starts to think, crap, like, I guess he's catching up for the 3 months of sleep he missed while in the hospital. At 2 o'clock, she decides, okay, he's been sleeping for 17 hours. I should go check on him. She can't wake him up. Imagine what she's been through. It's her first night with her husband in 3 months. And she brings him to our hospital. He comes to the triage, and I get called to see him stat by the best nurse in our hospital. You all know who she is, or he is, because you know when they're on how quickly you will run when they ask you to see someone. And I go see this person. I don't really know what's up, so I order a confusogram. You know what a confusogram is? Every single test you can think of. CBC, lights, creatinine, tox screen, thyroid, livers, urine, gas, lactate, CT head, extended lights, thyroid. It's all normal. The family doesn't want anything done. And the nurse, Ella, she walks over to me and she says, "What's wrong with the patient?" "Ella, I have no idea. All his tests are normal. The family doesn't want anything done." She's quiet for a second, and then she looks at me and she says, "You know what's wrong with him? He's in status." I said, "What?" "He's in status. Why don't you give him something?" I said, "But he's not shaking. What do you mean he's in status?" She said, "Just give him something." "Why do you think he's in status?" "Well, when I triaged him, he was doing these funny things with his lips." "You have nothing to lose. Give him some midazolam." "Okay, you win, Ella. What am I going to say? Give him some midazolam. Here, give him 3 milligrams and 2 milligrams and, you know, keep her happy." So she gives 2 milligrams of midazolam. About 3 minutes later, she grabs my shirt and she says, "I want you to meet Mr. Johnston." He looks at me and he says, "Hello, doctor." And he was in non-convulsive status epilepticus. I had never seen it. I had never diagnosed it, and it's a big problem in people who've had hypoxic brain injury, of comatose patients in the ICU. This is incredibly common. But you need to listen to others. And listening to Ella was what is the reason that that guy was talking right away. And giving midazolam to patients right before I'm going to give them that intubation has bought me some people from avoiding plastic. Those people on neuroleptics, on antidepressants, history of seizures. Sometimes when I'm about to intubate them because their GCS is 3, I give them that midaz right before, and I wait a minute or two just to see if their LOC is from seizures that are non-convulsive. Do nurses ever ask you to come see them as a patient or to look after their family? Has that ever happened to you? The nurses in the department will say, "Hey, Dave, can you come see my loved one?" What I've learned in all these years of practice is the biggest compliment you can receive as a physician is when a nurse or colleague asks you to look after the person they love most. Don't get annoyed. Realize that this is the ultimate form of flattery when they want you to care for them. Every day we wake up, we have an opportunity to do some good, but there's so much bad that you have to navigate to get to the good. And this is Captain Chelsea Sullenberger, who landed his US Airways flight on the Hudson River in New York City. Sometimes we see a lot of crap, but there's inspiration in all the patients we see. Joe was a guy who came to our Emerge about 250 nights a year. Every single night, the chief complaint was the same: intoxication. I was doing a night shift about 10 years ago. I've seen Joe maybe 60 times in my career. And he walks in, his chief complaint, it was a little different. He had fallen and can't get up. Okay, it's 4 in the morning. He's not gonna go home till the morning anyways. I go see Joe, I heard you fell, you can't get up. Yeah, doctor, I can't feel my legs. So I go and I say, can you feel that? Yeah. Can you feel that? Yeah. Can you feel that? Yeah. Okay, well listen, why don't you sober up and I'll come see you in the morning. And Joe said to me, doctor, I've been drunk every day of my life for the last 30 years. I'm not drunk. Oh, that's interesting. And Joe taught me an important lesson, that sometimes the neurological exam is not just a CT of the head. That my neuro exam was touch his legs, do a CT, he's fine. That sometimes you actually have to examine people. And I said, you can't feel your legs, Joe? He couldn't feel touch. So I took my fingers, do you feel that? So he could feel touch. So I started with pain. No pain to about the belly button. So then I went to temperature, and he had a sensory level of pain and temperature loss from T10 down. And Joe, who had been drunk in our merge for 35 years, 60 nights a year, had an anterior cord syndrome. Just because I listened to someone, and just because I decided that sometimes you actually have to do an exam. It was very humbling. This past year, I picked up a chart. The chart was the next to be seen. 30-year-old female with a headache and 36 weeks pregnant. I'm going to say it again. 35-year-old female, headache, 36 weeks pregnant. When you pick up that chart, how much are you hoping that the person beside you picked up that chart instead? That's a tough one, right? I was like, crap, what did I do wrong? So I go see this woman. My first thought, okay, hypertension in a 35-year-old in her third trimester. What are you thinking about? Shout it out. Preeclampsia. Her pressure's 100/60. I thought maybe we could get it higher and then I could refer her to OB, but it wasn't high. And I was like, crap. So I ordered all the preeclampsia blood work. I went to talk to her. I was hoping that her pressure would be higher, because then I could just say she has preeclampsia, but it wasn't. All her blood work was normal. I do a real neuro exam because I sure as heck don't want to CT this woman. There's nothing to find. So I said to her, why are you here? You're 38 weeks pregnant, 36 weeks. Have you had preeclampsia? No. Are you sure you haven't had preeclampsia? No. So I said to her a question that sometimes I ask people, and sometimes it's snarky, but sometimes it's helpful. Do you come to hospitals often? She paused, and she had like a 2 out of 10 headache, occipital. And her husband says to me, doctor, can I say something? So polite. Polite people always have bad things happen to them. Of course. When my wife had an appendicitis, it perforated for 4 days before she came to the hospital. And you know how much that made me nervous. So I did a CT venogram and diagnosed a sagittal vein thrombosis that went all the way to her IVC. Sometimes you just have to ask people. She had a 2 out of 10 headache that got better with Tylenol. And the craziest thing about this case, and I don't know if you feel this way, but I feel that sometimes emergency medicine is what I ate for breakfast. Some days, for some reason, you connect with a patient and you understand them, or you see them and you can figure out that there may be something wrong, and you know in your mind that tomorrow you may not have figured that out. And that's the most humbling thing and frightening thing about our job, is I was so close to sending this woman home. I swear to God, 2 out of 10 headache, better with Tylenol, wanting to go home, but just something. And it's frightening because tomorrow I could have missed that. Nancy was a 74-year-old female. It was a Friday afternoon at 4 o'clock. I was just starting my shift. And the chief complaint said, tired and weak for 4 months, requesting a 4th opinion. Again, who's happy that they got stuck picking up that chart? Fourth opinion. You can see the sarcasm in the nurse who wrote it from triage. So I pick it up. I have to go to the waiting room. Mrs. Smith? Mrs. Smith? So I start to think to myself, she must have left. The waits were long. I'm perfect. This is great. But in the distance, I see movement of an old person who looks like Mrs. Smith. I'm kind of hoping it's not her, but she's moving towards me. Crap. Mrs. Smith, come on. So we have a button on the wall that opens the door. I must have hit that button about 10 times before Mrs. Smith made it through the door. I swear I could have seen like 4 other patients. Eventually she comes here. After I've opened the door for her 10 times, I figure I'm going to bring her to the closest room possible so I can get rid of her short, because it took a long time, and this is a fourth opinion. So I go to talk to her and I say, you've been weak and you're sore all over and it's been 4 months? Yeah. And she can tell that I don't really care. Unfortunately, I'm grumpy. The rust and the cynicism has kind of acquired in my tenure. So I ask her all these questions. You saw this doctor and that doctor and this doctor and this person, and how can I help? So then I turn and I say to her, are you depressed? She pauses and she says to me, what year were you born? Okay, think about that. How are you feeling when she says that? Well, I get all defensive. Well, I don't think my birth has anything to do with you, so I'm not going to tell you my birth. Well, she says, I'm going to guess you're born in the 70s. Before you were born, I played tennis for Canada in Wimbledon. Oh, this is not her, that's Billie Jean King. I said, oh. She goes, and I look like looking at you, I'm in a lot better physical shape than you. I play tennis 2 sets, sometimes 3, every single day, 7 days a week, and all I want to do is be able to play tennis again. So you asked me if I'm depressed? I'm used to playing 4 sets of tennis a day, and now I can't even get out of bed in the morning. Of course I'm depressed. Does anyone know what's wrong with Mrs. Smith? I looked at her and I said, I'm going to order 1 blood test. And this blood test is going to change your life. Anyone? I can't hear well, but Mrs. Smith had an ESR of 120, and she had polymyalgia rheumatica. Now, this isn't the most exciting thing in your textbook. In fact, no one has ever in the history of a conference been invited to speak about PMR. But I'm going to tell you something. PMR, next to like a pulled elbow, is the best diagnosis you will make. There is no other diagnosis that will cause gratification. Now, every year, you know, my wife, she's an internal medicine specialist, and every year around the holidays, she gets chocolates, she gets champagne, she gets scarves, she gets tomato sauce. I get nothing. You get nothing. But Mrs. Smith used to buy me a box of chocolates from a really kind of borderline chocolate store in Toronto that your grandmother would have given you chocolates from when you were a little boy or a little girl. And every year, for 10 years, Mrs. Smith bought me chocolates at Christmas. Never saw her again. The only person who's ever bought me anything. About 4 years ago, the chocolates stopped. What's on your differential of chocolate stopped? She's dead. Nah, it happens. We're all gonna die. What can I do? During COVID, I went to see an old man. I walked in the room. He was there with his partner. Everyone's wearing masks and gowns and all that. And a woman says, hello, Dr. Carr, do you remember me? Again, a question I hate getting in the emergency department. Do you remember me? You know, with the mask and the gown, it's really hard to tell. She said, I played tennis in Wimbledon. I said, your ESR was 120. I've never forgot about you. Where the hell are my chocolates? I thought you were dead. And last year, the chocolates started coming back. Billy Mallon said, if you became an ER doc because you love thank yous, boy did you fuck up. Because your best work does not know who you are. And in emergency medicine, it's very thankless what we do. It's very thankless. You make the diagnosis of an aortic dissection, the patient is going to think the surgeon is God. But you're God. And you have to realize that you need to celebrate yourself in this job. When you make that diagnosis, go home, have a nice meal, buy yourself something special, do something fun that you wouldn't be, because no one celebrates you. Celebrate yourself. It's the only way to succeed and to survive in this business. So my interest clinically is hunting for zebras. I have spent my career looking for diagnoses that other people struggle to make. And people will say, Dave, you see all the cool cases. Okay? I want to tell you a story. A young woman comes in to me. The chief complaint is rash with their period. So you know I'm an emergency doctor, so rash during your period, I'm thinking she's got toxic shock, really cool, really excited to see her. But she says to me, yeah, I get this with my period every year for 18 months. Every month. So I said, well, you can't get toxic shock every month. You're no longer exciting to me. Every month you get a rash. Yeah. Can I see the rash? Oh, I don't have it anymore, doctor. So why are you here? Well, you know, every month for 18 months, I get a rash right before my period, and then I get my period and it goes away. And you don't have the rash now? Do you have a picture of it? No. But you're here anyways and you have no rash, just so I understand. Yeah. Okay. Do you care about this woman? Do you find her interesting? I see an honest reaction, which is a lot of us couldn't care less. She has no rash, her vitals are normal. This has been going on for almost 2 years. Why are you here? Now, Michael DeBakey would say, no physician can diagnose a condition she never thinks about. DeBakey never had the internet. So what I did, because I thought she was interesting, is I go to Google and I type in rash that occurs before menstruation. And it shows...
Mr. David, you have 2 more.
I'm going to go a bit longer.
Okay.
It shows that she has something called autoimmune progesterone dermatitis. Have any of you heard of this? No. So I walk in the room. I said, oh, sorry about that. You have classic APD. It's classic. Once you see it, you'll never miss it. Your options are either we take out your ovaries, but that seems drastic, or maybe you see your family doctor and go on the birth control pill. But it's classic. What the point of this story is if you want a fruitful academic career, you must be curious. If you're not curious, then you become average. You don't diagnose zebras. I had no idea what this condition was. I may never see it again. But by typing 4 words on Google, I was 100% confident I made that diagnosis. Wild. I leave you with one final case. This happened this summer. We had a lot of viral illnesses, and I got called to see an 8-year-old boy. He was wearing Spider-Man pajamas, and it was a febrile seizure. Is anyone nervous to see a febrile seizure? We got this. We see this pretty often. Temperature was 38.5. Apparently hasn't been well for 3 or 4 days. Parents brought him into the recess room, or to the room. He had had a seizure with EMS and another seizure. So I went to see him, getting a little bit of the story from the paramedics, getting a little bit of a story from the family, and all of a sudden, he has a cardiac arrest. I've run a lot of arrests in my career, but I can count in one hand, and not even all of it, the number of arrests I've run in children. And I can't count any of them that I've seen talking to me who've arrested. My brain was like mush. There are all these formulas you knew for ET tubes and chest tubes and medications. My brain was nowhere. I pulled out this Breslow tape and I ran this arrest. And, you know, with adults, we take so much pride. We don't ask for help in a cardiac arrest because they're kind of supposed to die if they're 90 and have a cardiac arrest. But the pediatrician came down. I was running this arrest, and she said, why don't we call the intensive care pediatrics at the other hospital? Because I didn't have pediatric ICU at my hospital. And they walked me through that arrest. And I did everything I could. And we did everything we could. And I knew where this was going. And I looked at the wall for something that I've done so many times in my career, and the parents were in the room, and I couldn't say the time of death. I couldn't say that number, and I still can't say that number. I didn't know what to say with these parents of this 8-year-old here. So I just kind of said, you know, I didn't say the number. I just said, okay, we can stop. I didn't know what to do. And then, you know, you haven't seen a patient for an hour and a half. Someone comes to you and says, I've had back pain I've been here for 9 hours and I've had back pain for 2 years, and somehow you have to smile and you have to pretend that that didn't affect you. And then a nurse says to you, Dave, our nurses are really upset about this situation. Do you think you could do a debrief? And it's as if we're supposed to be immune to this. Because we're doctors, we're not supposed to be affected by an 8-year-old boy who dies. But the nurses are. And I said, I'm the same as you. Hug your child. I don't know what else to say. Everyone did well. Life is very short. It's very tragic. You will never forget this kid. I can think about every kid I've lost. I know all their faces. It's just what we do. And how do we get through 20 years, 40 years? Is you need to have a team of support. Sarah Gray, who's the one who is in the front, came up with this concept of having failure friends. You need to know people in your group that you can call when life's crappy. And you might need a failure friend for your marriage. You might need a failure friend for your divorce, for raising children. I have so many failure friends. And you need a failure friend for when that patient didn't turn out the way you wanted to, and you feel gutted and you feel crap. How many of you have a mentor? How many of you are a mentor? Good. These are my 2 mentors. This year, they both retired. I feel like an orphan. I've lost the 2 people. And I remember saying to Anil once, I said to him, how can I thank you for what you've done to help my career? You know, I was trying to see, does he drink? Does he like chocolates? Does he like golf? And he said to me, David, one day you will be in the same situation as me. And what I would ask is you give back to that resident, to that staff, and then you will pay me back. Pay it forward. We've all had wonderful mentors that have pushed us forward. The greatest compliment to them is to emulate them and to give back to those who are the future of your profession in your country. So what can I say to wrap up this unbelievable conference and this unbelievable day at WASM? If you want to save lives, teach. You learn things at conferences, bring them home. Teach to your environment, you will make a difference. You have to learn to listen. We have 2 ears and 1 mouth, which means we're supposed to listen twice as much as we talk. Listen to patients. Probably more importantly, listen to nurses. Be curious. If you want to be an average doc, you're already there. If you want to be a great doc, be curious and push the envelope. And if you're not a mentor, seek mentorship and be a mentor. And thank you very much for your time.
Thank you so much, Mr. Kerr. And they were, all the slides almost, were very nice reflections about life.
It looks like there's a big party tonight, a big gala. Right here, 2015. What's the dress code, Bashar? Do we have to dress up nice? A tuxedo? Everyone come celebrate tonight, 10:15, 8:15, and we'll see you all later.
intercontinental trauma drill in December between Singapore and US. We'll tell you the results of the trauma drill, which will lay the foundation for our paper. So we are going to do the experiment of trauma alert and see where we fell off course, and then we will start building the evidence, and we plan to, before the next meeting, have the trauma alert published out. It will be published at the same time in two journals, so Eurasian Journal of Emergency Medicine, which is now a WASM journal, it will be going to PubMed next year, and our Journal of Emergency Trauma and Shock will publish those papers. We'll ask JTEC whether they would publish it, so the more the journals publish it simultaneously, the more it will look nice. So JTEC can also consider this is the Qatar Emergency Trauma and Acute Care Journal. So that's where we are right now for collaborative work. So I commend Dr. Fatima. Fatima is coming back to us after a couple of years, and Dr. Gacy.
One thing you might want to think about, Sasha, is just a similar protocol for cardiac arrest and trauma, because
that
work
is
on that a bit. You know, you see the single car MVC VF into a tree, and the trauma surgeons and the emergency physicians need to work closely with that, especially when it turns out to be a setting or something.
So we call it cardiac arrest and trauma survival, CATS.
Cat trauma.
Yeah, I think that will be it. Yeah, I think it will be good. So we need that. So trauma is being done by Dr. Fatima. If Dr. Ayman would like to take cat trauma, then we can work. Yeah, so we'll have to do a sim drill. So we'll plan that drill also. And the way we'll do this paper will be unique. Sal, if you are listening, the way the paper will be done is first will be simulation. which is a unique way of creating evidence and consensus, which has never been done. So this was an idea which was between the experts. Is they are not going to look at data, they are going to do real-time sim and then develop a consensus, which is very unique in the world of innovation. So we will look at the challenges which happened in the sim drills, and then we will find the answers to those questions and write a consensus framework document, which is more legitimate for real-time patient care, not based on published data, but on real-time data, and then resolve the challenges. It will be unique. So thank you. We'll go on to Dr. Alvi, who will update us on TopForm, and which also coincides with Pia Daniel presenting the first Vasan fellowship, and so then we go to fellowship training.
Thank you, Professor. Just want to confirm the TopForm for next year, 2024 in Kuala Lumpur, and it's going to be tentatively from 23rd to 24th, and it's going to be Kuala Lumpur, or we may even go to the Langkawi Island as another side island. So it's subject to about convenience, notifications, and everything. We will book on my team. And second thing is we also TopForm has gone to Nepal. This is the second year. TopForm in Wasan is in Nepal. So we are collaborating with Nepal now. We're also going to be collaborating with Indonesia as TopForm in Malaysia. So TopForm with Wasan and it's going to ASEAN partnership. And the next year's program will be a collaboration between all ASEAN partners, and they will be it's going to be more unique and more of the EMT teams will come in, and we may test the search and rescue simulation, and that is what we have to do. And we need it's going to be a Ministry of Health as well as the government and private university partnership, and there will be a lot of the Malaysian Red Crescent Society will be coming in. So we hope for your support and your commitment and your participation. We look forward to that. Thank you.
So Alvi has done a fantastic work of branding TopForm. So TopForm will, the national TopForm Global Vasan TopForm always happens once a year in the early rainy season, so in June, July. It will always happen in Malaysia, so if people want to participate, they can. But we are also conducting sessions to build the preparedness in Indonesia, in Nepal. We are going to come up with a Turkish version soon, so that we can offer it in Turkey, because it's uniquely one of the biggest Vasan's initiative is to bridge the linguistic barrier. So we are going to work on the linguistic barrier. Dr. Mizobata could not come because of his, he was not feeling well, but Dr. Mizobata is also going to work with us, and we have some presence in Korea through Dr. Salvatore. So we are going to bridge the barrier of linguistic divide when it comes to research, education and patient care. That should be a very big part of Vasan's agenda, is that we have to reach out to our colleagues in Africa which speak different languages. Turkey, we have already reached out, Japan, Korea, China, where they speak different, Russia, we speak different languages, but we need to be able to bridge research and take them to a certain level where there could be learning and collaboration. So that's what TopForm is doing. We are helping Nepal, we are supporting Nepal in fact. We must commend the leadership of the women leaders of Nepal who have taken this leadership to establish emergency medicine. They are trying to establish the board there. They are trying to build science in Nepal, and that's a very big achievement. I also want to inform the board that the Female World Women Leaders Conclave was a blockbuster event today, and Dr. Pia Daniels has informed me that they are going ahead with the Female Leadership Academy for Medical Excellence, will be established at the WASEP. So we have two new alliances coming up in WASEP, which will be the two new pillars, which will be WASEP, which we will announce. So the Female Leadership Academy will be one of those pillars. There will be a wellness pillar. So from 4 we will be expanding to 6 pillars, and the 7th pillar, Dr. Althani Vansi confirmed of the critical illness and injury. So we are literally in our 10th year, we have doubled our pillars, and that is a very big achievement for the group when it comes to things. I would like to request the board, one thing is the agenda item is to think before the paper and start publishing more articles collaboratively with WASEP names. So So that is very, very important. That it has to be the World Academic Council statement on this meta-analysis or this joint studies and surveys. So that will be very important. So when the trauma study or the CAT study will be published, it will be a vast initiative. So things like this, try to come up with white papers, documents which can be published. We have access to journals. With his journal, with the EPAT journal touching PubMed very soon, and JTAX we are going to also support for their quest to PubMed. Once we go to PubMed, we will be having at least 25% of the publishing market under WASM, because we have up to, with IndusIM having about 15 journals in PubMed, and we have about 18 to 20 journals in our reach, which is a huge market for us to publish, and I think we should work on that. So that is the most important part. Now we go to the two agenda items which are unique. One is the WASM Disaster Fellowship, which is very kindly being given under the WASM name, and the WASM Collaborative Fellowship in Qatar for trauma critical care for nations where trauma critical care has to be built. So I will first give to Dr. Hassan Thani and the
Thank you. This actually fellowship, as you remember, we discussed it so many times. It's a mini fellowship. The plan was we currently have a full fellowship, which is actually 2 years, a critical care fellowship in trauma. But that's a different fellowship. This is a fully paid and sponsored fellowship. Whereas the mini fellowship is actually planned to have exposure to the trauma system from pre-hospital all the way to rehab. It's a 2-month fellowship, and we actually secure the financial support for it for a 12 candidate per year. We secure also the approval for accommodation. We stuck with the license. The license is an issue, and we try to see if we can get a license that allows observership rather than a full training. So we are negotiating with medical education for observership rather than full fellowship, and that's the hurdle that we're trying to come over. But the others are already aligned, the curriculum and everything is set for more than 2 years now. Unfortunately, it's just the licensing issues which is we're trying to solve it, and hopefully when it's solved, we're trying to medical education, then we should start soon.
So,
thank you.
Thank you, Doctor. So, Dr. Adani, once the fellowship is announced, we will work on the agreement that WASM, the conduit that WASM will publicize it on the website, and the selection will be jointly done to make this happen, because I think exposure to an American-style trauma system, which is so uniquely and Joint Commission approved, ACGMI approved, existing in Qatar, will be very big for Asia and Africa. I think that is very, very important, because we need the support also to develop emergency and trauma system in the whole of Africa. That is also a very big area of need right now, and a very big area of growth where we could make a difference. We have our partners, Dr. Joe Boni in Ghana, Dr. Boten, who could not get a visa to come to Turkey. They were trying to get a visa because they have to, there's a process, a paper visa. So we have our presence in Ethiopia, Kenya, and I am going to have a meeting with the Kenyan Health Minister soon, so we are going to have a presence there in a very big way. And I think that mini fellowships like this, and as when what PI is going to present is going to make a huge difference. So I think observer model also will work. Tomorrow, if it works out to be a clinical model, that also works. But we are just getting exposure to the research division led by Dr. Albania and seeing what you do and understanding the processes is very important. Clinical skills they can do in their country, but the process management, operations management is very, very important. Before I go to Dr. Qazi, I'll tell you, in my experience in our studies conducted across the world, we realized that the greatest problem to developing emergency medicine was the lack of understanding of operations management. Everybody knows how to manage a trauma, everybody knows how to treat a chest pain. They just didn't know that ER has something called, and trauma has something called operations management. There's something called as patient flow, there's something called as metrics, there's something called a movement. They just did not know. And it took me 18 years to realize that all our work on training them on clinical systems was a waste, because 90% of the world of non-emergency medicine and trauma does not understand how to operate a trauma center or operate an emergency department. You'll be shocked, Dr. Canlı. All this ATLS is of no use. It's of no use. They just don't know how to operate it. They just don't know how to run it. They don't know process management. They don't know metrics driven care. They don't know how to audit it. It's unique. And there are countries where they are doing color coding system. But that's only to get in. What do you do after the emergency and trauma resuscitation? How do you move those patients? How much do you CT scan? And that is a monumental failure for Dr. Lisa, you'll be shocked. It's a monumental failure that we did not recognize that the growth of emergency medicine was stagnant because zero operations management acceptability or training. So last 1 year, we have started training emergency physicians in India on operations management, how to run the department, what is the difference between policy, what is the difference between process, what is the difference between protocol. These are 3 different things, and there was no concept. If you ask any doctor in trauma or emergency medicine, what do you do for a motor vehicle accident? I'll change my name. The answer will be COVID, ATLS, temperature, pulse, blood pressure, respiration, primary service. I can ask you that. How are you going to, what is your policies on managing this trauma? What is the process you follow to manage this patient? And what are the protocols? So you will only know the protocols, but that is very different from the policy, that is very different from the process. And that was one of our greatest failures, which I humbly accept, is now we have quickly moved away to that, and now we are focusing on operations management. So that should be a part of the fellowship.
Thank you, Segar. Thank you, Lisa. Dr. Athani, I actually had 2 items to talk about. One, I'm talking about the emergent items. I think it's very important to read this. It's going to be a little bit of bomb in this meeting, so I will have to come back to it. There are some little questions. Dr. Athani, you just said it here. Limited amount of information I am hearing right now raises one concern and a lot of I can tell you from my work in Lebanon, one of the main issues that I've been working on over the years, and I finally now have a minister who's busy and wants to make a reform with limited resources versus others who are more worried with corruption and selling and buying and importing equipment and medications and commissions. So now we have a different minister. The minister we have is actually because he needs to train the GPs to become staffers, fully funded hospitals. So he's willing to actually work with me on reforming the system. I'm asked to reform includes many prongs, many elements, a handful of elements, and so many. But 2 main ones include the categorization of hospitals across all of the acute care facilities. Categorization based on trauma, critical care, and emergency capacity. Who has a blood bank? Is the blood bank really a blood bank, just a license? What is the total preparedness? Do we have surgeons who have the responsibility or are available to really take care of these unique needs? Are we going to listen to people now? This kind of system, along with the issue of residency review committee, is something I met with both 17s and both medical schools in Lebanon. And I met with the dean and the president of the region of physicians, and we are at the point where we would like to do that. So when I hear about the availability of a fellowship, I see opportunity. I see opportunity because I presume, and I don't know, but I presume that Qatar is a very good system. And I can tell you one of the things that came up in my meetings was the fact that who are we to go to another university and tell them the hospitals need are not at the level of being 1, 2, 3, 4, 5. So the discussion with our Saudi friend in the MEMC in Rhodes, with Dr. Majid Salam and others, was that potentially could, that's what there is a role for WASM and for Qatar, was to really have non-Lebanese come to Lebanon, and the Lebanese come to Saudi Arabia, and the Saudi, do this exchange where we have people
voting and deciding on the category of, on the credentialing of these categories. And I'm not talking about commission accreditation, I'm talking about really categorization based on capacity of preparedness. So you bring us a very good opportunity. And I think it is time to look at how we can combine this beyond Qatar, via WASA, with your help, and use these categories. Now, you mentioned the 2-month fellowship, that's my concern. Once we use the name fellowship for something, we have a law and did unintended consequences. Have we defined what the fellowship means, and are we putting the name of WASA next to the 2-month fellowship? 2 years. 2 years of mentioned we have two different types of fellowships. Should we use the same name for the public, or could we do better than that for this time? You mentioned the licensing issue. I can tell you that the licensing issue, I know that we can send people from Beirut to your fellowship. We have our board, we have eligibility, so I'm sure we can tell them in your fellowship. But the idea I want is, what do you need to come off things? I mean, so I just would like more information, and perhaps if it was a 2-3 year fellowship, I would understand. But the 2-month fellowship, what is your objective? Why would Hamad do that?
Thank you. It's a called actually mini fellowship. It's not the reason for that is actually bringing people who are qualified. It's not to enhance their training. It's only to actually go through the system. It's just, unfortunately, in our region, there's a fragmentation of the trauma system or emergency system. So we have EMS under different umbrella, we have emergency under different also organization or authority, and then we have rehab and in hospital different. We are lucky in Doha because it's a small country and 95% under the same umbrella which look after the whole service in the country. So ambulance service, hospital service, rehab, integration with the community is under the same manner. And that's actually give us the chance that we have to go through the whole system, the North American system, which is under the same umbrella. It's a national ambulance service, it's a national drone service, and it's a national rehab support. So all the things under the same umbrella. And so the one who will come for 2 months is not somebody going to know how to do registration. It's just to see how ambulance service work, how the National Command Center coordinate, the dispatch system in the country, and then how the trauma system in Hamad works, all the components of the trauma, and then the rehab center. And during that time, they also can go and do some research at the same time. So we have also a small national trauma database, which is actually we work with North American National Trauma Data Set, with the people also with American College, and it's the only center outside North America. Something this from 2011. So that's actually what's the benefit. I think that the one who's coming mature will have a chance to go through this without going to North America. That's the whole thing. But we can discuss also the application for the formal fellowship, which usually is very tough because most of the candidate is from within Hamad. It's too old, but it's very difficult.
Thank you. Yeah.
Before I went to Jefferson, I was at Penn, and they had an observership, and it was doctors from Sweden who came over, and I believe they stayed for 2 weeks, 2 months, and they were trauma surgeons in Sweden. They were coming over to sort of to simultaneously learn about how our systems work, what our patient flow is, how our helicopter transport system, and then also to observe and do simulation in penetrating trauma, because they saw so little penetrating trauma in Sweden at least 10 years ago. I think that's changed a little bit. So it's just something to think about. Bill Schwab or John Pryor, I'm sure will
So I'm the fellowship director for the Disaster Medicine Fellowship at SUNY Downstate Hospital in Brooklyn. And what we did is I adapted the fellowship, the one-year program, and initially really designed for emergency medicine physicians, but we've actually, the director of our PICU has done the fellowship, so we broadened it to other specialties. And we adapted it so it could be remote. So essentially the exact same curriculum that the fellows who come train with me in person, we adapted it so it could be done remotely. To give you an example of how it's worked, we tested it out about 2 years ago. So I had a fellow who was a doctor in my facility, an ER graduate. And then I had Dr. Giovanni, who was an ER attending in Ghana. And then I had a critical care doctor in India. And so the three of them were doing this fellowship at the same time, following the same curriculum. And so the beauty of doing it this way is that every sort of assignment they would do would be tailored towards their facility. So for instance, when we were on the block of disasters, each of them would have to review the plans or policies for their facility, or if they didn't have one, and create them. And then they would have to develop a training, and they would have to train at least 50 people in their facility. And through that block, we would meet once a month, and each fellow would then present sort of what their institution was doing. So not only were the fellows learning the knowledge, but the institutions they worked for were benefiting, were getting a new plan, were getting staff trained, and they were learning from each other and seeing, okay, what's the difference between the policies in New York, in Ghana, and India. And then as part of the fellowship, it's always research, some sort of research abstract, paper, and I gave the option of actually if they wanted to do any collaboration. And so each of them did their own academic project, but then we started to look at creating databases that kind of included all three facilities, and sort of looking at doing joint IRBs between them. So it really, it's a one-year fellowship. The curriculum is accredited by my academic institution, SUNY. It's the exact same curriculum that the U.S. doctors get when they rotate with me, but it is always directly applicable in real time to the facility of the participant. And so that's the model that I've done so far. A newish model that I'm developing with Dr. Ali that hopefully will be starting in January is that Dr. Ali would like to give me 15 fellows that are going to be doing it remotely. There's going to be more diverse, so there'll be a mixture of ER physicians, some other types of physicians, maybe some other healthcare sectors, and public health, etc. Again, everyone will follow kind of the same topic month by month, but sort of approaching from their sector. And the beauty is that when we meet virtually once a month, we kind of review things. So by having sort of one country with multiple sectors, now they're going to be able to kind of see what other sectors are doing. And so after the sort of pilot version of this program, the idea is that in coming years, we'll have, again, multiple countries, again, everybody learning from each other, doing collaboration, trying to take their research projects and see how they can kind of collaborate that. So far we've tested it with just, one fellow from 3 different countries at the same time, worked really well. And then this next year, I'm testing it with 15 fellows from the same country, but from different kind of parts of the healthcare sector. We'll see how that goes, and then the goal is eventually to kind of do multiple countries, having multiple sectors from each country. We're learning from each other. We have joint journal clubs, and then ideally joint research projects.
So she will put up the curriculum to the circulate to the group, so the curriculum is there. Both the curriculums will be circulated, and then we will certify them. So hopefully by this year, now that we are all meeting in person, we should be able to get it done. We have already discussed about the ultrasound in the village, as you said. The other part which I want to inform the board is the mic. The part.
So for point of care ultrasound, so few things is we got first is networking of the focus leaders of each country. I think we need to identify from each country, and we can make a network within the WhatsApp which can be strong. Number 2 is developing a common agenda for working on education, training, and research on focus. At least the participating country, after we meet the networking of leaders, we can develop that. Third is the scope of practice, which is very important for doctors, nurses, and also how we can bring sonography to undergraduate medical education. These are the three things because there is availability across the world. If you see developed, if you US, they already brought it to undergraduate medical education when you're learning sonoanatomy, sonophysiology. When you go to clinics, they are learning point of care ultrasound. So these three things we also can adopt quickly, and work towards it. I think this can be done so that in future, because of smaller machines, it has become like a pocket, ultrasound. We can do adaptation of the technology to bring it in regular use. The next big point is doing regular networking, meeting of focus leaders virtually. We should do, this is a regular phenomenon, which we can do through our Boston, arm. And developing a fellow program, like we're discussing our fellowship in simulation, fellowship in disaster management. Similarly, fellowship in point of care ultrasound. This can be discussed and we can work towards it. This common agenda in developing a global fellowship on point of care ultrasound under the banner of WASEP. That is what I think Sarah also yesterday was talking about that. So this can be some of the agendas. So I think we did this in meeting again, on the last WASEP also. So I think the next immediate step will be, identifying within the country the focus leaders among you, and we can develop that over develop.
So we published a document under the leadership of Dr. Canlı on developing the focus in India through a framework. That framework is available on government. Developing the focus programs. Every pillar now will soon have a fellowship to offer in some country or the other. So disaster has one, critical illness, injury, patient care. Focus has to develop it. I've submitted an idea to Dr. Bowie. It should be able to implement it and be WHO certified. We're going to do it digitally. It's a unique model which I'm developing. We have a lot, by the way, we have a lot of digital strength. Because of IndusIM being a partner, IndusIM was very digitally driven. I try to explain to all the members as we open this discussion for a quick discussion on the research part. We are welcoming Poland group with Dr. Spack is joining us. He's one of we have two big scientists in the group who are mega-published, Prabhat, Salvatore, Dr. Spack with over 400 publications in literature. I think the research agenda has to be developed. I want the research leaders to understand, which in the last 5 years of me working with Prabhat, is that the level at which Hama, y'all work, Dr. Gayski work is here. The world is not yet there. So if we really want to do hardcore research, we have to make way for them to really understand what we really want of them. So small studies which are achievable, will have more power if they are done. I understand RCTs are the strength of everybody, which America can participate, but when it comes to countries like India, where IRB is a challenge, Malaysia, Turkey, where IRB is a challenge, we may have to go with 5 patients, 4 patients, 3 patients.
Can I say something about that, Sada? We discussed about 5 years ago in Dubai about the flash mob design we have developed in the Netherlands, where we do take a simple clinical question, sometimes a logistical question, and collect data from many hospitals in one day. And we have done it about sleeping hospitals in 8 countries, including 2,000 patients in one day. Another study with capillary refill time, including 3,000 patients. We were planning to do that, but then the COVID came. And I think we should really discuss about that flash mob research where you collect data in one day, where it doesn't cost much time. We have enough experience to share with you our knowledge. And you were talking about, funny you said, when you talk about research, you said big data. We also got a big data unit now with new PhDs, and we are working on the first randomized controlled trial using big data in the world that we started the 1st of December. So I would very much want to introduce the flash mob concept here. We should come up with a small group of researchers, come up with a question. We will give you all the necessary preparations and also background. I got enough PhDs to help me. So I would suggest that we just take it seriously and do a flash mob study. And what we noticed when we do flash mob study was we had lots of media coverage, lots and lots of media coverage about the study. Because we have even patients coming during the day wanting to take part in the study when we do a study. So I would seriously consider that. I would like to, do it with a few group of people. Think about it.
Yeah, I think it's a good idea, and maybe a small question, one case study could be done.
And also what Dr. Boyd said, when it comes to WHO, the gold standard method of giving emergency care is not clear. In Europe, we have done studies on Netherlands, Denmark, UK, Belgium, but it would be nice to do a study in one day, ask everybody what kind of patient is, how long did they stay, how many of patients were admitted, what's their presenting complaint. That will give us a lot of insight into the method. So I would suggest that we do that, and maybe we can do it next year, couple to Vaasa, 1 week before we come to the Congress, the next venue, we can do that.
Just one short point responding to your response. Excellent idea. And this study we did it in 2019-20, the 24-hour study in the ED across 100 facilities of India, both at the tertiary care, 50 tertiary care and 50 district hospital in the emergency department, and that is now published in the planning commission's document. So that is helping our government to make the policy national. Second point which is saying is that regarding emergency cases, constantly in LMI system, that we right now doing a adaptive modeling of facility-based emergency care in India, right? So we are doing what can I say? I should given a grant by the Indian Council of Medical Research.
I think we should talk. We should form a small key group and talk about it and come up with a plan.
I think we should do flash mob modeling is a very good modeling.
Thank you. This is a great idea, and I think we can cooperate. If you have any or I will scan the all contacts and maybe send you the email about cooperation, because firstly, cooperation also with many hospitals, even looks like my company has on 15 hospitals in Poland. And besides, I think I'm good in meta-analysis, so if you in future you will have some ideas for meta-analysis, I can contact it together with you, and then, for example, send to you to create some draft, and it will be also fast way to increase the number of publications. And I think, as we're sitting here, if we publish any articles, maybe we will agree that from today we will also sign the affiliation of us and our names. And for example, after the full name of the list, we should put that this is the team of us.
Yeah, it's like what we do is we have lots of collaborators. We give them all collaborators, so they will all get the publication of format. We'll be doing a flash mob in a couple of months in the UK and Denmark. Maybe after that, next year I would say we'll prepare well. We'll talk about a research question. We need to have ethical approval. We have enough experience with doing this multi-center study. We could do something nice together, and then we can propagate it through us and flash mob.
Almost what I want to say very simple. I think that the research effort will be very good in countries where we have dedicated research task group led by somebody and has a team with him to distribute the work, to organize the work, nobody work as a solo from scientific. And also this will be dedicated to have at least every 6 months one paper published, and we are also working on the Western Winter and we received by the whole Western Task Group. And this will open the gate for the future. We can have fellowship and data research will not need license, and it will be easy if it is possible group of research and we the fellowship and fellowship. It is a good idea. But first, we need to have a dedicated group to be practice.
So I'll create an email group between the three. Anybody who wants to join can join, and then we'll distribute the work.
And we can offer PhDs also. In our institute also, we can offer PhD to students who want to come and do research.
So I will create a research group. So we create a filler is already there, so we can have a team of top people who are good at data analysis, good at processing, and maybe one meta-analysis a year and one real-time study a year could be, or once in 2 years. It doesn't matter. We have a meta-analysis team also. So
I suppose one meta-analysis will be not problematic because I publish a lot of about 100 publications.
yeah, but for the Vasan's sake,
Yeah, but from this day, each publication will be also publication of Vasan.
Yeah.
If we increase and we compare together, the number of publications will increase diametrically. So,
and we have a full portal where we list the publications. We could do that.
We should send a research center around once in 2 months when we start something new. So if you want to collaborate, we can collaborate.
Okay.
And I think we should do that.
And all of you have the email, so you are all on the group email, the readers. So you can email back to the group. Just change the title so that the stacking of the email doesn't happen in the emails and doesn't get lost. We have a group email. Yeah, group email is there. So I'll re-put you in that. Yeah. So yes, Aruna, we have to move fast on the agenda. So we will do that. So yeah, please.
I just want to say, actually, your golden words about process management, which we have been doing in Sri Lanka, recently started, right? And the other thing is about this focus. Although we could not come there physically with our economic decision, but we have enough expertise and we can train many people from different parts of the world, provided that you allow you give them some scholarship and some other side, because Sri Lanka money is very cheap now, right? So in that case, you can organize many training programs throughout the people program and many institutions throughout the world. And the biggest thing is that new house administration ambassador, who is university, and he knows manager to use next large manager bureaucracy that you go. So in this we can have a very nice future. Thank you everyone for offering trauma and the other fellowships to Dr. Azani. Hope that we can work collaboratively in the future. Our organization will be over by 3 months time as picture. So after we can work together, and such time I am willing to gain as many people as possible from other countries, provided that we give them some kind of side. That's what I would say. And you are again emphasizing the process management principle, which is a must. I'm actually on this business management as well as some of the notes. And that must be incorporated into curriculum or emergency or trauma care or whatever the system or whatever. And my friend Professor Babalanka's concept of national can be incorporated in training focus as well. Thank you.
I know Sri Lanka, I'm Sri Lanka too. So
Thanks. So we'll go back to the most important point. Is the global competition corridor. So this year we are going to work on introducing new competitions in Turkish, the simulation, the sonography, and the CPC was a blockbuster. So the gaming section will also start this year in Masam, where we are going to do global level games. The CPC was held over 9 time zones. It was the 19th CPC with 20 teams, the highest ever. So basically 39 presentations were done.
with Zoom and in person, this very room. And our Sono games, which are unique in India, which is called the Whirlpool games. So we have a model of Whirlpool, which goes down and then the winner comes at the depth of the Whirlpool. That game, and the first ever Sono Sim crossover competition model will be developed. We are developing the simulation with sonography will be introduced. So in a sim format. So we are working on these 3 games. We are going to work with Turkey to give a Turkish version to those games, which will be the first time we will be having a Turkish version of the gaming system, which will be a unique copyright, which will have mixed methods and a methodology of crossovers. So that will be one of the big things. Move on to Dr. Lisa Moreno. We welcome the American Academy of Emergency Medicine. They are president, but she's the immediate past president and sits on the executive board of AEM. It's kindly consented to be here. We are on the verge of AEM joining WASEM, so this is I think the last step towards AEM bringing their full 15,000 membership to the WASEM board, which is a very big benchmark in the history of development of WASEM and for an American organization of that stature. So over to Dr. Lisa.
So thank you. It's an honor for me to be here. I am representing the American Academy of Emergency Medicine as the immediate past president, and we have had, I've had personally relationships with many people who are involved in WASEM, and this is something that is part of the mission statement of the American Academy of Emergency Medicine. We are committed to the development of emergency medicine globally. We are committed, however, to a very specific model of emergency medicine, and that is physician-controlled emergency medicine. So that we believe our first mission statement pillar is that every human being on the planet, it doesn't say on the planet, but every human being who has an emergency medical or surgical condition is entitled to the highest level of emergency care by a person who is board certified by the standards of their country. And so, because that is our vision, which of course is not going to be accomplished in our lifetimes, every person on the planet will get that level of care, but that is our goal, because all life is precious. And so, we are committed to assisting in the development of emergency medicine globally, according to a model where, based on the resources and based on the culture of that country, there is a training process put into place and a certification process put into place. And this is something that another past president of AAM, Dr. Canlı, from Lebanon, who was also board certified in the United States, has had a vision for a long time. And this is something that we've also been talking with Dr. Summer about. We believe that WASEM has several advantages for us. Number one is the fact that WASEM believes in the dignity of all human life and the entitlement of all human beings to have the highest level of emergency care when they experience a medical or surgical emergency. We also know that WASEM is committed to scholarship. It is an academic council. And so WASEM is committed to training, to learning, and that's what's been going on at this meeting the whole time. We at AAM are vehemently opposed to the corporate model of emergency medicine. It's interesting that you mentioned earlier, Dr. Summer, that you all these years you didn't understand why the teaching that you were giving wasn't taking hold, and the reason it wasn't taking hold was because in many countries they do not understand the operations management portion of emergency medicine, which is a critical part of running an emergency department. The absence of that understanding creates a gap into which corporate medical groups predatorily enter. So it is the fact that there's an absence of understanding that there is an organization management piece that is critical, these predatory groups come in and say, we know how to do this. We're not physicians, but it doesn't matter. We have experience in medicine, in emergency medicine, and other hospital-based practices, and we can step in and do this for you. And what ends up happening then is that it becomes a for-profit model, which is completely opposed to the concept that every human being, it doesn't matter whether they can pay, it doesn't matter who they are, it doesn't matter what value society places on their life. Their life is valuable and they deserve the best care. And so AAM is extremely committed to these values and extremely committed to the fact that we do not want to see the predatory behavior of corporate medical groups that has happened in the United States to happen in other countries because of the gap that is present. Not every emergency medicine group in the United States feels the way we do, believes the way we do, and so it is critical for us in forming an alliance with WASM that alliance would be unique. So that if we form an alliance where we support WASM and WASM's meetings, and WASM supports AAM and AAM's meetings, and then we also go forward with other plans for global training, global board certification, that the relationship be exclusive with AAM so that we can ensure the absence of corporate, non-physician-led groups stepping in and having an influence in other countries. So I am actually flying from here to a board meeting of the American Academy of Emergency Medicine, and I would like to present a proposal to them for a formal memorandum of understanding, a formal collaboration with WASM, where we share resources, we share training, we work together for the global development of emergency medicine in a physician-led model. And that's what I want to propose.
And as we have had discussions, I'll brief the board. We have been discussing the AEM partnership for a couple of years now. AEM has exclusively remained as an organization with accreditants, board-certified residency trained emergency physicians. That is their local responsibility towards the United States. But AEM also was the pioneer of international emergency medicine in the world, embracing international emergency medicine and conversation in the world was pioneered by Dr. Antoine Kazi, after whom the Kazi Award, which is reality-wise the Nobel Prize of International EM, highest award named after his legacy. He wrote the first script of internationalizing emergency care through emergency medicine. So that is their international responsibility. The way AEM wants to propose their partnership in WASM is AEM holds 50,000 members. It's a standard national organization, state-of-art, high-quality CNA credits. WASM AEM joining WASM comes with exclusivity agreements that they will be the American representative of professional medicine in WASM. So we would only exclusively be with them, which is quite agreeable because they are also experimenting with this collaboration, supporting this collaboration, which is unconventional collaboration where there are no societies, associations, individuals, and universities collaborating, which is a different kind of diplomatic arrangement internationally for AEM's presence to expand into the preview of emergency care. So from emergency medicine, collaborating with trauma, collaborating with emergency medicine, collaborating with critical care, anesthesia outside the United States. It's a new experiment for them, academic experiment, which they will be taking that experiment with us. They will be exposing all their resources. They will be allowing us to use all the resources. We will get representation at their congresses. Also, the membership will have an opportunity to attend WASM conferences and indulge in development of emergency trauma, critical care outside in the world, which is a big gain for American academic faculties to work with the world in different areas and not stick to chest pain, shortness of breath, UTI. that kind of model. So it's a huge global development model which is coming. But there are some non-negotiable clauses which have been put, which Dr. Lisa wanted me to highlight. One is that they will have exclusivity when it comes to AEM being a partner in the US, so we can't go with other organizations. We will only maintain our universities and all is fine, but when it comes to professional body, they will be the only professional body we will go with. That's agreeable because that's a huge benefit to ASEAN. But we maintain that exclusivity also maintains with us in this kind of model. The second, this is still subject to approval by the board in AEM. The second model is, which will come, but I want the board to know, is that they would like us to bridge resources. So they do an annual Congress at NEMC in the Mediterranean and the European regions, which is a big conference. So they do it in the odd years. And they want us, which is a good idea, which is quite acceptable to me at least, is that we save resources of doing the World Congress every year, and they will brand it as a World Academic Congress and NEMC Joint Congress. So it will be a WASEM and NEMC Congress every year, every odd year, but they stick to Mediterranean. So they will, European Mediterranean region. They don't mind if we go to another European, but they will stick to their tickets, which they have a full-scale workforce. They have established attendance of 400 to 500 people every alternate year. Sometimes they touch 1,000, which allows our faculty and to attend that meeting. But then, the odd year, in the even years, we do WASEM at our location, where that will open it to AEM members to attend our meeting. So every year, AEM will be able to offer them an international destination and international meeting to attend. Whenever they attend, we attend their meetings. We come up with a joint agreement on the rates and the registration process, which should be discussed. And when they come to us, of course, we will all get registration the way it is done. So that will be a very big benchmark for us. Once the board approves, we will decide which year we will kick it in. I don't think this model will kick in till 2025 or 2026. So 2024 will run according to the WASEM format. They will change presidency this year, so I think that will also come in the new president's agenda for next year. So the board meeting will come to know more. But I think till 2024 we are all fine. And 2025 also, Prabhat knows that if this model comes, so the board is quite okay with that. But this year also we are going to start a backup site model. So there will be a first site and there will be a backup site, so that we all know that the WASEM will happen come what may. So Poland has happened as agreed to be the backup site in case it's a problem. Like we had a problem in 2023 of COVID happened, then we had to literally change all the contracts, and then Malaysia was kind enough to move the site. And it was the first time where the Malaysian Congress was held without the Malaysian president because of the whole mix-up of COVID. So they were kind enough to do that. So we have to do that as a big organization. We have to do that. I would like the board to again understand we are a very easy, less red tape organization. We don't like fights. We don't encourage arguments. It's all for the patients, and it is all about research, education, and patient care. The reason why WASEM has grown is because it has ideologically maintained that to compete in a sector, we are not going to decrease anybody's length, we are just going to increase our strength. So don't decrease anybody's length, just increase our strength. That is the mission which we have maintained, and that's what we want to maintain. So all the new leaders who are joining, please understand that it's a very easy, flexible organization. There are some partners who are weak or not so strong, some partners are extremely strong, and that's where the balance is maintained. I think that is where it is. So the board will inform us to do what we have to do next, and then we'll take that. So, give it to
Hello everyone. We so sorry that for the first time after many years I was not able to join you because I was anticipating when I came back from my teaching period in St. during the flight. Anyway, again, all of my kind salutation to all of you. Just to briefly introduce what will be my idea of having also a role just to make the opportunity to also join Great Network. As you know, I was asked to give a talk to the European Society of Emergency Medicine Barcelona recently on the Emergency Medicine Research Organization, and I got the opportunity to show that the Great Network was able to publish more than 350 papers during the last 12 years. So basically, the main message of this Congress next year will be research and publications. And in this period, the period will be September 26 until September 30. So the first 2 days will be the Great Young Research meeting, and it is only to accept from the young people from all the Muslim countries to participate in submitting abstracts of all the publications. We have not so many lectures, just 1 or 2 by seniors. And then the other 3 days will be again cultural innovations. So this is the week we agree to adding some hot topics that are elderly emergency medicine and telemedicine and emergency medicine. Moreover, we are really like encourage for young people from your country to submit contribution. And if they are not submitting contribution, I got 80 journals ready to accept. So these young people, they can come in Rome, just having the papers, if accepted, ready to submit. So this is an innovation way to increase the number of publication with this person name. So not anymore abstract, not anymore posters, papers as government. And these papers, I just like to announce from now that there will be 2 consensus papers that we would like to join our lesson grade. One is artificial intelligence in emergency medicine, and the other one, laboratory medicine in emergency medicine. These are good topics that actually this has been not covered enough, and we really something where also can make the difference in the future. Just to conclude my presentation, I would like to say that from now, I need Sagar to send me immediately the name of the speakers that I have to include from your side, from the day from 28 to 30. And also, I would like to ask you to provide a board group of also to join the board group for starting from tomorrow to having this preparation and big meeting. For all the emergency medicine society from the world will come. I am not sure that I will be able to 1,200 people like in Turkey, but I hope that there will be really a more global presence of the rest of the world. So this will be an opportunity to increase the safe participation of other countries. You mentioned already Korea and US, and definitely I'm moving also more in Asia, Pacific area, and these people are more likely to meet for publication. Last part would be that we have a monthly Zoom meeting to prepare this conference. So I hope that you really enjoy Rome as an opportunity to have, I think this will be the first European meeting, right, Sarah?
Yes.
Of course.
Yes.
That is really something that I hope that all the people coming from so many countries will be happy about that. So waiting for you to, not from now, just start to this was in 2024 with the Great Network. Thank you, Sarah, for the opportunity.
So I want to put a vote to the board. This has been on my mind for a long, long time. So Dr. Salvatore has given a career to publications, the existence of BNP in our work that he has done in BNP, procalcitonin, the biomarker circuit, this legacy is there. I would like to propose to the board that he's God gave him a great life, but I think time is soon coming that Sal is going to love sailing and enjoying his life from science. So the 2024 meeting should be dedicated as a legacy to the research of Dr. Salvatore as he hosts his last global meeting. He has told me that he is hosting this. This will be his last global meeting before he leads a life after this. So I would ask the board to support me with the vote whether Masem approves that the 2024 will be a legacy meeting dedicated to Professor Salvatore. And
I would request him that the first 2 days workshop should be on longevity, where he has started research on living beyond 100 years. And he has got funding. So we would like you to work with Dr. Fatima also, because she has launched the Wellness Alliance for longevity. If we can get the Global Alliance in your study, where you are collecting blood on all the people who are 100 years old and who have no disease, to find out how they are living at 100. So we would like you to please include that, and we will share. So we have a research committee. Dr. Zampek is there from Poland. I think you know each other through publications. He has joined WhatsApp now. Dr. Prabhat is there, and Dr. Ayman, you know very well. So I think the whole team should be there, but a unique design of everybody should bring some study they have done to be a presenter. I think will be a phenomenal benchmark. And if the AEM comes through, then I think that opens up the doors to all their members to be presenters. So I think that will also be a rep. So the invited faculty will have a different path, and open access faculty who can apply will go through the registration process. So I think that will be great. Sal, I hope you get well soon. And I was a little shocked that you got COVID. So
yeah, it was great because I think I took my flight from San Diego to London and to Rome 4 days ago, and then I got fever and throat pain, but anyway, I'm really get on with recovery soon. And as you say, you're ready for a new life, but not without science. Yes. I can
some science. So, longevity, that's your new science to live a life. So I know what you're doing. So that's good. And we would like to taste your Mediterranean diet also, which you propose a lot, right? So Dr. Qazi, please.
Thank you. I just actually want to take a moment to raise some comments and observations. I see the dynamics that have gone on in meeting Malaysia and here. I've seen the conferences and successes of the conferences. I've compared the experience we've had in the organizing international meetings with UAE and across the world. We've done in Argentina, we've done in the Caribbean, some in the MENC, the American Academy has done a lot of international activities, and we've gained experience the last 20 years. But you mentioned the Nobel Prize and these, that's a bit too much. So what I can tell you is a word that carries my name, and perhaps 8 years long to be dead to join Observatory is Mediterranean diet. The point is, when you usually give a diet and name an award after someone, you say that they shouldn't be alive anymore. Anyway, so I don't know why they tell you did that, but I actually know why they did that, because we're the very big Ricci in Rome. 9 years ago, Salvatore was there. We did a very good coup over there, with its own impact and damages. Anyway, since I don't have a lot of experience in international business, looking at this great esteemed body of individuals over here today, in Malaysia before, I'm going to give you a little word that is important at this junction. We've been at least 10 years now out. So, and I see the caliber of individuals over here. I can tell you from the outside, I'm inside now, but from the outside, what I see is a potpourri, a conglomeration of institutions, nations, societies, and institutions, and individuals. They're all coming together without rank, without any, but you're all committed to scholarly activity and to what's right for your institution, your nation, and sometimes more. I think it is time for WASM to start redefining itself in the sense of trying to understand you can always be a potpourri of institutions, national societies, and individuals. And that's what you want to do, that's your choice. But that limits you in a sense, but empowers you in another. So the internal dynamics at some point will be important. Choosing one of the big successes, the reason for your successes in our meetings, since I remember now, is because you always do your conferences in the nations that have already a strong national society and or institution. That allows you in Malaysia to succeed, that allows you to succeed, that allows you a better to succeed. And etc. It will allow you to succeed also at home. The laboratory is there with the great network. Those things are successes. In the academy, our meetings is the time when we had our divorce with the European Society. Our meeting has been about bringing Americans and their associates from other countries to a country where sometimes emergency medicine isn't strong. Greece, etc. I don't want to criticize, but you know, when you go to Germany, what do you expect? There isn't a lot of strong emergency medicine there. If you came to Lebanon, emergency medicine is, there are 30 of us left out of 90 who are registered as specialists. There are 30 there left. So, you know, how can you bring masses of people? So those are things that are, if we measure the success of meeting by the number of attendees, you are forcing yourselves to go every 2 years to a country where you have a strong national society and to append yourselves to the national meeting. And that is the reason of your success. You bring industry, bring support, and you mobilize, let's face it, you mobilize the people who come to the meeting to come to you. We are moving a meeting that is other than our national meeting. This is the next meeting. And defining the schedule of meetings is critical. In the sense of, at the end of the day, when AAEM is having the AMC, it is a WASM meeting. We are going to be hopefully a member of WASM. Vice versa, when WASM is going to the MEMC, it's going to a WASM meeting. And when we promote the WASM meeting, we're promoting to our members the meeting to a federation, to an agglomeration we are members of. In the past, there was something known as international federation that occurred, and they ended up with one of the biggest challenges now is the $7 million loss that they had actually in Argentina due to COVID. I understand it's because they didn't have insurance for the meeting. We actually have always had insurance, fortunately. So it's all about it. Nevertheless, but we have lost one in Argentina. So I can tell you, we know where and what not to do in international meetings. And when we do lose money now in the meeting, it's affordable for us because we choose to do it. And we think of the bigger issue, and we have no sponsorship. The industry is not willing to go fund meetings that are outside the nation where they're based. So they don't want to fund Americans in Europe, but they want to. I think it's obvious. People want to fund people who are from their own countries, coming to their own meetings. So industry support is a bigger issue. We may change this ultimately together if we work together. Now, so I'm saying that it is time perhaps for WASM to decide to define itself or to build the bylaws that it requires and better understand who is joining what. In fact, some of the problems I mentioned earlier, the unintended consequence of going to a 2-month fellowship. Maybe fellowship is not the word, sectorship, other things. These definitions, we need to do them together. I don't say that I have the alternative. I know the value of what you're doing, and I would like to send you at least half a dozen from my own country to really benefit from what you have to do. I will use it together. We actually need it. So I'm not being critical, I'm just advising that we should really start reorganizing and organizing and taking the opportunity, because if we don't take the opportunity will go somewhere else. There is an opportunity for the creation of an international organization that brings emergency medicine together. It is time, and we're in an egalitarian way, where we're all doing it together. And I can take it a step further. It's time also to think not only of emergency medicine, but of acute care. You know, when I'm the chief editor for a journal, I started for the academy called the Mediterranean Journal of Emergency Medicine and Acute Care. 50% of the editorial board must be non-emergency medicine specialists. Why are we doing that? So it's because we need to remember that this fermentation is critical for the development of acute care medicine. So these are things that I've learned from Salvatore. I've learned them from my colleagues. I've learned them from Dr. outside of the surgeon who could do this. No, he chose to do it with us, to help us. So how to retain and bank on this to make us stronger is an element that really requires some retreat time, some 5-year, 10-year, 20-year strategy. I know we will not be there, probably, unless we eat the diet of certain people, Salvatore. But the point is we need to start creating ourselves and thinking where we're going. What's awesome? You really need to think, where will it be? And where will you be? What if you are in a Malaysian society, Dr. Ali, and someday somebody in a Malaysian society will replace you? What happens to you? One of the things we need in the academy to retain value of people like me. I'm a class president from 20 years ago for the academy. I'm called that the president council. We created an actual council which we tap on physicians, clinicians. You may want to create the same model because you need more at some point to create value for new blood. Yet retaining the value, the respect, and the courtesy for your older blood. It's time to create awards. It's time to create, more products within WASM than just conferences. These networks are not very obvious sometimes. So you talk about the journals you have. I can tell you, they're not very obvious to many of us. So how can we promote ourselves? That is also important. Part of what I recommend to be more than just an hour meeting or 2-hour meeting every year or two. I think we need to have Zoom meetings. I think we have to have task forces that are dedicated for to do a retreat. Maybe we go to Qatar, or we will go to somewhere down and think what can we do for the global development of acute care under the leadership of WASM.
I think those are fantastic points, and as the relationship evolves, we will progress in that direction. I think, the awards, we have the WASM Leader of the Year awards as we grow. As you know, the system by which WASM was developed was a very different system, and it will evolve as we move along, as more and more members come, more and more hands come, more and more brains come. We will develop that further. I think developing a relationship with AEM is a very big step for our evolution. It is a very big step for AEM's evolution because I am myself an AEM member, and I am also a recipient of the Canlı Award. So I value what AEM has done for the world, but I think their understanding of extending the conversation to include emergency trauma, critical care, anesthesia in the international market with a huge out-of-the-box thinking for American medical model, which is more like a focus model, segregated model. So taking the silo is what AEM is doing now. I think this will open the doors for AEM to have a better understanding of the world. They will be doing things which they have not done. So I think that is a very big thing for us. I would like Dr. Zalbek to say quickly a few words about his society before we change the call sign from Turkey to Italy. Sal would have been there, he would have had the handover ceremony, but we will replace the chairman's seat with the Italian flag. And the flags are already here after your brief comments.
Okay. So one more time, I'm happy to be with you here. I represent, I think, 3 organizations, because as I say, I am president of the Polish Society of Disaster Medicine, and we are working in the field of emergency medicine. We have even our own journal, Disaster and Emergency Medicine Journal, to which I invite you all, the editorial board, if you want, of course. The secondly, I invite the director of the Polish Society, the EMS dispatcher in Warsaw, and we have 88 ambulances, so this is the biggest EMS dispatcher in Poland. My third position is the director of clinical research and development in LuxNet Group. As I say, we have our own 15 hospitals and 270 private clinics. And the last, not least, I think, I'm vice director for science and cooperation and Maria Skłodowska Medical Academy. This is private medical university in Warsaw. And I try to combine all those positions to increase the number of research, increase the knowledge of the emergency
much. We'll come to the end of the meeting. The call sign has changed from Turkey to Italy now. Dr. Sanwikar is the new Secretary General of WASEM starting his term. The Turkish parade starts for us. A special parade has been arranged for us on their 100th Republic Day. A full command guard of honor is starting now, so we have to all proceed there. We'll quickly stand here, please, everybody, so that we can take a picture. Please take a picture from there so that the whole board meeting is covered. And the whole board is seen. We missed Dr. Salvatore, but we have the Italy flag here. So, let's go to the chair.
Down there, get sound.
Oh, yeah, we can stand there. Yeah, we'll all stand there.
That's exactly it.
Let's bring the flag.
You can calculate the surface according with the weight, total body superficie, weight, kilograms, and also for less and more than 10 kilograms. How you maintain the routine for the fluids? If the patient is more than 10 kilograms, you can increase 50 milliliters per kilo per day for the next 10 kilograms, or 20 per kilo per day if they are over 20 kilograms. So you need to be careful because sometimes if you use more than this, you are overloaded. How is the balance between the income water is about the income oral water that you use them and also performing water and oxidation water? And what is the expenses that you have? In sensitive losses like urine, stool, sweat, temperature, and breathing. So this is how you expense this. In this period, you have two different periods to treat the patient. The first one is the resuscitation phase in acute presentation when the fluids is needed to restore adequate tissue perfusion and prevent the lesion. In this time is immediately, the next couple of minutes and the next hour. The second phase for the period is the tridatration phase. It's a critical window to determine what intravascular repletion has been achieved and the trajectory of the fluids gain versus losses. And the third phase, or the third period, is maintain the phase, is the moment in which the fluids must be supplied to achieve the precise homeostatic equilibrium between the needs and the losses the patient present. And the next phase is convalescence, the period in which the administration of exogenous fluids is stopped and the patient return for the intrinsic regulation of the fluids. So it's a break to invite you to come to the conference next November in Mexico. So be careful. A specific protocol's dose is not able to apply for all patients. Every patient needs to be particular way to treatment. The needs of the fluids in patient ER is very widely. So many patients depend the pathology, depend the antecedent they have because it's very different. So the choice of the appropriate type and amount of the volume require great care. So you need to be careful about that. This is why we use different type of the solution. We have crystalloids and also we have colloids. Colloids is the best expanding capacity given by the sodium and maintain the electrolyte balance. But you need to be careful. 80% of the volume of the solution go straight to the internal space. Between 20 and 25% stay intravascular space, and the next 15 minutes disappear. So you need to be careful about that because when you start to overloading the doses of the solution, you produce more damage. So the colloids is try to maintain the colloids pressure and is one of the best expander volume. So you can use other solutions like gelatin, dextran, or albumin. And you can see if you compare the solution that the crystalloids, ringer lactate, and you compare with the plasma,
and you see the tonicity, and you see the equivalence between sodium and chlorine are similar. This is why we use most of the time this solution in the beginning of the patient. So also the osmolarity, if you compare with the plasma, the first one, the isotonic, is the osmolarity is osmolar and isotonic. But also, if you compare with the plasma, the next one, the tonicity is the same. So it's osmolar and isotonic for the patient that they use isotonic crystal contain between 121 milliequivalents of the sodium per solution. So what is the indication if we want to use the solution? In emergency room, normally we use a lot of physiology solution, and also we use the lactate ringer. So what is the indication for this is for reposition volume, hypovolemic shock, and also when you use lactate is for hypovolemic shock and reposition. The other one is the artificial colloids that we use for replacement volume, and also with the patient when present burns or ascites or nephropathy syndrome. You can see in this table what is the characteristic of the different states. The principal goal that you have in the first step, the rescue, is the life-saving and correct the shock. So the time that you need to use is minutes. And this is typical scenario for septic shock and major trauma and hypovolemic shock. The next is the optimization. The principal goal is rescue the organs, and also you can use for burns, ketoacidosis, and you can spend 4 hours, the next hours to use it. And the third line, this is the stabilization. The principal goal is the organ support. You can use in days and stable it, and also use for patients that they have pancreatitis or they have operating room or something. And the last is this escalation is for preserve the organ recovery. This is the principal goal. And this is the time that you see, you can use in days and the weeks, but also you can use it for patients that they are in the parenteral or they are in the other problems for the surgery and other things. So in these different states, you can see what is the principal goal in every state that you see to try to maintain the solution. So in resume, rescue is between 0 and 24 hours. Optimization is between 24 and 72 hours. Stabilization is 72 to 110, and desreanimation is after 110 hours. So you can see the strong recommendation accord with this chapter. This is one of the papers that they wrote in the last November, and this is other one in the last December. And they showed the guidelines to this, and they are the evidence to recommend of the fluids, the use of the provide critical support for patients that they are really serious, and for that patient that they cannot provide or they do not use the enteral administration like gastroenteritis, respiratory problem, and the patient with neurology, right? So in these papers that I show you, they recommend the administration of the hypotonic solution has been the standard in pediatrics. But most of them, they have incident for the hyponatremia. So you need to be careful because the patient, when you start to use this solution, they produce more hyponatremia than the other ones. This is why in two of these papers, and other more than this, they recommend the isotonic solution for children that they need IV solution could be prevent the development of the hyponatremia. So they don't use hypotonic, they now use isotonic because they want to prevent hyponatremia. In this paper also, they have a strong recommendation on the isotonic solution between the patient to 28 days until 18 years old, they require solution and should receive isotonic solution because with appropriate potassium chloride and dextrosa, they significantly reduce the risk of developing hyponatremia. So in that way, you can prevent more complication than the benefits that you can do. Also, you can use the personalized fluid resuscitation. Require principal attention for this mnemonic: context, indication, target, timing, among the fluids, infusion strategy, a type of the diffusion that you want to use in case the patient requires. So this model using characterization is for every patient in particular. This was published recently in 2015, and they are now accepted, and because they are not normally accepted for all people that work in the emergency room in pediatric situation. But over the years, emergency room, we create the shock units or trauma units, and they have developed over the years. One could argue that the PER has offered the ultimate environment to the real-time personal medicine. When we treat patients in the emergency room, and specifically in the bay of the trauma or burns or ketoacidosis, we personalize the treatment for every patient. So remember, in emergency medicine are significant heterogeneous, the patient. Sometimes they have one disease, sometimes they have problem for genetics, sometimes. So we need to personalize medicine for different patients that we receive. But also we have other problem, the problem with the sepsis. The treatment remains remarkably weak and highly conflicting. If you see, the diagnosis of sepsis require interpretation, no specific signs, and can therefore be subjective and variable. So this is why you need to pay attention, because the heterogeneity and intervention may be benefit for one group, but could be harmful for the other group when you have patients with the sepsis or more pathology. The future is that we need to focus on several important issues. First, we need to educate the clinician about the risk of the fluids loading patients who are not fluid respondent. The potential of the harm caused by the fluid bolus therapy should be more clearly featured in the guidelines. Other implementation is the physiology and a hemodynamic guide, conservative approach, the fluid therapy in patients with sepsis. Good possibility to reduce the morbidity and improve the outcome if you use correctly the fluids. The second is the effect of the fluids infusion in the immune system. On endothelial function, in the one integrity, the glycocalyx remain poorly understood. Degradation of the glycocalyx on the vascular luminal cell membrane has been identified to be early step for the sepsis, for the subvascular endothelial cell disorder. So if you see, when you start to use this in bolus, you can produce more damage than benefits for the patient, because start to destroy and more damage for the different part of the human body. So the second one is the fluid therapy has the potential to the further damage for the glycocalyx, especially when you have rapid infusion, as used when the fluid infusion results in hyperkalemia. So you have alternative fluids volume therapy for the treatment in shock that the early use and vasoactive drugs. So in that way you can prevent more damage for the kidney and also for them. And the third concept is the hypertonic resuscitation may provide effective and rapid intravascular bovine resuscitation for the patient in the emergency room. So in conclusion, there is no ideal solution that guarantees the correlation with electrolytes and normality, and it's important to individualize the liquor measure according with the physiology and the pathology of each patient that comes to the emergency room. So in London in 2013, they proposed 3 points. One is the goals, the fluid therapy for goals to every patient. The method of monitoring the patient in the emergency room and the different clinical contexts about this patient. So in conclusion, the fluid resuscitation has been one of the cornerstones in the treatment. An increased body of literature suggests that the fluid volume therapy may contribute to the fluid overload and cause harm. The effect of the fluid volumes on physiological parameters are not well studied and seen small and short life and the best. Personal fluid administration requires clinicians to integrate a normal physiology parameters into clinical decision making. So personal fluid resuscitation therefore requires careful attention for each patient with the mnemonic name that I told you before. Context, indication, target, time, amount, and everything, so and so. More of the progress that has been made in emergency medicine is the result of identifying and abandoning the potential harmful intervention in the treatment. So it's time, perhaps now, to add the indiscriminate use of the therapy for that list. Because sometimes when the patients come to the emergency room, it's like normally they order to, hey, they go glucosaline or they go glucose 5% and started this, and sometimes produce more hyponatremia or alteration in the electrolytes, and they produce more damage in the kidney or the perfusion in the cellular zone. So I think this is the new concept that they have now in the emergency room about the solution for the patient, pediatric patient in the ER. I don't know if you have a question. Question? Yes, sir.
Yeah. Thank you very much, Professor Carlos, for your nice presentation. My question is about that. Do we have an ideal mean arterial pressure or systolic blood pressure to maintain an adequate organ perfusion or tissue oxygenation for the children while infusing the resuscitation?
That I show you in the score depend what is the situation of the patient. You can see for the first one is for the rescue. So you can use the isotonic solution to prevent the alteration of the hyponatremia. This is how you use in the patient in the ER. The paper that I show you, they show that if you still use it, glucose 5%, you can produce more alteration in the electrolytes like the sodium hyponatremia than it's better if you use isotonic solution in the patient.
Okay.
Excellent. Excellent. I think we have one more question over there. Please go ahead.
Thank you for your presentation, Professor Garcia Rosas. In trauma surgery with major hemorrhage, contemporary best practice is damage control resuscitation with limited use of crystalloids and early use of blood components. That's for adults. What has been the experience of damage control resuscitation in children?
Well, first of all, if the patient they have really hemorrhagic shock severe, the best thing is use blood. If you have, but in trauma, sometimes you are not available the blood already, so you start with crystalloids to use them, and then when you have already the blood, you start to treat the patient with blood, because this is the recommendation that we have in the ER. The most important is recovery and control the damage for the patient in trauma. Trauma is a particular issue that is different like the other issues, right? Trauma, you need to be ready for number of the blood components and everything to try to control. And also, if they need a laparotomy to control the damage for the liver or for any injury inside, you need to control and start to use the blood.
My question was the difference between adults and children. What are the differences? Are there any?
For children, what age? Because the children is 28 to 18. If you're talking about teenagers, or what age? Any age. At the beginning, you start to use crystalloids. Then when you get it, the blood component, you use it. Because the point is, first of all, you need to control the bleeding. Depend what we're talking about, liver or whatever. But the second one is you start if you have the elements for the blood, you use blood or component of the blood, right? But if you don't have it at the beginning, you use crystalloids and for treat the hypovolemic shock. This is how we use it. I don't know if it's the answer or not.
Thank you. Thank you. I think that's a great answer to the question. There's very little difference. If you have blood, use it. And if you don't, try volume expansion with crystalloids until you do. Right. Are there any other questions? No? Okay. Thank you. I think with that, we'll move on to our next speaker.
Thank you.
Okay. Our next speaker is Dr. Bashak Yilmaz. She is an emergency medicine physician and working in the State Hospital of Burdur, Turkey. And she's also the member of USM. Her topic is the indication of the CT in the emergency department. You are welcome.
So they gave me some room to move. Thank you for that, and sorry for my sore throat and a terrible voice. Bear with me. I'm an emergency physician, a fresh one, and all emergency physicians have their interest areas. And pediatric emergency medicine definitely is not one of mine. But it doesn't really matter if you're in emergency medicine, because well, all the emergency cases basically just show up at your door. You care for the pediatric patient or not, they will be there and you will need to take care of them. So you will need to know how to act. And the title I was given was to CT or not to CT. Well, to me, that's not the question. You know, when it comes to CTs, nothing's really all black or all white. The CTs work in grayscale. We have a lot of room in between. If you want to know all the criteria, all the guidelines, they're out in the world. You can go out, check them out. You don't even need to memorize them. There are a lot of applications right now. You can just check the criteria on my mobile phone when you see the patient. Do I need to CT them or not? But there are other sets of questions you need to ask before you try to make your mind. The first and the most basic one is, can we CT? Do we even have a CT machine? Are we in an established center blessed with a CT machine that we now take for granted during our training programs? We may be in a humanitarian aid area with a limited resource setting. We may be in a rural hospital. Our city might be out of order. That happens all the time. We might have a CT, but we may not have the skill set to evaluate the images we have. We might have the skill set to evaluate the images, but it may not be accepted as the official report by our governing bodies. So we may also need the report from the radiologist. Do we have access to a radiologist 24/7 in our centers? So do we need to refer our patients who we perform CTs on to an upper level center? So should we perform the CT? I work in a rural hospital, the only hospital in my small city, with a lot of connecting towns nearby. 2 of my connecting towns have a CT, but they don't have the GP, they only have GPs on call, and they don't certainly have emergency physicians or radiologists that they can refer their CT images to during their shifts. So a lot of times I receive patients that have pan-CTs performed, but they don't have the images. I can't retrieve the images to evaluate myself. I need to perform everything all over again. The patient gets twice the dose. After the evaluation, I see something, or most of the times, I don't see anything. I discharge the patient, and the patient has no means to go back home. And this is important. If asking for a CT, if to CT means hundreds of kilometers, if it comes on the expense of hours of lack of an inter-hospital or per-hospital transfer team, depending on how they operate in your home city, it really affects your practice, your day-to-day practice. So should we CT? Will it really change our practice? This is something we should consider. Is it a minor trauma that I can simply observe in my own center and decide if I want to refer it to the upper center later on or not? Or is it something that my surgeon can handle? For example, is it an, I don't know, stomach pain, a possible appendicitis? And can I operate without the CT? Should I really refer the patient to an upper center for that? How many of you work in an environment as sterile as that? Or is it more like this or this? This is how we work in Turkey. So we work in overpressured, overworked, overcrowded environments. So we always feel overwhelmed, and we try to protect ourselves. I work with a lot of freshly graduated GPs coming out, straight out of medical school and into my department, overanalyzing the patients, afraid of missing out on some important diagnosis. My whole emergency department staff loads them because this means extra workload for them. Also, my hospital administration doesn't like that because it also means extra money for them. And they constantly tell me to talk to my GPs to the number of CTs performed or the lab tests they ask for. But how can I do that? We live in a time of constant malpractice cases. We live in a time of constant medical legal fear. Most of my GPs, on top of my head, I can easily think of 3 of them who still deal with 3 medical legal cases right now in the first few months of their practices. And thanks to their overanalyzing, they will not be charged with any problems in the end. Whereas myself has been sued a few weeks ago by a patient who had a mild stomach pain, and I didn't perform a stomach CT on, and she accused me of apparently overlooking her diagnosis of appendicitis, but she haven't been operated in any hospital. And moreover, my hospital administration, when talking to me about the suit I have, asked me why the hell I wouldn't just perform the CT the patient asked me for. It would be much more easier for me, and apparently it would be much more easier for the hospital administration. So in the hassle, in this crowded place, I work 24-hour shifts. I don't know how you work, but in a 24-hour shift, you tend to forget things. You tend to forget asking for the simplest things. Do you ask the kids how many times they have been in a CT machine before? I had a patient 2 days ago, just on my last shift before I came here. She had been in a fight. She had a tender cervical spine. Her X-ray didn't give me anything. And according to the appropriateness criteria, I should have performed a CT scan. And I was trying to convince her to lie still in the CT machine. She said, no, I'm not afraid of that. I've been there before. I said, oh, what? Why? How? So her father explained me, oh yes, she fell on the road last week. A minor trauma with no need for a CT. But last week, with the trauma, apparently, she already had a head and neck CT scan already. And we all know a simple CT scan can easily increase dose-dependently the lifetime cancer incidence. It is known, radiation causes cancer. And the next question we should ask is it worth to CT? Adults are easy. You tell them to lie still and they do. But have you tried holding an infant or a toddler still in a CT machine? You don't want to sedate them because then it makes it harder to follow up with their neurological symptoms, etc. Then is it really worth the hassle? Or can I just observe them a little bit before performing the CT? Is it really worth all the effort? Oh, and then comes the important question. Can they ask for the CT? Because that happens a lot. Patients come in through our doors, ask for a CT scan. I want a CT for my son. I want a CT for my daughter. I want an MRI for myself. This happens all the time. Again, on my last shift, I had a woman yelling in front of my resuscitation door when I was dealing with another patient, saying that her son, age of 3, who had some food poisoning symptoms, but also happened to fell on the floor at home, was vomiting. And she thought that was worthy of a CT scan. And I couldn't convince her otherwise. And my emergency department at that time was like this. Do I have the time to convince her otherwise? On expense of all the other patients there, on expense of my mental health. So I told her to just try to put the baby to sleep. And if she manages to keep the baby still enough to stay in that patient CT machine, I will perform the CT. And eventually, the CT scan was completely normal and they went back home. Very happy. But on what expense? Is it worth it? So, my last question is, not to CT or not to CT, but have to CT. With a justifiable clinical indication, does the patient really need the CT? Is it really important for my practice? And if yes, we should practice it with optimization in mind, with a radiation level as low as reasonably achievable. So to CT or not to CT is not the question, but the decision. Thank you for your time.
Okay. Okay, thank you, Dr. Bashak. Is there any question or comment from the audience? No questions? Okay, there is no question. Thank you very much for your nice speak. Are you going to present? Me? Okay. Okay. Our next speaker Association Professor Dr. Afshin Emre, he's coming from Ankara, he's working in Ankara. He's going to talk about, his topic is about the choosing appropriate size of equipment in pediatric patients. You are welcome, Dr. Afshin.
Thank you very much. Dear session moderators and dear audience, good morning from a beautiful Antalya morning. Welcome to our country and welcome to this nice city. I hope you all liked our opening ceremony and this fantastic hotel. And I hope you will have a nice time in here. I greet you all respectfully. I would like to express my gratitude to the President of Congress and the Organization Committee for their invitation and great hospitality. Today, I would like to talk about choosing the appropriate size of equipment in pediatric patients. Successful assessment and treatment of injured children depends on immediately available equipment of the appropriate size. We can classify the equipments in three groups: airway and breathing, circulation, and supplemental equipments. A length-based resuscitation tape, such as the Breslow emergency tape, is an ideal adjunct for rapidly determining weight based on length for appropriate fluid volumes, drug doses, and equipment size. By measuring the child's height, clinicians can readily determine his or her estimated weight. One side of the tape provides drugs and their recommended doses for pediatric patients based on weight, and the other side identifies equipment needs for pediatric patients based on length. Clinicians and emergency physicians should be familiar with length-based resuscitation tapes and their uses. The A of the ABCDE of initial assessment is the same in the child as for adults. Establishing a patent airway to provide adequate tissue oxygenation is the first objective. The inability to establish and maintain a patent airway with the associated lack of oxygenation and ventilation is the most common cause of cardiac arrest in children. Therefore, the child's airway is the first priority. Several anatomical features of children affect airway assessment and management. The 10th Advanced Trauma Life Support Guideline divided the essential equipments to 6 groups according to age and body weight. Hereafter, I will try to explain the equipment size according to this classification. Premier means 3 kilogram child, 0 to 6 months, 3.5 kilogram child, 6 to 12 months, 7 kilogram child, 1 to 3 years, 10 and 12 kilogram, and 4 to 7 years, 16 and 18 kilogram child, and 8 to 10 years means 24 and 30 kilogram child. These 6 groups, we will classify the equipments. After the mouth and oropharynx are cleared of secretions and debris, we should administer supplemental oxygen. There is a small technical problem.
Kullandığınız için diğer ekranda kalıyor mouse. O yüzden sola doğru çekerseniz dursun. Sola doğru çekin. Tamam.
Okay. If the patient is unconscious, mechanical methods of maintaining the airway may be necessary. Before attempting to mechanically establish an airway, we should pre-oxygenate the child. So we can use oxygen masks, newborn types for the first 2 groups, and the other 3 groups we can use pediatric size oxygen mask, and for the last group we can use adult size oxygen mask. An oral airway should be inserted only if a child is unconscious, because vomiting is likely to occur if the gag reflex is intact. The practice of inserting the airway backward and rotating it 180 degrees is not recommended for children, since trauma and hemorrhage into soft tissue structures of the oropharynx may occur. You can insert the oral airway gently and directly into oropharynx. Using a tongue blade to depress the tongue may helpful. So we can use infant and infant small types for the first 2 groups. We can use small one, the green one. For the other 2 groups, we can use medium size for 5th group, and for the last group, we can use medium or large size oral airway, the yellow and red color. In this slide, you can see 3 sizes of bag valve masks: infant size, pediatric size, and adult size. We can use infant size pediatric bag valve masks for the first 2 groups. We can use pediatric size for the other 3 groups, and for the last group, we can use either pediatric and adult size bag valve mask for oxygenate the patient. Laryngoscopy. Laryngoscopy is an important part of intubation process. Choosing the appropriate size blade is also really important for pediatric patients. Why? Because the soft tissues of an infant's oropharynx, for example, the tongue and tonsils, are relatively large compared with the tissues in the oral cavity, which may compromise visualization of the larynx. So, a child's larynx is funnel-shaped, allowing secretions to accumulate in the retropharyngeal area. An infant's trachea is approximately 5 centimeters long and grows to 7 centimeters by about 18 months. Failure to appreciate this short length can result in intubation of the right main stem bronchus, inadequate ventilation, and also accidental tube dislodgement, and sometimes mechanical barotrauma. Orotracheal intubation, maybe we can also discuss the sizes of laryngoscope plates. We can use 0 straight for the first group, 1 straight for second, third, and fourth group, 2 straight or curved for the 5th group, and we can use 2 or 3 straight or curved for the last group. And orotracheal intubation is the most reliable means of establishing an airway and administering ventilation to a child. The smallest area of a young child's airway is at cricoid ring, which forms a natural seal around an uncuffed tube, a device that is commonly used in infants because of their anatomic features. However, the use of cuffed tubes, even in toddlers and small children, provides the benefit of improving ventilation and carbon dioxide management, resulting in improved cerebral blood flow. Previous concerns about cuffed endotracheal tube causing tracheal necrosis are no longer relevant due to improvements in the design of the cuffs. Ideally, cuff pressure should be measured as soon as is feasible, and below 30 mm mercury is considered safe. A simple technique to gauge the tube size needed for a specific patient is to approximate the diameter of the child's external nares or the tip of the child's smallest finger and use a tube with a similar diameter. We should ensure that also the ready availability of tubes that are one size larger and one size smaller than the predicted size. The optimal endotracheal tube depth can be calculated as 3 times the appropriate tube size. For example, a number 4 tube would be properly positioned at 12 centimeters from the gums. Yes, let's talk about stylets. Stylets is a device that can facilitate the intubation, and we use stylets in our routinely emergency departments. If we are using a stylet to facilitate intubation, we should ensure that the tip does not extend beyond the end of the tube. So we can use 6 French stylets for the first 4 groups and 14 French stylets for the last 2 groups. What about suction? We can use a color reference chart to determine the appropriate catheter size for suction. Any of these catheters can be used to suck the oropharynx or gastric content or airway. So we can use 8 French suction catheters for the first 3 groups. The 8 French catheters is blue color, and we can use 10 French, it's black color for the 4th group, and we can use 14 French catheters for the 5th and 6th group. It's also dark green color. Circulation is really important for pediatric patients, as Dr. Rosa described, detailed. So, 2 equipments that we can use in circulation: blood pressure cuffs and intravenous catheters are important equipments for the circulation of pediatric patients. Use of the largest intravenous catheter that can readily be inserted with reasonable certainty of success is preferred for pediatric patients. A child's increased physiologic reserve allows for maintenance of systolic blood pressure in the normal range, even in the presence of shock. Up to a 30% decrease in circulating blood volume may be required to manifest a decrease in the child's systolic blood pressure. This can mislead clinicians who are not familiar with the subtle physiologic changes manifested by children in hypovolemic shock. Tachycardia and poor skin perfusion often are the only case to early recognition of hypovolemia and the early initiation of appropriate fluid resuscitation. So we can use 4 types blood pressure cuffs: premier newborn type, newborn infant type for second group, infant or child type for third group, and child type for fourth and fifth group. For the last group, we can use either child and adult size blood pressure cuffs. Changes must be treated by a rapid infusion of both isotonic crystalloid and blood by using an intravenous catheter. Intravenous access in young children with hypovolemia can be a challenging skill, even in the most experienced hands. A peripheral percutaneous route is preferable to establish venous access. If percutaneous access is unsuccessful after 2 attempts, we should consider intraosseous infusion via a bone marrow needle. 18 gauge in infants and 15 gauge in young children. So we can use these types of catheters for pediatric patients. The yellow one, the smallest one, we can give fluids by a flow rate 20 milliliters per minute. And with the green one, the largest for pediatric patients, we can give 90 milliliters per minute fluids by using green intravenous catheter. What are the supplemental equipments? Orogastric, nasogastric tubes, chest tubes, urinary catheters, and cervical collars. We can also use a color reference chart to determine the appropriate tube size. So, 8 French means blue one, 10 French means black one, 12 is white one, and 14 French is green one, orogastric or nasogastric tube. So we can use color reference charts to determine. What about chest tubes? Chest tubes need to be proportionally smaller and are placed into the thoracic cavity by tunneling the tube over the rib above the skin incision site and directing it superiorly and posteriorly along the inside of the chest wall. Tunneling is especially important in children because of their thinner chest wall. The site of chest tube insertion is the same in children as in adults. The 5th intercostal space just anterior to the mid-axillary line. Measurement of urine output and urine-specific gravity is a reliable method of determining the adequacy of volume resuscitation. Insertion of a urinary catheter facilitates accurate measurement of a child's urinary output for patients who receive substantial volume resuscitation. We can use 5-branch feeding for small child for premiers, and we can use 12-branch urinary catheter for 8 to 10 years children. And the last equipment, cervical collar. Fortunately, spinal cord injury in children is uncommon. Only 5% of spinal cord injuries occur in the pediatric age group. For children younger than 10 years of age, motor vehicle crashes most commonly produce these injuries. For children aged 10 to 14, motor vehicles and sporting activities account for an equal number of spinal injuries. So we can use small size pediatric catheters for 3rd and 4th group, also for 5th group, and we can use medium size cervical collars for 8 to 10 years children. And thank you very much for your interest to our presentation and conference.
Thank you very much, Dr. Afshin. Thank you very much for your nice presentation. Is there any question or comments from audience? There is. Please.
Dr. Mustafa from Nizip State Hospital. Thank you so much for your great presentation. To be honest with you, I'm not a clever person to memorize a lot of things, but I want to recommend some important application such as WEKEM, W-E-K-E-M. This is a great application in my opinion, and you can use it and you can choose whatever you want for management your critical care patient. I just want to talk about this one. Yeah.
Thank you for your contribution. Thank you.
Any question? Yes? I have a question to audience. Who resuscitated a newborn patient and started the initial fluid resuscitation? Nobody? Dr. Carlos? I said my question, who resuscitated a newborn patient and started the initial fluid resuscitation to a newborn for avoidance? Anyone? No. A second question, who is the patient less than 3 years old, pediatric? There is one. Only 2, 3, okay. As you see, this is a challenge for us. We are emergency medicine physician, but we are caring the adult patient. When we face such pediatric patient, you know how it is a challenge, and it is difficult for us to resuscitate, to control the airway or start the initial resuscitation for such patient. So we have to learn it. In Turkey, some emergency department, they are caring just traumatic pediatric patients, not normal patients. What about you, Carlos, in your country? Can you care all pediatric patients? Just
available pediatrician and trauma surgeon, but if you go for the general hospital, they don't have only general practitioner, so they call for the anesthesiology or for the other pediatrician. But in some places that they have emergency physician, the emergency physician start to do everything there. And also we have the subspecialization in pediatrician emergency medicine. So in that places, the emergency physician expertise in pediatrician, they take care for the patient about the trauma and no trauma.
Thank you. Is there anybody who intubated a newborn? Newborn? You intubated? Newborn. Nice. Okay. Do you have an extra question, or what about your experience, your practice?
Yeah, I mean, I think taking care of pediatric patients is certainly one of the most challenging things we do. In my hospital, we do see newborns. We sometimes end up having women that deliver in the emergency department, and then of course you have to resuscitate from, day one, minute one of birth. And one of the challenges that we do have is that we have a separation of our pediatric emergency area from the adult emergency area, and not all of the sizes of things are stocked everywhere. And so, definitely I think that these are challenges that we run into, but like emergency medicine doctors everywhere, we do what we can with what we have. I think that's our job. Yeah.
And I know the position in Turkey, but I'm wondering about our guest. Which country has emergency medicine pediatric training? Emergency medicine pediatric training. Especially this question for foreigner guest. Who has? You. Microphone, can you give it, please? We have time. We
started the emergency medicine in pediatric 20 years ago in Mexico, and we have pediatrician plus subspecialty in emergency medicine. And in the big hospital, they treat the patient exactly right there in the ER, but they are specialized in emergency medicine in pediatrician. If they want to board certify, now we have a chapter special for emergency physician, pediatrician for board certified.
You have. Okay. Dr. Garcia, do you have? No.
We have two different paths to emergency medicine in the United States for pediatrics. You can do a pediatric residency.
Fellowship or?
Yeah, you can do a pediatric residency and then do a fellowship in emergency medicine for pediatrics, and then you only practice pediatrics.
It is not mandatory to be a pediatrician.
No, you can also just do an emergency medicine residency and you are trained to take care of pediatric patients also. But if you are a pediatrician, you have to do a fellowship in emergency medicine for pediatrics.
Okay. Okay, any question or comment for this section? Okay. The next speaker, unfortunately, he's not here. He was set up and sent his apologies, Dr. Apostolos from Greek. He's not here now. So we are going to finish this section. Thank you very much for your participation. You are welcome.
Kongremizin ilk uydu sempozyumunda bir aradayız. Hepinize bize katıldığınızdan dolayı teşekkür ediyorum. Acil tıbbın en önemli başvuru semptomlarından biri alerjiler. Özellikle bahar aylarında da bunun daha çok karşımıza çıktığını biliyorsunuz. Yapılan araştırmalarda alerjik şikayetlerle başvuran hasta sayısının oldukça yüksek bir oranda olduğunu göstermişler. Siz de biliyorsunuz tabii ki deneyimlerinizden. Bu yüzden bu konuda bilgilerimizi tazelemeye ihtiyacımız var. Ayrıca hani yeni bir yol haritası çizmemiz gerekiyor mu? Yenilikler nedir? Bunları incelemek amaçlı çok değerli yönetim kurulu üyemiz Profesör Doktor Hakan Oğuztürk'ü bu konudaki bilgilerini bizimle paylaşmak üzere sahneye davet ediyorum.
Herkese merhaba. Uluslararası Acil Tıp Kongresi'nin bu ikinci günündeki birinci oturumun sonundaki uydu sempozyumda sizlere alerji ile ilgili temel bilgilerin dışında yeni yol haritası konusunda da bilgi vermeye çalışacağım. Şimdi alerji dediğimiz zaman iki ana konu üzerinde ben durmaya çalışacağım. Bunlardan bir tanesi saman nezlesi, diğeri ise ürtiker. Bu iki problem dünyanın her yerinde, her toplumda sıklıkla görülen önemli bir halk sağlığı sorunu oluşturuyor. Bunlardan ilki saman nezlesi. Klasik, ilk tanımlamayı 1920'li yıllarda yapmışlar. Kardinal bulguları burun tıkanıklığı, burunda akıntı ve hapşırık. Bu triyat bu problem için ilk başta 1900'lü yılların başlarında tanımlanmıştı. Fakat daha sonra başka bilgiler de bu probleme eklenmişti. Gözlerde kaşıntı gibi şikayetlerle kendini gösteren, klinikte alerjik rinit veya alerjik rinokonjüktivit olarak tanımladığımız tip 1 alerjik hastalıklarla ilgili klinik semptomları tanımlamak için kullanılan bir terimdir. Tüm ülkelerde görülüyor dedik. Gelişmişlikle veya gelişmemişlikle direkt bağlantısı yok. Tüm etnik gruplarda ve tüm yaştaki insanlarda bu problem görülebiliyor. Dünya üzerinde yaklaşık 800 milyon kişinin bu problemle birlikte olduğu söylenmekte. Slaytta da görüldüğü gibi dünyanın muhtelif coğrafyalarında %10 ile 30 arasında değişen bir rakamsal range var. Amerika Birleşik Devletleri'nde de kronik hastalıklar arasında 6. sırada olduğu ifade edilmiş. Yani görülme oranının oldukça yüksek olduğu bir sağlık problemini biz şu an görmekteyiz. Peki bu problemde olay ne? Bir enflamasyon olayı durumu söz konusu. Nazal mukozanın hücresel enflamasyonu ile karakterize immunoglobulin E'ye bağlı bir alerjik reaksiyon sonucunda ortaya çıkan bir hastalık. Bu da diğer tanımı. Yani farklı tanımlar var fakat bir enflamasyon ve ona bağlı immunoglobulin E'ye bağlı alerjik reaksiyon sonucunda ortaya çıkan bir problemden bahsediyoruz. İki faz var. Erken faz ve geç faz. Fakat klinik bulgular özellikle geç faz sırasında ortaya çıkıyor. Ne oluyor? Mast hücresi yüzeyindeki immunoglobulin E reseptörlerine alerjen ve alerjene spesifik olan immunoglobulin E bağlanıyor ve bunun sonucunda histamin, prostaglandin ve lökotrienlerin salgılanması gerçekleşiyor. Klinik bulguların daha çok görüldüğü geç faz bölümünde ise yine eozinofil, nötrofil ve bazofillerin infiltrasyonu sonrasında çeşitli sitokinler, kemokinler, adezyon moleküllerinin salınım durumu söz konusu. Alerjik rinitin sınıflandırılmasında arkadaşlar en sık kullanılanlardan bir tanesi iki alt grupta oluşturulmuş olanı. Bunlardan birincisi mevsimsel, diğeri de perirenal denilen yıl boyu problemle karşılaşma durumu ile karakterize alt grup. Şimdi tabii ki yani bu iki grup oluşturulmuş ama keskin bir ayrım durumu söz konusu değil. Yılın herhangi bir zamanında veya mevsimsel olan durumda yine farklı sebeplere bağlı problemler alerjik rinit oluşturabiliyor. Mevsimsel ilkbahar ve yaz mevsimlerinde ortaya çıkıyor. Polen ve küf alerjenlerini örnek olarak gösterebiliyoruz. Devamlı yılın her ayında görülme durumu olan yıl boyu alt grubunda ise ev tozu akarları, akarcıkları, mite dediğimiz canlılar özellikle etiyolojide önemli bir oran oluşturmakta. Yine küfler, hamam böceği ve ev hayvanı alerjenleri de yine bu alt grubu oluşturmakta. İkinci bir sınıflandırma daha var arkadaşlar. Bu da intermittent semptomlara göre veya persistent semptomlara göre alt gruplara ayırma durumu. Alerjik rinitte eğer intermittent bir durum söz konusu ise 4 günden haftada 4 günden daha az bu problemle karşı karşıya kalma durumu veya 4 haftadan daha az bu sorunu yaşama durumu söz konusu. Tabii ki intermittentta durum biraz daha hafif seyretmekte ve bu problemle karşı karşıya kalmış olan kişilerde hafif uyku durumunda herhangi bir problem yok. Günlük aktiviteler, iş okul aktivitelerinde ve semptomlarda şiddetlenme durumu söz konusu değil. Buna karşın persistent semptomların olduğu durumda ise haftada 4 günden daha fazla veya 4 haftadan daha uzun olan bir durum söz konusu şikayetlere maruziyet açısından ve bunun dışında da orta ve ağır uyku, günlük aktiviteler, iş ve okul aktiviteleri ve şiddetli semptomların varlığı, aktivitelerin bozulması durumu veya rahat bir şekilde günlük aktivitelerini ifade etmede kısıtlılık durumu söz konusu olabilmekte persistent semptomlar. Bu anlattıklarımdan da görüldüğü üzere arkadaşlar bu problemler insanın günlük sosyal aktivitelerini yapmada ciddi anlamda soruna sebebiyet veriyor. Yaşam aktivitesini ciddi anlamda kısıtlıyor. Öyleyse bu problemin çözümü için öncelikle bu problemin tanısını netleştirmekte, diyagnozda bir kesinlik sağlamakta fayda var diye düşünüyoruz. Peki ne yapacağız? Alerjik tanısında en önemli adımlardan bir tanesi arkadaşlar aile öyküsü. Ve bunun dışında hastaya daha önce uygulanmış olan teşhis ve tedaviyi içeren ayrıntılı anamnez. Tıpta zaten her branşta net olarak konuşulan bir konu var. O da şu: iyi bir hekim, iyi bir öykü, iyi bir anamnez almışsa her problemin %50 tanısını rahatlıkla koyabilir diye bu efsaneleşmiş olan cümleyi tekrar hatırlatmakta da fayda görüyorum. Alerjik rinitte de öyle. Öyküyü aldığımız zaman arkadaşlar, ayrıntılı anemnezi aldığımız zaman tanısal anlamda büyük bir mesafeye kat etmiş olmaktayız. Hastanın yaşı, şikayetlerinin hangi ortamlarda ortaya çıktığı ve aile hekim hikayesi sorgulanmalı. Bir de arkadaşlar burun içindeki sekresyonun rengi ve miktarına dikkat edilmelidir. Genellikle berrak ve sulu akıntı alerjik reaksiyon, alerjik rinit lehine bir tanı koymanızı sağlamaktadır. En sık kullanılan testler cilt testleri ve serum spesifik immunoglobulin veya total immunoglobulin E. Şimdi normalde 150 ünitelik bir rakam normal değeri oluşturmakta. Fakat bu tanısal testlerde bu rakamın bazen tanı koymada sıkıntı oluşturduğunu söyleyebiliriz. Tabii ki ekstraordinary paraziter hastalıklarda bu oran artabilir, alerjik reaksiyon dışında veya normalde bu problemle karşı karşıya kalmış olan kişilerde de her zaman %100 oranında bu değeri yüksek göremeyebiliriz. Preventif mekanizmayı ilk başta devreye sokmak gerekiyor tedaviye başlamadan önce. Dedik polenler önemli bir risk oluşturmakta. Bu anlamda açık havada uzun süre polen mevsiminde bu probleme sahip olan kişilerin dolaşmaması gerekiyor. Evlerin havalandırılması da yine akşam saatlerinde gerçekleştirilmeli. Ev tozu akarları. Mite dediğimiz bu mikro canlılar parazit dünyasının en önemli unsurlarından bir tanesi ve herkesin ekonomik durumundan bağımsız olarak evlerinde rahatlıkla yaşamlarını idame ettirebilecek olan canlılardandır bu mite'lar. Özellikle yatak odalarında, halıların kenarlarında, yastıkların kıvrımlarında çok rahat bir şekilde yaşamlarını idame ettirebilirler ve alerjik bünyede olan genotip yatkınlığı olan kişilerde de bu tür problemleri çok rahatlıkla gerçekleştirebilmektedirler. Bu anlamda evlerdeki nem oranını %50'nin altında tutmak, yerlerin halı ile kaplanmaması gibi basit tedbirlere başvurulabilir. Nevresim takımları da 60 santigrat derece ısıda yıkanmalı. Akarisit, HEPA filtreleri ve akar geçirmeyen yatak kılıfları doktor mutlaka önerilmişse kullanılmalıdır. Bunlar basit temel mite'lardan korunma yöntemleri. Bunları uygulayarak bu kişilerin mevsimsel ataklardan korunması daha da başarılı bir orana yükseltilebiliyor. Küfler ve evcil hayvanlar, bunlar da yine sıkıntı oluşturan önemli unsurlardan. Bunlarda da yine evlerin sık havalandırılması, halı ile kaplanmaması, özellikle banyo ve küf oluşumuna uygun ortamların kontrol edilmesi de preventif mekanizmada önemli maddeler. Evcil hayvanların evde beslenmesi de yine riski oluşturmakta. Bilhassa yatak odasına alınmaması ve sık yıkanması gibi yine önleyici tedbirler yapılabilir. Bizi ilgilendiren aşaması ise preventif mekanizmadan sonra farmakolojik tedavi arkadaşlar. Salondaki herkese sorsak antihistaminikleri kesinlikle ilk planda düşündüğünü ifade edecektir. Evet, antihistaminiklerin birinci kuşak ve ikinci kuşaklarını bildiğiniz üzere biz birçok rahatsızlıkta kullanıyoruz ama bu problemlerde birinci kuşak antihistaminiklerin genel olarak ilk basamak tedavisinde textbooklarda ve literatürde önerilmediğini rahatlıkla görmekteyiz. İkinci kuşak antihistaminikler ise daha az yan etkiye sahip olmalarından dolayı ve minimal veya sıfıra yakın sedasyona sahip olmalarından dolayı tercih edilebilmekte. Evet, bu tedavinin diğer elemanları ise nazal ve sistemik steroidler, dekonjestanlar, lökotrien antagonistleri, mast hücre stabilizatörleri ve immünoterapi gibi alt gruplarda görülmekte. Oral kortikosteroidler duruma göre düşünülebilir ama bu aşamada damardan steroid verilmesi gibi bir tedavi yaklaşımı önerilmemektedir. İkinci konu ürtiker. Buna da kısaca değineceğim arkadaşlar. Hipokrat zamanından beri bilinen deri ve mukozaları tutan ürtika denilen kaşıntılı papül ve plaklarla seyreden bir problem ürtiker. Bu lezyonların deriden kabarık basmakla olan, etrafı kızarık, sınırları belirgin, kaşıntılı, döküntülü olduğunu söyleyebiliriz. Kısa sürüyor ve bu karakteristik özelliği ise bu döküntülerin bir günden fazla sürmemesi. Daha sonra kayboluyor veya kaybolmaya yüz tuttuğu anda vücudun başka yerlerinde de tekrar benzer lezyonlar ortaya çıkıyor. Karakteristik özelliği bu ürtikerin. Oldukça sık görülüyor. Hatta bazı textbooklarda diyor ki her insan yaşamı boyunca kesinlikle bu problemle karşı karşıya kalabilir. Ortalama da veriyorlar. 2 veya 4 defa her insan bu problemle muhatap olabiliyor deniliyor. Toplumdaki kişilerin de yine %20'si 30'unun da yaşamı boyunca en az bir kez ürtiker geçirdiği şeklinde başka bir kaynak da var. Önemli bir dermatolojik problem. Akut ve kronik anlamda değerlendirdiğimiz bu problemin kronik olan grubunda ise yine %0,5 ile 1 arasında bir tüm yaşam boyunca görülme durumu söz konusu. Evet, bu benim çalıştığım hastaneden bir görüntü. Dedik, dünyanın her tarafında yine alerjik rinitte olduğu gibi ekonomik gelişmişlikle doğru orantılı olmayacak bir şekilde rastlanabiliyor. Şu coğrafyada daha fazla, şu coğrafyada daha az diye bir genelleme kesinlikle yapılamamıştır. Ve ırk ayrımı da ürtiker konusunda gündeme getirilmiyor. Akut ürtiker çocuk ve gençlerde sık görülmesine rağmen kronik ürtiker orta yaşlı kadınlarda daha sık görülüyor. Kronik ürtikerin akut ürtikere göre 3 kat daha fazla karşımıza çıktığını söyleyebiliriz. Cinsiyette ise 2'ye 1 oranında kadın hakimiyeti söz konusu. 3 önemli grup var. Akut ürtiker, akut spontan ürtiker ve kronik ürtiker. Kronik ürtikerin de 2 alt grubu var arkadaşlar. Kronik spontan ürtiker. Bunu da indiklenebilir alt gruplarından hepimizin bildiği gibi fiziksel bir maruziyete bağlı olarak ortaya çıkan subgrubu var. İşte solar ürtiker, basınç ürtikeri, semptomatik termografizm, soğukla indiklenen ürtiker, sıcakla indiklenen ürtiker, vibrasyonla indiklenen anjiödem gibi. Kolinerjik ürtiker ve kontak ürtiker de diğer kronik ürtikerin indiklenebilir alt grubunu oluşturuyor. Fakat yine başka bir gruplandırma yapacak olursak 6 haftadan kısa süren problemler arkadaşlar akut, uzun süren problemler ise kronik ürtiker olarak kabul görmekte. Akut ürtikerde sebep iyi bir anamnezde çoğunlukla bulunabiliyor ama kronik ürtikerde de az önce söylediğimiz gibi etiyolojik neden, idiopatik bir mekanizmadan dolayı çok fazla belirlenemeyebiliyor. Akut ürtikerdeki en önemli etiyolojik nedenler ilaçlar, gıdalar ve enfeksiyonlardır. Birçok gıda hiç tahmin edilmeyecek bir anda insanlarda bu problemi oluşturabiliyor. İlaçları ise yine geniş bir spektruma sahip. Non-steroid anti-inflamatuarlardan antibiyotiklere kadar, basit analjeziklerden diğer gruplara kadar arkadaşlar bu problemi oluşturabilecek ilaçlardan bahsedebiliriz. Antibiyotikler de yine penisilinler, sülfanamitler başta olmak üzere bu problemi oluşturabilmekte. Enfeksiyonlarda da yine geniş bir spektrum söz konusu. Basit bir diş absesinden, üst solunum yolu absesinden, idrar yolu enfeksiyonuna kadar birçok enfeksiyon bu problemin ortaya çıkmasına neden olabiliyor. Az önce de ifade ettiğim gibi kronik spontan ürtikerde de sebep konusunda bir netlik oluşmadığından dolayı bizim anamnez konusunda tanısal anlamda dikkatli olmamız gerekmekte. Histaminin etkisiyle ortaya çıkıyor bu problem arkadaşlar. Histamin hepimizin de bildiği gibi damarlarda genişlemeye, damar duvarlarında geçirgenliğin artmasına ve bu geçirgenliğin artmasından sonra damar dışına bir çıkışa sebebiyet vermekte ve bunun sonucunda da cildimizde şişlikler oluşturmakta ve kızarıklıklar oluşmakta. Eğer sıvı cilt altına oluyorsa mukozal bir problem de birlikte olduğundan dolayı hepimizin bildiği anjiyoödem problemini ortaya çıkarmakta. Anjiyoödem, cilt altı dokusunun göz çevresi, ağız ve genital bölgelerimizde daha gevşek olmasından dolayı bu bölgelerde diğer bölgelere göre daha fazla oranda görülebilmekte. Akut ertükerde arkadaşlar tanısal anlamda çok fazla bir derinlemesine araştırmaya gerek bulunmamakta. Kronik ürtikerde ise sedimentasyon, tam kan sayımı, CRP, tam idrar tahlili istenebilir. Bunların hepsini bir arada isteyeceksiniz diye bir durum söz konusu değil. Detaylı analize göre seçiciliği açığa çıkarabilirsiniz. Onun dışında bizim ayrıcı tanı önemli arkadaşlar. Ayrıcı tanıda herediter anjiyoödem ve otoinflamatuar hastalıklarında atlanmaması gerekiyor. Ürtikerdeki en önemli problemlerden bir tanesi başta da ifade ettiğim gibi kaşıntı arkadaşlar. Otoinflamatuar hastalıklarda benzer lezyonlar olmasına rağmen kaşıntılı bir süreç ürtikere göre daha nadir görülebilmekte. Yani iş anamnezde bitiyor. Ürtikerin tedavisinde de yine preventif mekanizma ile birlikte arkadaşlar semptomların giderilmesi için acil tedavi durumunu biz aktive etmek durumundayız. İlaçların, gıdaların ve stres gibi ürtikeri alevlendirebilecek etmenlerin uzaklaştırılması ve sakınılması tüm hastalara zaten önerilmekte. Bu can sıkıcı problemin çözümünde arkadaşlar genel cümleleri yine hatırlamakta fayda görüyorum. Hastanın eğitimi ve iyi bir diyaloğun, stres ve fiziksel egzersizlerden kaçınma, sıcak ortamdan kaçınma, uyku düzeninin sağlanması ve yeterli bir süre içerisinde gerçekleşmesi, aşırı yorgunluktan sakınma, dar ve sıkı giysiler giymeme, alkol ve riskli olduğu biliniyorsa ACE inhibitörlerini, aspirin ve diğer NSAID'lerin kullanılmaması yönünde bir mekanizmanın geliştirilmesi gerekiyor. Akut ürtiker tedavisinde oral antihistaminiklerin 3 hafta kullanımı gibi bir durum söz konusu. Bu 3 hafta kullanım olayı şikayetlerin giderildi artık ben keseyim şeklindeki bir sürece girmesi maalesef arkadaşlar tedavi anlamında sıkıntılara yol açmakta. Eğer biz durumun daha şiddetli olduğunu gözlemlemiş isek tedaviye steroidleri de ekleyebiliyoruz. Daha şiddetli ve anjiyoödemin mukozal tutulumunun da olduğunu görmüş isek arkadaşlar klasik yine o probleme ait tedavimizi aktive ediyoruz. Adrenalin, steroid, antihistaminik veya anaflaksi de varsa o açıdan da hastanın dikkat edilir bir şekilde değerlendirilmesi gerekiyor. Diğer grup olan kronik ürtikerde ise arkadaşlar ikinci kuşak antihistaminikleri biz ilk planda aklımıza getiriyoruz. 2 hafta sonra semptomlar sebat ediyorsa ikinci kuşak antihistaminiklerde bir doz artımını sağlıyoruz. 4 kata çıkarıyoruz. Daha sonraki aşamada yine 1-4 haftalık bir süreçte semptomlar sebat ediyorsa daha farklı ilaçları aktive ediyoruz. Omalizumab, siklosporina ve lökotriene antagonistlerini ekleyebiliyoruz. Akut ataklar sırasında ise kısa süreli sistemik kortikosteroid de denenebilir diyoruz. Ama burada vurgulamak istediğim husus şu, ikinci kuşak antihistaminikler tedavinin başlangıç aşamasında bizim aklımıza getirmemiz gereken ilaç grupları. İşte bu gruptan bir tanesi de blastin arkadaşlar. Sedasyona yol açmayan yeni kuşak, ikinci kuşak bir reseptör antagonisti olan preparat. Blastinin piperidin grubuna ait bir antihistaminik olduğunu söylüyoruz. Evet, bu da bu ajanın kimyasal yapısı. Bu ikinci kuşak antihistaminik bilastinin etkinliği ile ilgili birçok çalışma yapılmış. Literatürden araştırdığım kadarıyla bu çalışmalardan birkaçını sizinle paylaşmak istiyorum. Reseptöre afinitesi setirizinden 3 kat daha fazla, feksofenadinden 6 kat daha yüksek olan bir kimyasal ajan. Mix, hidrojen 1 antagonisti olarak davranmasına rağmen güçlü ve spesifik bir antihistaminik etki gösteriyor bu ajan. Bilastinin yine interleukin 4 ve tümör nekrozis faktör alfa gibi pro-inflamatuar sitokinlerin salınımını azaltan anti-inflamatuar bir özelliği olduğuna dair de yayınlar yapılmış durumda. Yine başka bir çalışmada, ratlarda yapılan başka bir çalışmada histaminle uyarılan endotel permeabilitesinde, mikrovasküler ekstravazasyonda ve bronş düz kaslarında gevşeme ile bronkospazmın azaltılmasında setirizine göre 11 kat daha etkili olduğu gösterilmiştir. Setirizine göre lezyonların gerilemesinde ilk 1,5 saatte daha hızlı etkinlik gösterdiği bildirilmiştir. Bu ilacı kullanırken daha fazla fayda sağlanabilmesi için kriterimiz aç olarak kullanılması. Yemeklerden 1 saat, 2 saat önce veya 1 saat önce veya yemeklerden 2 saat sonra kullanımı ve aç karna olduğumuz zaman yakın bir zaman aralığında da yine C vitaminli preparatların alınmaması ilaç etkinlik düzeyinin sağlanması açısından önem arz ediyor. Yaklaşık 1 saat sonra maksimum plazma konsantrasyonuna ulaşabiliyor bu ilaç. Etken madde. Oral biyoyararlılığı ortalama %60 ve önemli bir özelliği de yaklaşık olarak arkadaşlar %90'lık bir durumunun yüzdesinin metabolize olmadığı, karaciğer stokrom P450 enzim sistemi üzerinden herhangi bir etki göstermediği, ketokonazol, eritromisin ya da diltiazinle birlikte alındığında bilastin dozunda değişikliğe gerekli olmadığına ait de literatürde bilgiler mevcut. %95'i vücuttan atılıyor, dışkı ve idrarla atılma durumu söz konusu. Bu cümleye dikkat çekiyorum. Ortalama yarı ömrü 14,5 saat. Yine yapılan bir faz 2 çalışmasında arkadaşlar 20 mg blastinin alerjik rinitli hastalarda 10 mg setirizin veya 120 mg feksofenadine göre 1 saatte göz semptomlarını azaltmada daha etkin olduğu ve alımdan 26 saat sonra dahi bu etkinliğinin devam ettiğini bildirmişler. Bilastine santral sinir sistemi etkileri yönünden iyi bir güvenlik profili sahip olduğu söylenebiliyor. Setirizinin aksine alkol ve lorazepamın santral sinir sistemi depresan etkilerini de artırmadığı ifade edilmekte. Şimdi tabii ki bir ilaç kullanıldığı zaman kardiyovasküler sistem ve santral sinir sistemi etkinliği konusunda da araştırmaların ve netliğin sağlanması gerekiyor. Bu anlamda bu etken madde ile ilgili terapötik dozlardan daha yüksek dozlarda kullanımında dahi herhangi bir EKG problemi oluşturma konusunda sıkıntı oluşturulmadığı ifade edilmiştir. Yine EKG'de kalp atış hızında veya sistolik ve diastolik kan basıncında da klinik olarak bir değişiklik saptanmadığı söylenilmekte. Bilastin sağlıklı kişilerde tüm dozlarda iyi tolere edilebilmekte. Tabii ki her ilacın bir yan etki durumu söz konusu ama bunlarda şiddetli veya hafif olma durumu bizim için önem arz etmekte. En sık görülen yan etkiler günde bir kez 10 mg alan, setirizin alan hastalara göre daha az bildirilen baş ağrısı, uyku hali ve yorgunluktur. Yapılan başka bir çalışmada randomize çift kör plasebo kontrollü bir çalışmada 20 sağlıklı gönüllü art arda bir hafta boyunca tekrarlayan dozlarda 20-40 ve 80 mg dozlarda birinci jenerasyon antihistaminik hidroksizin alıyor ve 40 miligrama kadar subjektif sedasyon raporu veriliyor bu ilacın bu sürede kullanımı ile ilgili. Ama Blastin'de ise bu problemin olmadığını, plaseboya göre dahi daha bir rahatlık olduğu ifade ediliyor. Yine benzer bir şekilde Blastin'in 40 miligrama kadar tek veya tekrarlayan dozlarda alınması durumunda dahi bir sürüş bozukluğu, araba kullanma durumunda herhangi bir sürüş bozukluğu oluşmadığı ifade edilmiştir. Genel olarak yan etkilerde plasebo ile eşdeğer bir durum söz konusu. Cetirizine göre yorgunluk ve uyku hali daha az oluşmakta bu ajanda. Yine çim alerjisi olan alerjik rinitli hastalarda Blastin'in fexofenadinden daha etkili ve en az cetirizin kadar etkili olduğu gösterilmiştir. Yine desloratadin ile karşılaştırılabilir bir çalışmada da daha anlamlı bir etkisi olduğu ifade edilmiştir. Birçok çalışma yapılmış arkadaşlar. Derlemelerden meta analizlere veya olgu sunumlarından makale araştırmalarına kadar bu yeni kuşak antihistaminikle ilgili olan çalışmalarda birçok detaylı veriye rahatlıkla ulaşabiliyorsunuz. Bunlardan birkaç örnek. İşte rinokonjüktivit ve ürtikerdeki tedavisiyle ilgili ana iki problem endikasyonu ile ilgili ana iki problem bunlar. Alerjik rinokonjüktivit ve ürtiker. Sonuç olarak arkadaşlar günde bir kez 20 mg Blastin'in alerjik rinitin tüm nazal ve oküler semptomlarını ve alerjik hastalıklarda önemli bir sonuç olan, başta da ifade etmiştik, yaşam kalitesini ciddi manada negatif anlamda etkiliyor demiştik. Bu yaşam kalitesini artırdığını ifade edebiliriz. Blastin'in alerjik rinit tedavisinde kullanılan ilaçlar için mevcut ARIA kriterlerini de karşıladığı sonucuna meta-analizlerde rastlamaktayız. Ürtiker semptomlarında da Blastin'in etkinliğinin günde bir kez 20 mg Blastin tedavisinin semptomların düzelmesinde ve kronik ürtikerde de yine yaşam kalitesinin artırılmasında önemli bir etkinliği olduğu sonucuna varılmıştır. Mevcut uluslararası rehberler bundan dolayı alerjik rinit ve ürtiker için ikinci nesil antihistaminiklerin kullanılmasını tavsiye etmekte arkadaşlar. Yaşam kalitesiyle ilgili veriyi az önce ifade etmiştim. Bu anlamda bu etken maddeye ait olan preparatı da sizlere hatırlatmak istiyorum. Bilaksen deride kızarıklık ve şişlik ve kaşıntı gibi belirtileri içeren, halk arasında da kurdeşen dediğimiz ürtikerin ve nedeni belli olmayan kronik ürtikerin tedavisinde, buna ek olarak boğaz, burun ve gözlerde kaşıntı, hapşırma, gözlerde sulanma, burun tıkanıklığı veya burun akıntısı gibi belirtileri içeren mevsimlere bağlı alerjik nezlerin tedavisinde kullanılmaktadır. 20 mg'lık tabletleri olan bu preparatın etken maddesi az önce de ifade ettiğimiz Blastin. Histaminin yol açtığı az önce de bahsettiğim bu problemlerin, alerjik belirtilerin tedavisinde etkili bir antihistaminik ilaç. 12 yaş ve üstü çocuklarda ve yetişkinlerde günlük önerilen dozu günde bir defa bir tablet arkadaşlar. Yaşlı hastalarda da ciddi bir sistemik problemi yok ise önerilen doz aynı düzeyde. Hatta böbrek yetmezliği olan hastalarda dahi ek bir doz ayarlama durumunun gerekli olmadığı ifade edilmekte. Sonuç olarak arkadaşlar, alerjik problemler hastanın yaşam kalitesini etkileyen ciddi sorunlar. Dünyanın her yerinde, her ırkta oldukça fazla bir yüzdeyle karşımıza çıkıyor demiştik. Bu anlamda arkadaşlar dünya üzerinde de 1 milyara yakın insanın bu problemlerle maruziyeti durumunu da ifade ettikten sonra çözümsel anlamda iyi bir hasta-doktor iletişiminin takip sürecinde olması gerektiğini, yeni ilaç tedavilerinin şu anki tedavi seçeneklerinin semptomatik yaklaşımda fayda gösterdiğini ifade ederek bizim yine hasta endeksli tedavi yaklaşımlarını en akılcı şekilde uygulamamız gerektiğini ifade edebiliyoruz. Ben dinlediğiniz için çok teşekkür ediyorum. Katkı veya sorusu olan var ise dinleyebiliriz.
Evet, çok teşekkürler Hakan Hocam. Bir soru katkı varsa alabiliriz arkadaşlar. Evet, ilk uydu sempozyumumuz bu. Bizim Hakan Hoca'nın da belirttiği gibi aslında alerji rutin kullandığımız genel acil semptomları içinde yer olan bir şey ve bu herhalde antialerjik ilaç verirken hepimize aklına şu soru geliyor: sedasyon yapar mı? İşi ne? Değil mi? Soruyoruz. İş durumu ne vesaire. Dolayısıyla bu konuda yeni bir nefes olduğunu görmüş olduk. Evet Hakan Bey buyurun.
Hocam adaşıma teşekkür ediyorum. Çok güzel bir sunum oldu öncelikle. Yeni görevinde de başarılar diliyorum. Allah yardımcısı olsun. Ben çok kısa bir katkıda bulunmak istiyorum kendisine ve salondaki arkadaşlara. Şimdi ben Gaziantep Üniversitesi bünyesinde Teknopark denilen bir yerde Farmagen Araştırma Merkezi var, İKU. Burada biyoeşdeğerlilik ve faz 3 çalışmaları yapılıyor. Genelde biyoeşdeğerlilik daha fazla. Ben de burada hastaların EKG'lerine bakıyorum, danışmanlıklarını yapıyorum. Genelde her çalışma için 50-60 arası hasta alınıyor. Genç erkek bireyler bunlar. Sağlıklı, tamamen sağlıklı. Taramalarını yapıyoruz ve hiçbir hastalığı yoksa onları çalışmaya dahil ediyoruz. Bazen işte bu antihistaminikler deyince aklıma o geldi. Antihistaminikler, antimantar ilaçlar, antiaritmiklerin %75'i, bunların hepsi QT, EKG'de QT'yi uzatıyor. O çalışmalarda bize diyorlar ki işte QT'nin normal değeri 440 ise siz bunu bir 10 düşürün, 430 ve üzerini almayın diyorlar. Çünkü vereceğimiz ilaç da QT seviyesini ve düzeyini uzattığı için sıkıntı olabilir diye ben 60'a yakın hastanın 2 tanesini, 3 tanesini eliyorum. Niye? Bunların QT'leri hep yüksek geliyor, uzun geliyor. İşte biz de bunları veriyoruz, körlemeye veriyoruz değil mi? Mesela EKG çekip antihistaminik veren var mı içimizde acaba? Veya antihistaminik vermeden önce EKG'sine bakan var mı? Sanmıyorum yani. O nedenle benim naçizane değerlendirmem şu yönde olacak. Özellikle bu QT, konjenital QT hastalıkları var. Onları hiç katmıyorum bile zaten hesaba. QT'yi uzatan ilaçları hastalara reçete ederken bir nebze bunları düşünmek gerekiyor. Belki de ailede hikayesi olanlarda erken ölümler sorgulanması gerekiyor. Çünkü artık öyle bir seviyeye geldi ki insanlar neresinden tutsa bizi şikayet etmeye çalışıyorlar. Yani bir ucunu tutuyorlar ve bizi şikayet ediyorlar ve muhteşem paralar kazanıyorlar. O nedenle bence bunlara dikkat etmek gerekiyor. Naçizane benim görüşüm bu yönde. Teşekkür ediyorum.
Teşekkürler. Başka soru katkı var mı? Yani salon büyük olduğu için göremiyorum ama herhalde gördüğüm kadarıyla yok. Bir 10-15 dakikalık aramız var. 11.30'da tekrar buradayız arkadaşlar. Daha doğrusu program devam ediyor. 10 dakika aramız.
I was crossing the street in front of my house, and my assistant chief called me on my mobile phone. And I thought, why is she calling? For once I'm late, and she's on my back. So I was a bit irritated, and I picked up the phone quickly, and I said, okay. I said, what is it? And she said, are you coming in today? And that even irritated me. I said, what do you mean? Of course I'm coming in today. I come in every day. And I thought, just because I'm late, she's on my back. And she said, there's been an explosion at the airport. And because I was a bit irritated, I really answered back to her, there was no explosion at the airport. It was either a plane crash or bombing. And if it were a plane crash, it would have been said there was a plane crash. I'll be right in. So I started walking a bit faster, and then I started running, actually, because I thought, oh my God, what's going on? I arrived in the department, we started scaling up, and I could see the fear in the eyes of my colleagues. And I thought, I must be the example of calm here. And at the same time, I thought, this is a new department. We're just getting used to moving patients from here to there, and now this happens. How many patients would there be? How severe would they be? How long will this last? Do we have enough staff? And were we really prepared? Sure, we did tests and all this, but were we really prepared? This is the real test. And I didn't have too much time to think of that either, because at about 9:15, on the television in one of the patient rooms in my department, smoke was coming out of 2 metro stations in Brussels. And that was the moment where I was terrified. I thought to myself, my world is being attacked. My city is being attacked. My home. But I knew at the same time, I really had to be the stay for my team. So I just put myself into a sort of organizational mode, focused only on practical aspects of what had to be done, and we began receiving patients. Well, I was quite proud of my team, actually, because they were working on very difficult situations. But I saw the fear, and I saw the stress. And, you know, one of the policemen, they were going from emergency department to emergency department. One of the policemen came in, who I know quite well, and said to me, hey, it's really calm in your department. And I could tell I was stressed, because normally I'm not very sharp with the police officers. And I said to him, I said, well, what do you think? I said, we don't have time to be running around screaming. Because he had said to me, in the other departments where he had visited, people were yelling, people were running around, and he said, in your department, it's so calm. Now, we received the largest number of patients from the metro station, so that does not mean that we had 2 patients in the hospital, in my department. And it was at that time where I thought, we're calm, however, we're accumulating stress. And this is just not going to go away. So I thought, what can I do? It's not with a cup of coffee, even though this one looks not so bad, that we could just sit down, grab a cup, talk a bit, and go home. It would have to take something a bit more, something organized, something structured. More or less what I imagine a board meeting to be, with the CEO and all the different operating chiefs. And I thought, I have to do it? I'm the chief. At the same time, I'm no CEO. I'd never had to address this sort of significant event before. And so the first thing that came to my mind was that horrible word that evokes a lot, debrief. And so I said, yeah, it has to be done. Because why do we debrief? To avoid errors and to maintain wellness amongst our team. So I thought, where to go from here? Well, I may surprise you with this next slide, because I used, if you want, and again, this is very important, I'm explaining to you my experience. I am not giving a recommendation. This is not evidence-based. It is a, if you want, a case study. And what I used as a basis, well, I can't, well, what I used is the critical incident stressing debriefing, okay? Why? Because it was structured. And I thought this will be helpful for me. I contacted the Department of Psychiatry, talked with the psychologists, and said, hey, look, I've never done this sort of debrief. This is what I'm thinking. What do you think? We discussed it, and we came about with a compromise. The CISD, of course, for those who read medical literature, especially on debriefing, they know that my neighbors in Amsterdam, they published a meta-analysis saying that CIDS or no CIDS makes no difference to the patients, or the victims, I should say, to the victims. So I took the chance anyways, because of course there are many, the SMD, there are plenty of debriefing methods used for rescue workers, used for victims, used for adverse effects. Let's be honest, when one debriefs for the team. When you have an adverse effect in your department, someone gives the wrong medication to a patient, you discuss it afterward. The patient has already received the medication. They are the victims. If the patient has complications, it's the family also that is the victim. However, there are secondary victims, and the secondary victims are the healthcare givers. So, what I decided was we're going to use this, but modified. Now, there were 7 steps. I did not use all 7 steps because I adapted it to this situation. Assessing the individual impact, that's sort of easy if you want. I know my team. I was there when the patients were coming in. I saw how people were reacting. I could imagine who needed a bit more care, a bit more attention, and who didn't. The second topic I really didn't use, identifying surrounding sources, that's sort of safety and security and all that sort of thing. It's not the context here. As I said, I adapted this CISD. Diffusing, I thought this was the most important aspect because here people had to express themselves and at the same time the discussion could go anywhere. People mad because the government did not protect the people of Brussels, realizing that we had been in lockdown since November, the whole idea about terrorism, and the innocent victims. We received terrible examples of children, pregnant women, and so it was very stressful for them, and I believe they really had to diffuse all that. Predicting future reactions, I left that for the psychiatrists. That's not my role. However, the day after the attacks, my entire team received a message saying, you can have anonymous, individual, psychological contact with a psychologist that does not work with our department. So there's no professional interference at all. And that would be anonymous, free of charge. The systematic review, that's easy. We do that normally with the debriefing, so that's nothing new. Bringing closure, a bit tricky because it's easier to start the conversation than to stop it. You have to decide when people have expressed what they individually need to express. It's not what you think, it's what they need. And that's sort of tricky because some people may be late starters in the discussion because it was a group meeting. But that's what had to be done. You had to really feel your team and say, okay, this is the time when we can close this discussion. And the re-entry aspect was simply, at the end of the meeting, I had pizza for my team. And we were able to discuss anything but the debrief. We could just talk. We didn't have to talk. We were just there as a team. Now, just a few points. I mentioned team a few times. I believe it's the key. I really do. And the secret is to be a team before something like this happens. Because during it, it's too late. And the pathway, I believe, to do it is to have in your departments a culture of forgiveness, as they say. And what does that mean? That means that you are able, when you do a debriefing session and when there's an error or adverse event that occurs, that you're able to honestly say, I didn't think about that, or I forgot that. We all forget things. We will all make errors, and it's much more helpful and supportive to be able to say to your colleagues, you know, I should have and I could have done better. This way, the communication is open amongst your colleagues, and they will be there for you, and they will be a source of support when you are before a situation where you are not sure which way to go. You can rely on them, and that is really what we do in emergency medicine. It's a teamwork. What I did, of course, here, I talk about the debrief in two parts. The technical aspects. Did we do the tetanus vaccine? All that was discussed, but with my chief, my assistant chief, and myself, and with the individual doctors and the nurses, we called them in individually. The group was just for that emotional impact. Well, this is a calendar of 2016, and I just wanted to remind you, but I can't really, well, the 10th of March was when we moved. 12 days later, the 22nd, were the attacks. It was done during what the Christians call Holy Week, meaning that the Sunday, the 27th, was Easter Sunday. The Friday and the Monday around that Sunday were bank holidays. And the two following weeks, the week that starts on the 28th and the week that starts the 4th of April, were school holidays. People had planned to travel, people had taken time off, and I wanted to respect that. It's maybe criticizable. One can say, well, you know, all the literature says it should be done 48, 72 hours. It was impossible. If you look on the 22nd, the 23rd, and the 24th, it was hellish in Brussels. It was impossible. I had meetings at the Ministry of Health. It was just impossible for me to organize it. And so I had no choice. When they came back on the 11th of April, I sent out the email on the 13th. We debriefed on the 20th, almost a month later. That's not really good. And actually what happened is my colleagues in Amsterdam, when they were doing their meta-analysis, some of the cases were done much too late, the debriefing, and that could possibly explain why this famous CISD was not any better than doing nothing, okay? Again, I did not use it. I modified it. I used it as a guideline. And I used it as a guideline with the psychologists and the psychiatrists in my hospital. I did not just do it alone. So I'm almost out of time. I wanted to just give you some take-home messages. And the take-home message is, begin today with team building. It's really important. We are going to grow old in emergency medicine. We might as well have a bit of wellness while we're working, because we will spend almost as much time with our colleagues in the hospital than with our families and with our friends. Debriefing should be begun even with little events. Yeah, you know, maybe the EKG machine should be placed more centrally, because the last time we had to do it, someone left it on the other side of the department and the nurse couldn't find it, and so the EKG was not done in the 5 minutes after the patient was signed into the emergency department. And so it's out of our protocol. That's not acceptable. It must be done in a constructive way. Seek advice if you don't know how to debrief, what you should do. There are courses. There are ways to learn how to do it. And I think the last thing is really, the reason why we do it is to maintain quality and maintain wellness. We do it for ourselves. It's terribly important. Yes, of course, we do it for the future patient that we don't know when they will come, but we do it for ourselves. Thank you.
Thank you very much, Dr. Leach.
Excuse me, I just forgot one thing. Oh, it's too late. Okay, thank you for attention. I won't dare try to pronounce this. And I just wanted to have a quick reminder. There is going to be in Emergency and Disaster Congress, again in Turkey, in Istanbul, in June. It's done with IPAT, IMAT, and USAM, and a lot of the Balkan states. And I hope to see you in Prague. Now I'm finished.
Okay, well, thank you very much. We do have a minute or two for questions. Do we have any questions for Dr. Leach about this important topic? Okay, well, I don't see anybody raising their hand right now. I'll encourage you, if you had any questions, the speakers may be available after the session is over too for your individual questions. So now it's my pleasure to introduce our second speaker, Dr. Abdo Khoury. Dr. Khoury is a member of the Department of Emergency Medicine and Critical Care at the University of France. He's a vice president of the International Pan-Arab Critical Care Medicine Society. He's a member of the research committee at the French Society for Emergency Medicine and also the industry liaison officer at the European Society for Emergency Medicine, and is very active politically in the European Society of Emergency Medicine and in a lot of places in the MENA region. Dr. Khoury's talk this morning is entitled Difficulties in the Field Hospital. So it's my pleasure to introduce Dr. Khoury.
Thank you, Mr. Chairman, for this extensive presentation. Thanks a lot. I'm really happy to be here. I'm really privileged to be here. I want to thank the Professor Bashar Khan Chander for this invitation. I've been here for the past, I think, 5, 6, 7 years, I don't know. I feel like I've been here eternally. And I tried to speak in this disaster session about difficulties in the field hospital. So for those who don't know me, I'm coming from Besançon, from the eastern part of France, very nice city. I invite you all to my city. This is our trauma center, level 1, 2 helicopters, EMS, dispatch center. We do lots of retrieval. For this talk, I don't have any conflict of interest in any kind of disaster, neither with Mr. Kalashnikov, but lots of acknowledgement for people I work with from different countries, from Turkey, from Belgium, from France, and everywhere. And especially with Maud Michalou from the Summit of Paris, because we work extensively in training in disaster medicine, in training also in dispatch and disaster on the field. As you all know, disaster was defined by the United Nations by a serious disruption of the functioning of the community or a society. And then the impact of this will exceed the ability of the affected community to cope with this disaster and to cope with this own resources. You know the cycle of disasters, and when the sudden onset of disaster occur, it happens with little warning, and it means that you don't have enough time to get prepared. So it's going to arrive at one night, in one morning, and if you're not prepared for that, you're going to be really, really late on the response. This is how usually it happens before and after. This is a picture from the tsunami, and I think you all remember these pictures. It was before and it was after, with nothing remaining. But it's the same when you have an earthquake, when you have a typhoon, when you have war in Syria or others, when you have flooding. This is what happens. You don't even have hospitals. And the massive number of casualties and the ability of your healthcare system to cope with this will be completely reduced or completely maybe unrealistic and unreal. So it's completely compromised. And this is why when we operate in these kind of situations, we operate derived from the military. We learned a lot from the military, and we started to use field hospitals from the military and from the military doctrine and to cope with these situations. And this is how it looks like in military field hospital. It's NATO standards. This is a French one, but these are NATO standards. But these NATO standards and these army standards are not really applicable for civilian disasters. And some years ago, in 2003, in San Salvador, there were a big gathering for United Nations, for WHO, and they started to define and try to define the field hospitals and what are the requirements for the field hospitals and what are these field hospitals and how can we implement them and how can we deploy them in disaster countries. So there are lots of roles of these field hospitals, but at least they should provide early emergency medical treatment and also provide follow-up, and sometimes act as temporary facilities or substitute completely damaged healthcare system. So it's quite a huge configuration. Although it was written in like 30 pages at that time, it's a huge configuration and a huge requirement. But the problem is that one day came Haiti. And I think that all of you remember Haiti and remember the extensive damage that Haiti have had. And still these consequences are up to today, 10 years later, we still are coping with these consequences of Haiti in terms of destruction, in terms of lots of UN and lots of international help and aid. Everyone wanted to go to Haiti. Everyone wanted to be on the picture. Everyone wanted to be represented. And from everywhere, we came to Haiti. 44 foreign field hospitals, more than 18 countries represented. And you see some from Turkey, from France, from Israel, from everywhere. And everyone wanted to be there. And in my opinion, in the opinion of lots of others, it was a complete mess. We really messed up in Haiti. And I think this is why some years later, in 2013, we've gathered at the United Nations, and they once again have tried to work on these procedures and work on the deployment of immersive medical teams and foreign medical teams and immersive field hospitals to just try to regulate all this and not have the same picture that we have in Haiti. And Dr. Gianni, who is our next speaker, was extensively involved in this writing of these protocols. So this is how it looks like. It's derived once again from the military, but once again it's applicable much more for civilian. And you see that you have 3 roles or 3 different organizations or 3 different involvement. The first one, to be able to give triage, outpatient care, immersive medical care. Then if you are more important, you can also bring inpatient surgical care. And if you are much more important, you can bring also inpatient care and much longer term patient care and field hospital. And also they specified for some more roles, some specialized team in burns, in pediatrics, in the dialysis, for crash syndromes, and all this. So you see, once again, derived from the military field, but we just applied them for civilians, and we just configured this for civilians. So we trained, and we in France have also our response team, rapid response team, and to go and be deployed within hours outside France also. And we train a lot. We train in establishing our tents. We train in doing our field hospital. We train, and you see the very nice field hospital upstairs. We train to put all this into configuration and in minimal amount of time. But unfortunately, it's not always what we expect when you arrive on the scene. We have lots of difficulties, and I won't talk about all difficulties that we can encounter. I'm going to talk about some which are important in my point of view. First of all, the configuration of the field. When we arrive somewhere, it's not that nice that we saw when we are training. Sometimes it looks like this. And this is field hospital from the Red Cross in Bangladesh. So you see, all are dispatched in the forest. All X-ray is far from triage far from OR. So it's not the way we trained for that. So it's something challenging for us, and you have to cope with this, and you have to adapt to this. Second difficulty, the security. And I think the security is much more important than other things. You are in conflict zones, you are in war, you have floodings, you have lots of things, and you have also riots, and people want all of them come and gather and have the medical equipment and medical health care and the medical aid. So they are all can be of threat for you, and so you have to discuss your own security and something important. But also evacuation. When you evacuate your wounded or your people, how can you evacuate when the weather is bad? When you don't have place to land your helicopters? When you have lots of crowd that you cannot come and deliver proper aid? So these are things are challenging, and the evacuation should be considered and took in place. Otherwise, it can be very, very tough for you to do your mission completely. And when you evacuate, where do you want to evacuate? Is it close? Is it long? This is an example of the French military aircraft. It's ICU aircraft that you can transport around 30 wounded with ICU and with other ICU and non-ICU patients. But you can work a lot on them. You can do ultrasound, you can do a lot of things. It's really ICU airplane. But once again, when you evacuate, you have to know where to evacuate and what is the range of your plane, what is the range of your helicopters to know what the evacuation will be. And then one more difficulty about the length of your mission. You have to think of rotating your teams when you get deployed somewhere. You're not deployed for 2 days or for 4 days. You have to know for how many times you're going to be deployed. And if it's a longer mission, you have to think about rotating your teams because they'll be exhausted, they won't be operational, and they have to work on that. And the team you're going to deploy the first hours or the first days or the first weeks won't be necessarily the same that you're going to deploy 1 month later or 2 months later. Not the same. So once again, you have to cope with this beforehand, and you have to think of this beforehand. You have to think about your supplies. How do you have supplies to your field hospital? Okay, you have lots of things for the first week, second week, but when the mission will extend for 1, 2, 3, 4 months, how do you have the supplies? With some uncertainty, some security issues, some weather issues maybe. So you have to work on that beforehand. And as I told you have to adapt your mission, because at the first days, you are doing the emergency care, but afterwards you are doing the rehabilitation and you are doing regular health issues. And then you can cope with normal diseases, chronic diseases, and shortage of medication, shortage of supplies, and all that stuff that you have to supply for the population. It's something quite tricky, and you have to work on that. And especially you have to have in your teams different profiles. Not only emergency physicians and surgeons and critical care physicians or anesthesiologists. You should have also internal medicine, pediatricians. This is because it's gonna start longer, it's gonna stay longer. So we trained and we were deployed all over the world almost, different configurations with field hospitals, without field hospitals. And we're working on differentiating the crisis typology. As you know, you have short crisis and long crisis, and you have to adapt on this. Every one of this is not the same.
Objective global assessment. This is a structured approach to taking a history that includes weight change, changes in food intake, gastrointestinal symptoms, and functional impairment. And is combined with a physical examination looking for evidence of the loss of subcutaneous fat, especially at the chest and triceps, muscle wasting, especially at temporal region, deltoids and gluteals, and also an examination for edema and acids. To actually measure energy use requires sophisticated equipment, so requirements are more often estimated using formula. One such formula, maybe the most famous one, is the Harris-Benedict equation, which estimates basal metabolic rate in kilocalorie per day. The equation will usually give a result of around 25 kilocalorie per day, 25 kilogram per day, and the equation estimates basal metabolic rate in afebrile healthy individuals and will therefore need to be modified according to the situation to calculate resting energy expenditure. And when prescribing enteral or parenteral nutrition, the appropriate body weight from which to calculate caloric and protein intake, which is called the dosing weight, must first be determined. Guidelines indicate that protein requirements increase as illness becomes more severe. Practices to give patients with only mild to moderate illness 0.8 to 1.2 gram-kilogram protein per day, and critically ill patients are generally prescribed 1.2 to 1.5 gram-kilogram per day, and patients with severe burns, that's the most dramatic one, may benefit from as much as 2 gram-kilogram per day. And also the other essential nutrients, lipids provide 9.3 kilocalories per gram, and calories from lipids should be limited to 40% of total calories. And usually, standard enteral nutrition delivers approximately 50% of calories as carbohydrate and 30% of them from fats. And it is also reasonable to provide vitamins and trace elements to critically ill patients, regardless of the type of the nutritional route. The optimal mixture of vitamins and trace elements is yet to be determined, so daily recommended allowances should not be routinely exceeded in the absence of well-designed and valid randomized trials. So I have talked about a lot of formulas, a lot of numbers. Maybe it's better to make it simple with a case. A case example of 33-year-old male admitted post-laparotomy for a ruptured appendix and sepsis with a body temperature of 39 degrees. How should we calculate the energy requirements of this patient? Let's go with Harris-Benedict formula. First, we should estimate basal metabolic rate, then modify this value according to his clinical situation to calculate resting energy expenditure. The modification for temperature and sepsis are additive, and the caloric requirement works out to approximately 2,500 kilocalories per day. As you see, the basal metabolic rate we find with Harris-Benedict formula is nearly 1,800 kilocalories per day, and we have to add 20% for temperature, 9% for sepsis, and 6% for surgery. Now, how should we give this energy? We provide 40% of this requirement with lipids, and we will provide 1.5 kilogram per day protein, and in the end, the remaining energy comes from carbohydrates, and it seems that 106 grams of lipids, 112 grams of protein, and 234 grams of carbohydrate per day for this patient's requirements. But how should we give this energy? We should bolus it from the beginning, or we should start slowly? We should start slowly. An acceptable initial nutritional goal is 8 to 10 kilocalories of calories per kilogram per day, and then 18 to 25 kilocalories and 1.5 grams of protein per kilogram per day after 5 to 7 days. How should we administer it? Nutritional support can be given through oral, enteral, or parenteral routes. And if at all possible, oral or enteral are the preferred routes for nutritional support. They are far cheaper, more physiological, reduce the risk of peptic ulceration, minimize mucosal atrophy, since food in the gut lumen is a potent stimulus for mucosal cell growth and may reduce translocation of bacteria from the intestinal lumen. And the nasogastric tubes is the most common method in ICUs, but it also has some disadvantages, like it can cause malposition, difficulty swallowing or coughing, discomfort, sinusitis, and nasal tissue erosion, but it is still the most common method for nutritional support. Also, oral tubes, enterostomy, and post-pyloric feeding are the other enteral nutritional methods. Parenteral nutrition is most often given via a central vein, as the solutions are usually hypertonic. Preparations for peripheral use are available, however, they have to be isotonic, which means that very large volumes would have to be given to provide adequate nutritional support, and this severely limits their usefulness. And for a successful enteral nutrition, there is much discussion about that, but there are some simple guidelines, some simple points. For example, the first one is, let's confirm the tube position. Because otherwise, the most common complication of enteral nutrition we will face aspiration. So it should be better to confirm the tube's position both clinically and radiographically if it is possible. And also there should always be a high index of suspicion that the tube may have become dislodged, which is an easy thing, and the patient should be set up to an angle of at least 30 degrees to minimize the risk of reflux and subsequent aspiration of gastric contents. This can still occur around a cuffed tracheal tube. And maybe the most important part of my presentation is early feeding. Early feeding has been shown to reduce septic complications, length of hospital stay, and readmission rates in patients after both upper and lower gastrointestinal surgery. And that's true for also the medical patients. Enteral feeding does not appear to increase and may in fact decrease the incidence of anastomotic breakdown. And large volumes of feed in the stomach will increase the risk of aspiration of gastric contents. So bolus feeding should be avoided if possible. Also, if the patient is not tolerating enteral feed, then prokinetic agents, such as IV metoclopramide, should be given. Guidelines discourage early enteral nutrition in critically ill patients who are both hemodynamically unstable and have not had their intravascular volume fully resuscitated, since such patients may be predisposed to bowel ischemia. Hemodynamic instability by itself, unless severe, is not a contraindication for enteral nutrition if there is evidence for adequate volume resuscitation and tissue perfusion. Other contraindications to enteral nutrition include bowel obstruction, severe and protracted ileus, major upper gastrointestinal bleeding, intractable vomiting or diarrhea, severe hemodynamic instability, gastrointestinal ischemia, and a high output fistula. But despite these complications, still the most important route, the preferred route, is enteral route. And the best time is in the first 24 or 48 hours. And for parenteral nutrition, it may be given via peripheral vein if it is significantly more dilute, so-called peripheral parenteral nutrition. Because of the lack of benefit from short-term parenteral nutrition, peripheral parenteral nutrition is rarely indicated. In general, for short-term administration of total parenteral nutrition, peripherally inserted central catheter is the preferred route. Alternatively, but not preferable, total parenteral nutrition may be administered through a subclavian internal jugular or femoral central venous catheter if total parenteral nutrition is only needed for very short periods, like a few days, or if a peripherally inserted central catheter is not feasible or reasonable. For long-term administration of TPN, a tunneled central venous catheter is the preferred route. Guidelines use an arbitrary cutoff 30 days to distinguish short-term from long-term total parenteral nutrition use. So, if you are going to provide a parenteral nutrition which lasts less than 30 days, then we should choose peripherally inserted central catheter. If it is more than 30 days, then the best choice is tunneled central venous catheter. We very rarely use peripheral veins, and if the peripherally inserted central catheter is not feasible or not reasonable, then we may use subclavian internal jugular or femoral central venous catheters, but that's not the best choice, especially for the femoral central venous catheter. We face a huge risk of infection. And contraindications to parenteral nutrition includes hyperosmolality, severe hyperglycemia, severe electrolyte abnormalities, volume overload, inadequate IV access, and inadequate attempts to feed enterally. Relative contraindications to parenteral nutrition are not well defined. However, parenteral nutrition is often avoided in sepsis, systemic inflammatory response syndrome, gastrointestinal bleeding, short-term mechanical ventilation, and conditions expected to reverse quickly that temporarily preclude enteral feeding. And usually we do not suggest to start parenteral nutrition for the first 5 to 7 days, unless the patient is severely malnourished and it is impossible to use the enteral nutrition. When it comes to complications, maybe the most problematic complication is refeeding syndrome. Patients who are severely malnourished or have undergone a significant period of starvation are at risk of refeeding syndrome during the first few days of nutritional support, regardless of the route. The clinical features include weakness, respiratory failure, cardiac failure, arrhythmias, seizure, and death. Starvation causes a loss of intracellular electrolytes secondary to leakage and reduced transmembrane pumping, and intracellular stores can become severely depleted even though serum levels may be normal. When carbohydrate is available again, there is an insulin-dependent influx of electrolytes into the cells, which can result in rapid and severe drops in serum levels of phosphate, magnesium, potassium, and calcium. And it usually starts with hypophosphatemia. So, Based on this pathophysiology, it's better maybe to start slowly. But how? To the feeding. At-risk patients should be identified and feeding must be introduced slowly, starting with only 25 to 50% of energy requirements and gradually increasing after 4 days. Electrolytes should be generously supplemented at the same time as starting feeding and should be closely monitored. Thiamine and other vitamin Bs should also be given IV before starting feeding and then daily for at least 3 days. As I mentioned before, it's better to start with 8 to 10 kilocalories. Then we also protect our patients from the refeeding syndrome. As you see, it is approximately 40 or 30% of the total energy when we start with 10 kilocalories per day for the first 5 or 7 days. And another complication, overfeeding, can cause uremia, hyperglycemia, hyperlipidemia, fatty liver, hypercapnia, especially with excess carbohydrates, and fluid overload. And to avoid from that, it's better to closely monitor the patients. Another important complication, hyperglycemia, is shown that critically ill medical and surgical patients who are hyperglycemic have a higher mortality rate than patients who are normoglycemic. And hyperglycemia can be related to overfeeding, but it is often not. It is not a rare thing that critically ill patients become insulin resistant as part of the stress response. And it is an acceptable approach to have a blood glucose target of 140 to 180 milligram per deciliter in most critically ill adult patients. And there are some other suggestions like targeting 8 to 110 milligram per deciliter, but it is shown that when we target this, we have hypoglycemic attacks, and it is proven that are related to higher mortality rates. And when we choose a more liberate target like 180 to 200, it is also shown with poor prognosis. So it's a simple and a good approach to aiming the 140 to 180 milligram per deciliter. And the most common risk with enteral feeding is aspiration of feeding causing pneumonia. The implementation of a combination of measures as well as a nurse education program and good oral hygiene has been shown to decrease the risk of ventilator-associated pneumonia. Diarrhea can also be a problem, but is not an indication to stop feeds. Other causes of diarrhea need to be excluded, but if enteral feeds are the cause, then a feed with more fiber can be tried. The more common adverse metabolic consequences of enteral nutrition include hyperglycemia, micronutrient deficiencies, and refeeding syndrome, which we mentioned earlier. And the most common mechanical complication of enteral nutrition is constipation. Development of a fiber bezoar is a rare complication that can occur among patients receiving enteral feedings with fiber. And fiber bezoars may be more prevalent when peristalsis is impaired, such as in patients on pressors. So fiber should be used in such patients with caution. Either constipation or a fiber bezoar can cause impaction, bowel distension, perforation, and death if not treated early, although these sequels are very rare. And insertion of a nasogastric or nasoenteric tube can also cause mechanical complications such as insertion into the lung. And the specific complications of parenteral nutrition, the insertion and presence of a central venous catheter has inherent risks including pneumothorax, hemothorax, arterial or nerve damage, infection, central vein thrombosis, and erosion through the wall of the vein or right atrium. And it's thought that some of the increased risk of sepsis seen in patients receiving parenteral nutrition has actually been the result of overfeeding and uncontrolled hyperglycemia rather than due to parenteral nutrition itself. And nevertheless, infection is a serious risk, and the bags must be sterile and discarded within 24 hours of starting. And sterile precautions must be used when changing bags, and the lumen of the central venous line must not be used to take blood or give drugs or fluids. We should only use the parenteral nutrition rod for giving the nutritional support. And parenteral nutrition also predisposes to hepatobiliary disease, including fatty liver, cholestasis, and acalculous cholestasis, electrolyte imbalances, and micronutrient deficiencies. Thank you for listening.
Thank you, Professor Yit. Are there any questions? All right, thanks for an excellent talk. Oh, we have a question.
Firstly, thank you very much for your excellent presentation. There is our intensive care unit in university. Sometimes we ask some questions to our. When we must start nutritional support in the patients, for example, when admission to the sepsis patients, when we must start nutritional support to the patients in intensive care unit, for example, sepsis patients. When admission to the intensive care unit, or maybe the other time failure of the feeding parameters or failure of the laboratory test, what time?
Actually, that's an excellent question, which has a long answer. It may be the best answer, or maybe it's better to start with. It depends on the patient, but there are some very important points about the answer of this question. First, we have to start as early as possible. There's no doubt about that. So it's better to start in the first 24 or 48 hours. And for the sepsis patients, it's also the same. There are some contraindications, as I mentioned in my presentation, like severe hemodynamic problems. Other than that, or bowel ischemia, ileus, or such that things. But even in these positions, we have to insist to use the enteral feeding. So my answer would be in 95% of the patients, or let's say a huge percent of the patients, it's better to start in 24 or 48 hours with enteral nutrition. For parenteral nutrition, even the patient is in not a good condition, we should wait for 5 or 7 days. If it is going to be a problem about enteral nutrition and we will start enteral nutrition in 3 or 4 days, we can start in 3 or 4 days. Let's say the patient has a subileus, but it seems that in 3 or 4 days we will handle that problem and we will start. Then we should wait for enteral nutrition. In that position, we do not start parenteral nutrition.
Thank you very much.
It's my pleasure. Thank you.
Dear participant, now the second speaker, in my opinion, he is pioneers of emergency medicine and international advocate of EM and past president of USM. I invite Abdullah Bello. Your topic, patient safety reporting system in the emergency. Stage is yours.
Thank you very much, Chairman, and I'm happy to be here. First, I would like to thank again Bashar Kandar and Beset all and all the team, because it's a teamwork for this fantastic Congress. The first slide, can you, the only thing is important in the slide is my email. Please take my email. We are a project for the next Congresses to implement a global international course in quality and safety. And I do believe that this topic is one of the most important in medicine, and particularly in emergency medicine. I'm a basic researcher. I'm doing research in rat and mouse. This is my patient. And my second patient is quality and safety. I have two dreams. The first one is I don't want to be rich. I want to be happy. My second dream is I want to give to patients I'm managing in the emergency department the best care I can give to them. I want to share with you some concept and philosophy, and I will bring some data about reporting system in emergency medicine. I have no conflict of interest, and yesterday I showed you this slide. Please do something. And if you do good and this something work, do it more. If it doesn't work, stop it. Now the message is do something. I want also to share a story from Amerindian people, and this is a very nice story. One day, a big fire started in the forest. Big fire. And all the animals were completely in panic. And this lion, or the big animals, they were watching this very small bird, the colibri. And the colibri was going forward, bringing water, small water, and put the water in the fire. The lion said, "Why are you doing that, small bird? Do you think that you are going to stop the fire in the forest?" And the small bird said, "Okay, I'm small, but I'm doing my job. I'm doing my part of the work." This is the message for quality and safety. We have all to do our job, our part of the work, and we have to be excellent in what we are doing. The concept of quality started many centuries ago, and I'd like to show you this slide, and particularly this Aristoteles is a very important Greek philosopher. He said that quality is not an act, quality is a habit. Yes, it must be a habit. Every day you have to be the best. And the next day, when you look yourself at the mirror, you have to say, I will be better than yesterday. I will manage the patient better than yesterday. And also Hippocrates. And Hippocrates said, the most important is not the disease. The most important is the patient. Keep in your mind. And I think we forgot this concept of patient in the center of the healthcare, and let's say now in the healthcare system. Yesterday I showed this slide. Our objective is to balance between the performance, the excellence, and the requirement. It's important to have requirement, to have standards, to have guidelines, and we are working on that for many years. For the next century, I think, the objective is to have global guidelines for everybody in the world. Quality and safety is a matter of support from government because it needs a lot of money, and you will see some figures, and it needs a lot of agency, institution, organization working together to get data which will be helpful to improve the quality of the care. You know very well, I showed you the slide yesterday, keep it in your mind. Healthcare system is killing more than aviation. Every year in America, for example, but I think we have the same figures all over the world, 120,000 patients die because of adverse events and medical errors. Put this in your mind. That means we have a lot to do to improve our quality of care. This is very expensive, very costly. You can see here that the cost in America, we have a lot of data from America, the cost for adverse event is up to 50 billion, which is huge. That means we always say that quality is expensive because we have to put a lot of money to organize better our healthcare system. But non-quality is more expensive than quality. Keep in mind this slide, and you have to go to read this report. The journey of quality and safety started in 1999 with this report. This is a very important report from the Institute of Medicine in America. And this report has this title, "To Err is Human." To err is human. We have to stop to blame people. We have to understand why we do errors. Once we do that, we decrease the number of errors, and we decrease also, of course, the adverse event. Very important. To err is human. We have to implement a culture of safety, a just culture of safety. This is very important. I like this slide. I built this slide to show you that an accident occurs if there is no defenses. Okay? There are a lot of errors, we don't see them. We don't see them. We call them latent errors. And we have to find these latent errors. This is very important if we want to prevent the accident. And you can see here that the healthcare is a complex. It's a huge complexity. Why? Because we are dealing with human. It's not a car, it's not a plane. We are dealing with human. And you know that human are complex. There's a relationship between medical errors and adverse event. We have this big family of medical errors. We have a lot of medical errors in the healthcare system. And we have, hopefully, small amount of adverse event. But we have to detect them. I will show you by reporting system. And among these adverse events, we have to abolish the preventable adverse event. This is very important. We can prevent adverse event in the healthcare. Human factors are very important. And today, there is a lot of groups working on human factor to understand why we are making errors. Of course, we are not going to blame humans because most of the errors came because of systems error. And we have to work on the system, but also on human. We have to improve our skills, our way to manage patients in the emergency department. This is a very nice study, very old study, but very important, 1991, published in Harvard by the father of quality and safety, Lips. And you can see here that the death with the adverse event is almost 14% in this study. And the report on To Err is Human started with this study. And you can see we have a different level of disability from a minimal impairment to a permanent impairment. That means it's important to prevent this kind of event when we manage patients. There is no difference between surgery and medicine. We have the same amount of errors. And you can see that, for example, in medicine, we have a lot of errors in diagnosis, a lot of errors in therapeutics, and we have a lot of errors related to drug. In surgery, there's a lot of error in late complication or non-technical complication. In America, they put a lot of energy, a lot of money and human resources to decrease this adverse event. And you can see here that the number of adverse events increased all over the year because they implemented the reporting system. If we declare the adverse event or errors, we increase the number, of course. The objective is to increase the numbers, then to try to decrease the number of adverse events. And the most important factor that is involved in adverse event is communication. We have to improve communication in our team. Medicine is a teamwork. It's a teamwork. Put in mind this key word. There's a lot of action, solution to improve that. And one of the most important, and focus on this topic, is to implement in the hospital, but I believe in the department, a system that will allow you to report adverse event. We need metrics. Without metrics, it will be difficult to improve the quality of care. And in America, you know, they do a lot of things, but you know that the healthcare system in America is the worst in the world, one of the worst in the world. We have the data, we have everything. It's worse because the social system is not good, but they put a lot of money in quality and safety, I can guarantee you. They want really to improve the quality of care, and they implemented reporting system, technical reporting system everywhere in states, and they want to get it for all states in America to get national American data on medical errors and adverse events. This is very important. I think Turkey should work on this topic. There's a lot of technology on that. One of the best in the world is the English or the UK reporting system, very interesting, and they implemented, I think 3 years ago or 4 years ago, reporting system at the national level for emergency care. This is very important. They have a report every year. And the most important keyword here in this talk is that 86% of hospital safety incidents are not reported. We have to report everything. People, they are afraid to report because they think that if I report, maybe they will fire me. Because the culture of blame is still in the healthcare system. We have to abolish the culture of blaming the people. And the objective with this reporting system is to be in the green part here, okay? And to improve the quality of care by using these metrics. In the hospital where I was in Boston, 5 years ago, they were very bad. They were in a green line, red line. They implemented quality and safety in all departments in the hospital. And now they are in the top. They are in the top now. They decrease medical errors. They decrease adverse events. That means it's possible. If there is a policy in the hospital, in each department, we can have this kind of achievement. But this is a very hard job. We have to do a continuous job. In the image department, you can read some papers, and this one is very good because this one is a systematic review, and you will see that the reporting of patient safety incident is from 0.36 to 6%. Not too much. I suspect that we are under-reporting adverse event and medical error, and 36% to 70% of these adverse events are preventable. And you know why? As I said yesterday, emergency medicine is a very special specialty. It's a unique specialty. In a short time, we manage patients, and we have to do the best for those patients. Organization is important. This is one of the examples in this hospital in Boston. It's a teamwork. You can see here, there's a QAI, Quality Improvement Committee, and this committee receives a lot of information from the reporting system everywhere, from patient complaint, from the data board in the file patient, from some criteria like you have on the top. And all of this system is connected with the hospital. They work together, administration, doctors, nurses, all professionals, to improve the quality of care. Here is the system. They have electronic system. This is very important. And with this system, you can flag. You click here. If you think that you did a mistake, you flag. I did a mistake, okay? Or I saw a mistake. You flag. Then the system will register you flag. This is very interesting. And then there is something happening in the computer. We'll give you some information here, and you click. You can also put some description. This is very interesting. This is the culture safety. All the professionals, they do the job. They understood that we have to report what we are doing in the emergency department, and we have to report our errors to be sure that we are not going to repeat the errors. You can put some indicators, for example here, 72 hours return in the ED. You have a patient, you finish the management, and the patient go at home, for example. 3 days later, the patient come back. And then this could be a way to catch all the patients with medical errors. Or, for example, ICU transfer after 24 hours management in the ED. It's interesting. You can also measure the death 24 hours after the management. Look, we have a lot of indicators, and then you can rank the information from this flag system, reporting system. You can rank here, okay? And then, with this system, you publish. Research is very important. Without research, you will not improve quality and safety. I can guarantee you. Put effort in the research. And here, for example, patients with abdominal pain has a lot of medical errors and adverse events. You can see here, when you implement a reporting system, you can see here progressively there's an increase of number of adverse events. Increase, because you report. And this is good. This is good. It doesn't mean that you are not doing a good job. It means that you are reporting, okay? And you can compare different EDs here, okay? And you can see here that, for example, this one reports a lot of adverse events. This is very good. It doesn't mean that this one is a bad ED. It means that he's doing a good job. He's reporting to try to improve. What is the reality? We did a big study with 300,000 patients. You can see here, and we, from these 300,000, we flagged only 6,000 patients or adverse events. And you can see here that the most important indicator is the 72 ED return visit with adverse event. And the complaint from patient is increasing. Look, we have to encourage patient and family to also inform us that we did mistakes. We work together. We don't have to blame the professionals, and we don't blame the patient. We work together. It's very important. Transparency is important. Communication is important. And you can see here that the number of adverse events decreased over the year with this system because they implemented solution. But, you see, very important side. We don't know what happened here in the bottom. Oh, in the bottom here, in the hidden iceberg. We know what happened on the top there because it's visible. But many things appear here in the bottom, in the hidden iceberg. Evidence, we need evidence, we need research again, and again. We need to design, and we need to implement. And we are not very good in implementing what we've got from the research. Why? We need a continuous quality improvement. This is very important. Act, plan, do, check. This is the doing, the wheel, Deming wheel. This is very important. You have to keep it in your mind. We have to be the best every day. We have to monitor also. And we have to use more and more. Yeah, more and more technology. More and more technology. But human is important. Without human, technology is nothing. And teamwork. Work together. We work together. And we have to work together, but in a right way. In the right way. Together in the same way. For me, this is personal. And I will be provocative. One of the problems we're facing in the healthcare system, we're increasing the administrators, a lot of CEOs, a lot of CIOs, CTO, a lot of people in the top, in the office, staying in the office, and we have a few doctors on the bottom and nurses. We have to increase this number over the number of administrators. I'm not saying that administrators are not good, but we need to have those people more, the doctors more and the nurse more. Last slide, or last slide. If you want to go far, please go together. You have to be strong. And I like this animal. You know this animal. You cannot drink for maybe 1 month or 2 months. And you have to be a very strong emergency physician. Don't be afraid. Don't be afraid. You need a vision. Important. You have to look on the top. A vision to be excellent. We need spirituality. We need spirituality. Teamwork. We are not robots. We are human. It's very important. Thank you very much.
Thanks for your valuable presentation. Dear participant, is there any question or contribution? Okay. Mr. Ram, please.
Thank you very much, Dr. Bellew, for your nice talk. As we know, the one most important exhibition for a good quality is the supply and the request. The request that the patient are asking for us and the supply we have to present to them. I'm wondering if there is a criteria for a good approach for the number of the patients and the number of the staff in emergency department. Is there any criteria for a good quality?
Yes, we unfortunately we are not so strong like the intensivist. The intensivist, they put everything in the law. In France, I can send you what we did for many years. I was very involved in the National Society in France. We wrote how many nurses, how many doctors we need for a number of patients. Okay? For example, we need for 150 patients a day. I know that you have more than 150. We need, for example, in my department, I used to ask my administration to have 30 senior, and 20 resident, but 30 senior, okay? In America, they're very strong, and they can't justify the number. In the department when I was working in Boston, 150, same than me, 57 senior doctor, and 34 resident. No, they are data. You can calculate the number. You cannot do quality and safety without resources. Impossible. I visited your department, Beset, 700 patients a day, and Bashar, I was in Istanbul, 3,500 patients a day, with a very small amount of doctors and nurses. Impossible. It's impossible. No, you have to work with the government administration to get more and more and more doctors.
Hello, sir. So I wanted to add something to that, is that the National Accreditation Board of Hospitals and Healthcare Providers is like the Joint Commission for the US. In India, we have something like NABH, and National Accreditation Board of Hospitals and Healthcare Providers sits on ISQA as a national body representing India. And I think it's one of the only organizations in the world who has a separate accreditation for emergency department. So there is 109 benchmark accreditation. So what happens in the US or everywhere is when you do a joint commission accreditation of the hospital, they will do the whole hospital and then they will accredit you specifically for orthopedics, for cardiac, for critical care. But nowhere did they have a separate rating for emergency care. So because we were a part of ISQA and the red tape is less in India because of our new government, we went ahead and got experts together and we have 109 benchmark document for accreditation, and now over 45 departments in the country have a separate quality accreditation for emergency department only.
Yeah.
So you have a hospital accreditation, but if you want a rating for 5-star care, 4-star, you have a star rating through our national body for emergency medicine is the only one, as far as I know, in the whole world to give a separate accreditation.
Yeah, we have it in France too.
Yeah.
I was president of the evaluation committee for emergency care in France, and we wrote a book. We can't translate. I want to translate the book in English, and this book presents all the metrics and everything. And we do audits every year in France, and we accredit emergency department. Last advice. I'm sorry. This is very important. Last advice. You have to create your own system of evaluation and accreditation. You don't need joint commission. You don't need to put a lot of money for those people. You create your agency. National Agency of Evaluation and Accreditation. Important. We have it in France, there's in England, there's everywhere, in India, everywhere. This is very important, very, very important. Because if you don't do that at the national level, it will be difficult for your country and your hospitals and departments to improve the quality. Very important.
Okay. Thanks for your excellent presentation and contribution.
Thank you.
Unfortunately, time is not enough. Okay.
So I'd like to introduce our next speaker, who's Dr. Ayman El-Manyar, who's the Director of Clinical Research in Trauma and Vascular Surgery at the Weill Cornell Medicine Hospital in Qatar. And he's going to be speaking on where are we in the management of ARDS.
Good morning. Thank you for inviting me for this session. As you know, in the intensive care, the most important complication, one of the most important complications is the ARDS with high fatality. So I'm going to summarize the management and where do we stand in this era. So before we discuss the management, we should know what is the ARDS and how to diagnose it. This is acute inflammatory syndrome with diffuse pulmonary edema and respiratory failure that cannot be explained by heart failure, but it can be combined. Acute onset of severe respiratory distress and cyanosis, which is refractory to the routine oxygen or regular oxygen therapy, with associated with diffuse X-ray, chest X-ray abnormality, and decreased lung compliance. The pathophysiology, it is acute inflammation affecting the gas exchange surface, which is very important for oxygenation, the alveolar capillary membrane. The resultant will be that exudate inactivates the surfactant, leading to the collapse and consolidation of the distal air space with progressive loss of the lung gas exchange surface area. And you can see this, how to diagnose from the chest X-ray with the diffuse lung opacity and CT scan, and also you can see what is the inflammatory role in this disaster or this disease. So it is not a disease, it is actually a syndrome, and because of this there is no laboratory and imaging or gold standard diagnostic investigation of ARDS. It should be based on the clinical, imaging, and lab. So ARDS is caused by a huge range of conditions, which consequence patients with ARDS are heterogeneous. It can develop in any patient in the intensive care. So there is a 4-point lung injury scoring system for quantifying ARDS severity, which based on the PEEP, the peak end expiratory pressure, the ratio of the partial pressure of oxygen to the fraction of inspired oxygen, also depend on the dynamic lung compliance and the degree of radiologic infiltration. The outcome is determined by the underlying cause, patient-specific factor and comorbidity, diabetic, hypertension, renal disease, and so on, lung disease, clinical management, and severity of illness. The survivor commonly suffer from muscle weakness and neuropsychiatric problem, and fewer than 50% return to work 1 year after leaving the ICU. But the mortality is very high. It reaches 40%. This is from our center in Qatar. We collected the data from 2011 until 2018. It was 118 patients. And you can see the mortality group the mortality is 40% in this group. And the only characteristic in this patient is the polytrauma and receiving too much blood transfusion. So back to the management, there is 10 topic based on the available guidelines. It discuss the corticosteroid, the ECMO, the extracorporeal carbon dioxide removal, fluid strategy in the management, high frequency oscillation, inhaled vasodilator, nitric oxide, lung protective ventilation, neuromuscular blocking agent, positive or the beep, prone position. So this is the 10 items for management. If you take the most important items like the steroid, and I looked for the guidelines, they mentioned some meta-analysis done for this. You can see the mortality is reduced using the corticosteroid, but is not statistically significant. For the ECMO, also the mortality reduced, but at the expense of the bleeding. There is too much bleeding, but the mortality is less. For the ECCOR, there is no meta-analysis so far about this. So the evidence about its role is very weak. For the conservative fluid strategy, using liberal fluid or diuretics versus diuretics as a policy, the mortality reduced, but it's not significant also. But we can see the renal dysfunction increase. For the high velocity oscillation, also we can see the mortality is increasing, either on hospital or 30 days mortality. For the inhaled nitric oxide or vasodilator, the mortality increased, but statistically not significant. Lower tidal volume compared to the higher tidal volume, the mortality increased, and mortality in 60 days increased, by in-hospital mortality reduced when we use low tidal volume. The barotrauma increased. For lower tidal volume plus higher beep, which is called the open lung approach, the mortality reduced. But infection is increased, which is not statistically significant. Using the muscle relaxant on this patient, the mortality reduced. But the patient developed more weakness, but statistically not significant. Higher beep, the mortality reduced. For prone position, the meta-analysis, all meta-analysis shows the mortality reduced by putting the patient in the prone position. So to summarize what we should do, the prone position strongly indicated, high frequency oscillation should be avoided. The higher beep, there is weak evidence, but can be used. Muscle relaxant, it can be used, but the evidence is weak. ECMO also can be used, but evidence is still low. Inhaled vasodilator, the evidence is still low. Steroid and the ECCOR, it is mainly used till now for research purpose. So for mild, moderate, and severe ARDS, low tidal volume should be used, the prone position. For the moderate to severe, we can use the muscle relaxant. And for severe ARDS, ECMO is recommended. So this is to summarize again in the flow chart, that increasing beep, reducing tidal volume, prone position, but in time fashion. I mean early is important. For ARDS with refractory hypoxemia, again, we should play with the ventilator setting, reducing the tidal volume, increasing the beep, and increasing respiratory rate, and consider neuromuscular block, muscle relaxant, and prone position. ECMO only for severe cases. And thank you very much.
Thanks very much for an excellent talk. Are there any questions?
Okay.
Yeah, in the interest of time, I think we'll go on to the next speaker. Thanks very much.
Evet. Final speaker, in my opinion, pioneer of emergency medicine, Poland and East Europe. According to me, an important topic in emergency medicine practice. When can I discharge my patient? Julius Jakubowski, stage is yours.
Thank you. Thank you very much for the invitation being here with you. I'm already 6th time on this conference and I'm very proud observing how you are progressing. Thank you, Bashar Sander, for being with us all the time here. I'm representing Poland, Polish Society for Emergency Medicine, Polish Academic Emergency Medicine, but at the same time Emergency Medicine section from European Union of Medical Specialties, which I'm a member of this board. That's my university new hospital where I'm coming from, a big hospital, saying true. The Polish emergency medicine was born in this area already 20 years ago. When I would remind you the definition of emergency medicine, which is still under discuss, to make this definition more exact, more proper, but still in the common days we are using this discipline, this definition, which I just combine definition of IFEM and European definition altogether. So as you see, it's a primary specialty established using the knowledge and skill required for prevention of diagnostic and management, urgent emergency aspects, and so on. This includes organization, the proper medical responses for patients looking for urgent medical care. What is important in this definition, then the timing in this setting may be critical, either from side of the patient and from side of the medical point. Definition of emergency physician task is, of course, care for the patient with wide range of pathology from life-threatening. But the attendance and number of these patients is unpredictable and they mostly present with symptoms rather than diagnosis. Patient care includes physical, mental, and social aspects. So if focus on initial care until discharge or referral to other health professionals. So generally saying, emergency medicine addresses the comprehensive medical needs of all patients in emergency setting, prioritize interventions, coordinating, directing care for multiple patients at any one time. In other words, emergency physicians have a fundamental role in a modern healthcare system. That's typical view of referral emergency department, as my department is, for example. Growing number from hour to hour, growing number of ambulances with acute patients. This, of course, make a great pressure for emergency physicians working there. They are faced with numerous challenges. The first challenge is that limit of time. Time constraints occur because the severity and acuity of the illness, and also because the event presents worry that someone else will need the physician's attention. The second challenge for physicians is that they need to quickly assess and make therapeutic decisions on the basis of limited informations. So emergency physician may also provide medical control for patients in the pre-hospital environment. Also need to determine what care was given prior to arrival and what impact to this intervention made. This is the classical model of emergency care for the patient passing through emergency department. There are 6 phases of this care, of this model, from one phase until the 6th one. So you see how the patient is passing through all facilities in emergency department. What we are observing, the first moment when patient is arriving, the triage, allocation to appropriate clinical area. This may happen on different settings, as you see, the resuscitation or acute treatment and subacute treatment and waiting room. Following development of emergency medicine, those 2 areas, acute treatment and subacute treatment, are growing on importance, and in fact they are getting longer and longer with development of emergency medicine. This is also because, in between, also because there's a different mindset of emergency physician than other specialists, which means that emergency physician is concerning not necessarily the diagnosis, but process of thinking aimed at ruling in or ruling out serious pathology that are life or limb threatening. The evaluation of patients should proceed in a parallel fashion rather than time-honored method. So the mindset, the patient must be triaged and registered in the waiting room when there are beds available, must be abandoned. This is the relatively new philosophy of understanding the role of emergency physician inside emergency department having a new patient. It means that patients should be taken straight away to any available facilities with physician, eventually with the nurse or with another physician, to assess the patient, get history while patient is simultaneously having intravenous line, blood, all other procedures necessary in this concrete setting. So the single intervention, it is already well registered that intervention of in-room registration can decrease the length of stay of the patient for about 15 minutes on average. As you know, emergency department overcrowding is one of the plague of our daily practice. So a cornerstone of emergency physician practice is recognition of patterns in a patient presentation. That's why, as we are understanding now, and it's more and more developed or underlined, that the prudent emergency physician must be a detective and scientist in the same time, or another one, Sherlock Holmes and Einstein, having the new patient and having another way of understanding of this patient. He has to muddle through the mug of vague signs and symptoms to find the real one, the real problem, the pattern of this concrete patient. It is a well-known fact about emergency department patients that their presentation do not fit specific textbook diagnosis or classical presentation of illness. This we know from everyday practice. If you look to the most common presented symptoms from patients coming to emergency departments, there is a list. The list looks easy way and not very huge list, but if you look more details to each one of those points, you have to realize that each one of these manifestations in fact is another textbook. So to pass through this mass of possibilities, that's the art of emergency physician working in emergency department everyday practice. To pass through this, the main principle of this practice is to be able to state a simple questions that must be answered to provide effective care as a simple method to guide the emergency physician through the quagmire of clinical emergency medicine. So the first question which we are stating on the very beginning, seeing first time the patient, is the question, is this patient about to die? And that's the basic divagation. If he's a critical, having symptoms of life-threatening illness or injury which need to be immediate intervented, or is this patient emergent? His symptoms of illness or injury that may progress in severity treatment is not begun quickly. So usually following the, let's say, standards still existing as a standards, this moment relations between emergency physician first seeing the patient and the patient should not take more than about 10-15 minutes. And then the non-urgent patient, having low probability of progression, but still looking for symptoms and for life-threatening emergency, not a specific disease entity. You still need to anticipate impending life treatment. The next step, the next question is, what must be the next step undertaken to stabilize the patient? You must be quick, stabilize the critically or injured patient, focus on the primary survey, make necessary intervention, do not delay necessity primary intervention while awaiting completion of ancillary testing. Again, the main point of thinking for emergency physician. The third question is, if what you see, the serious case of the patient presentation, will this kill your patient or not yet? Maybe. This list is developed, you need to establish the history, examination, broad, and ancillary assessment should identify to confirm if you are right or not. Then you are coming to another question, what saying true means if there are another multiple causes of the patient's presentation. It means if this what you see is the only what you see, or maybe there is something else which may be covered somewhere and you need to be closer observing a patient. There is example, very, very classical example. If the near syncope and abdominal pain, a young woman apparently intoxicated from ruptured ectopic pregnancy, or maybe there is ruptured spleen secondary to undisclosed physical abuse by her boyfriend. So again and again, frequent reassessment of patient condition is imperative. The next question, can a treat assist the diagnosis in otherwise undifferentiation illness? Often in emergency medicine, treatment response further before diagnosis. In emergency medicine, philosophy and established diagnosis is not prerequisite to initiate appropriate treatment. So all those questions are running through your head during this second stage of patient's presentation in emergency department. And as I said before, this period is getting longer and longer in our daily practice in emergency departments because we have more and more tools, first to diagnose, but then to intervene to the patients. In that point, I would like to underline that there is a changing character of emergency medicine. We are becoming more and more intensive care practitioners, which is very important. And in my opinion, it is the future of emergency medicine, become more and more practically intensive care area. So the further questions are if diagnosis is mandatory or even possible. Sometimes it's impossible. So you are treating the patients, you're having treating symptoms and excluding emergency condition without giving a specific diagnosis, and that's also normal. Does the patient need to be admitted to the hospital? You are coming to the final point, what to decide about this patient. Not always you are able to answer appropriately. So sometimes those questions are not answered. Once assessment and treatment are underway, decide whether an emergency condition exists. If you, as an emergency physician, are comfortable, not always. That's the point of your practice. So then you are coming to the final decision. What to do with your patients? Should he be hospitalized? Should he be discharged? Sometimes those patients are dying, which is, of course, one of the standards of our daily practice. Sometimes patients escape from emergency department, which also happened, without being seen by doctor or without following rules already given to him. So your responsibility mostly are in this area. Hospitalize him or discharge him. If patient is not admitted, disposition is safe and adequate. In many cases, more frequently than not, patients are discharged. And then the question, how this happened? How many patients do not receive specific diagnosis? How many and if any symptoms persist? What is recommendation given to this patient? What is your final talk with the patient, disposition? Did you give him any advices, instructed him when to return for further evaluation, and so on? All those points should be documented. Documentation of your decision is very important. As Dr. Abdul Belou already said, this is a part of quality, documentation. And of course, this documentation, if it's good enough, it gives type of safety for you, for yourself as a physician, this decision giving. So risk assessment and disposition of the critically patient is guided by impression of clinical trajectory as well as presumed diagnosis. While diagnosis very often is based on information you receive from the patient, but also from your experience and intuition. So clinical picture is dictated by the state of tissue perfusion and patient ability to compensate physiologic perturbances. For example, if patient with positive troponin, ST segment changes, mean arterial pressure low, may be having simple coronary insufficiency, but another patient with the same signs is already in cardiogenic shock. So this is your art as a physician, as an emergency physician, as your intuition should decide how to interpret this, what you see with your patient. Or another example, low blood pressure in patient may result from therapeutic lowering of vascular tone. Sometimes when you are using sedation or analgesic sedation, this low pressure is just a result of your procedure. But same level of blood pressure in different individual patient may significantly distribute shock. So probably this patient may be in the first stage of sepsis. So differentiating these possibilities enable appropriate disposition and treatment and is essential in the practice of emergency physician. Organ dysfunction arising from emergency critical illness can be treated to abnormalities in either one or both of the following physiological relationships. This is very important. Relationship between organ blood flow and mean arterial pressure. and another relation between oxygen supply and oxygen consumption. You need to realize in which state of this balance, in which point in this balance is your patient. You must be able to evaluate those two key hemostatic relationships: mean arterial pressure, blood flow, and oxygen supply to oxygen demand. These presentations are essential for your decision. Failure to do commonly results in misdiagnosis and delayed recognition of clinical deterioration. I will not go more to details, but you need to be able to recognize this patient consumption, in which state he is, oxygen delivery, which is again dependent from cardiac output, and oxygen content of arterial blood. Then cardiac output, stroke volume, contra heart rate, oxygen content that's determined by hemoglobin concentration and saturation, so those are classical points. So then evaluation of oxygen delivery, low stroke volume. Is this because of hypovolemia or maybe not? Maybe it's already because some constraints dedicated to status of heart and his vascular system. Then you need to evaluate blood pressure, which is low because of low cardiac volume or low systemic vascular resistance or opposite. Then again, your art of understanding what's going on with patients, observing him, will bring you to the final decision. The same evaluation of hemorrhage. I will not go more to this detail. This is our daily classical practice. So having this pressure and knowing that another group of patients waiting for you, you are working in type of, let's say, chaotic environments. So as already Abdel Belou taught some moments concerning errors which may occur in emergency department. So saying true, the emergency department environment is complex, time pressure and dynamic, and generally saying is the most environment, as people are saying, perfectly designed for errors to occur. This we should always remember. Nowhere else in medical practice...
Sorry, time is up.
Yeah, I'm coming to the end. Wait a moment. And this is the last one. We just need to understand and come back to hierarchy of factors influencing safety of clinical practice. Institutional context, organization, work environments, team factors, individual staff factors, task forces, patient factors. All those factors influencing our decision to discharge or not discharge your patient. Thank you for your attention, references. Thank you.
Thanks for your excellent presentation. Dear participant, is there any question? Unfortunately, one question, I think, or contribution?
No.
Okay, thanks.
Right, well, we'll let you all have your coffee break and see you again in 20 minutes or so. Thanks.
For the great presentation. I am Dr. Samir. I want to ask you, Doctor, do you use fibrinolytic therapy in the pre-hospital setting or care here in Turkey? Fibrinolytic therapy, or do you use tegretol or clopidogrel in the pre-hospital? or if there is any study about to use it?
Sorry, I cannot hear it. The voice is very, it is not clear to me.
Hastane öncesinde fibrinotik kullanıyor musunuz diye sordu.
Yok, buraya sesi iyi gelmiyor.
Okay.
Geliyor da.
Do you use fibrinolytic therapy in the pre-hospital care in Turkey?
Yes.
Or,
Hocam siz cevap vermek istiyorsanız.
Yani siz de söyleyebilirsiniz geneline, çünkü Türkiye'nin genelini soruyor. Ben çok her tarafa biz de hakim değiliz çünkü sonuç itibariyle.
If your diagnosis is clear, is actually clear for pre-hospital, you are talking for pre-hospital, isn't it?
Yes.
Okay. If your diagnosis is clear, you have an ECG, and in ECG the patient is ST elevation or non-ST elevation, it is possible to start to initiate this fibrinolytic treatment for pre-hospital. But actually, it is not common. It is not common. Some centers are using it. It's possible. There is no contraindication to use it.
and maybe there's
We do it.
comment from my side. Sometimes if we have STEMI elevation,
Yeah.
I think it's better to take the patient to cath lab direct without emergency department, so you save the time for it. Because we have in our practice, we have advanced unit who use ECG and STEMI, and we be on telephone or online with the cath lab if they have same this patient.
You are completely right. We are completely agree with you because the time is very important. That is mentioned in this slide. We have to do it. We are using it, but not the common.
Okay, thank you very much. Thank you.
Any comment or question from the audience? We have foreigner listeners.
İngilizce geçiyoruz.
Evet. Ben sorayım o zaman. Yani salona sormak istiyorum. Biraz basit bir soru olacak ama acil serviste bunları başlamayan bir bölüm var mı? Niye sordum bunu? Çünkü bazı yerlerde kardiyologlar yapmayın biz başlayacağız. Serviste biz anjiyografide biz vereceğiz falan. Öyle yapan yerimiz var mı acil serviste? Olmadığını düşünüyorum. Olmaması gerekiyor. Demek ki yani doğru yoldayız. Bunu tekrarlıyorum. Bazı yerlerde kardiyologlar siz vermeyin. Biz işte anjiyografide vereceğiz. Serviste çıkınca vereceğiz. Ve yoğun bakıma çıkarınca vereceğiz. Böyle bir şey yapmayacağız. Burada zamanın ne kadar emniyetli olduğu burada vurgulandı. Dolayısıyla acil servislerde bunu başlayacağız. Başta bir şey söylemiştim. Onu sormak istiyorum. Anjiyografinin de acil serviste yapılması gerektiğine inanmayan var mı? Çok güzel. Herkes istiyor, değil mi? Buyurun.
Doktor Akkan ben şehir hastanesinde, Adana Şehir Eğitim Araştırma Hastanesi'nde çalışıyorum. Şimdi şehir hastanelerinin büyüklüğünü biliyoruz yani yüz ölçüm olarak. Biz ilk taşındığımızda anjiyo ünitesinin acil servise mesafesi yaklaşık bir kilometrenin üzerinde. Ve asansör kullanıyorsunuz. Bayağı uzun koridorlardan geçiyorsunuz.
Acil servisten 1 kilometre ötede.
Ötede koroner
Başka bir mahallede
ünitesi.
yani.
Evet biz mesela B bloğun biraz daha iç şeyindeyiz, bacağındayız. İşte koroner anjiyografi ünitesi 2 kat yukarıda ve A blok. Diğer tam tersi bir alanda bulunuyor. Şimdi bu mesafe tabii çok önemli. Bizim gece saat 2'de 3'te arrest nedeniyle gelip döndürdüğümüz zaman dirençli fibrilasyon nedeniyle işte hastayı transfer ederken anjiyo ünitesine birkaç kez defalarca defibrilasyon uygulamak zorunda kaldığımız ama buna rağmen kurtarabildiğimiz hastalarımız oldu anjiyoya yetiştirirken. Şimdi siz bunu söyleyince direkt 1-1,5 yıldır bu yaşadığımız mesafe sıkıntılarından dolayı aslında acil servislerde özellikle şimdi bir de ülkemizde şehir hastanelerinin yaygınlaşmasıyla beraber bunun ciddi gündeme gelmesi gerekir. Acil serviste koroner anjiyografinin olması bu önemli bir adım olacaktır. Ben bu anlamda hem şeyi söylemek isterim. Bir de ayrıca aslında biz hastane öncesi fibrinotikten önce hastane öncesi acil sağlık hizmetlerini yürüten arkadaşlarımızın aspirin kullanımı konusunda ciddi eksiklikleri var. Yani fibrinolizisten önce aspirinin kullanımında çok ciddi uygulama problemleri var. Ben sahada çalışan bir acil hekimi olarak gelen...
Destekliyorsunuz bunu.
Destekliyorum bir. İkincisi şunu sahada gördüğüm eksik. Gerçekten göğüs ağrısı, alt koroner sendromla gelen hastalara ne yazık ki hastane öncesinde aspirin dahi verilmiyor ne yazık ki.
Teşekkür ederim. Sağ olun. Şimdi burada bu konuyla ilgilenen firmalarımız var biliyorum. Ben herhangi bir firma veya ajan ismini zikretmeyeceğim. Ama yılda 139 milyon acil servis başvurularının olduğu bir yerde, bir ülkede ve bu akut koroner sendromu hastaların ilk başvurduğu yerlerin acil olduğu bir yerde ki gayet doğal bir şey. Yani bu firmaların veya bu ajanları bu ülkede satışa sunan firmaların nerede durmaları gerektiği, hiç çıkmamaları gereken yerin neresi olduğu, kendilerini çok iyi tanıtmaları gerektiği gayet net bir şekilde anlaşılıyor. Sanırım onlar da bu durumun farkındalar. Değillerse de olmaları gerekiyor mutlak surette. Adeta acil servislerin etrafında nöbet tutmaları gerekiyor. Başka bir soru daha alalım. Evet, şurada bir soru daha var.
Ben İstanbul Bakırköy Devlet Hastanesi'nden Doktor Taha. Ben de az önceki katkıya benzer bir katkıda ve gözlemde bulunmak isterim. Elbette ki bu konudaki araştırmalar çok değerli. Fibrinolitik tedaviler, antitrombotik tedaviler ve bunun farmakolojisi, bunun ekonomisi çok büyük ve değerli. Çünkü bu hastaları daha öncesinde müdahale ederek daha morbid ve mortal gitmesini önlemek devletlerin işte sağlık politikalarının, ekonomik harcamaların da önüne geçmek açısından değerli. Ama bence bundan daha değerli ve önemli olan bir şey var ki sizin de bahsettiğiniz gibi acil sağlık hizmetleri artık bu konuda primer temas noktası oldu bizim ülkemizde veya acil tıp olan birçok ülkede. Biz kardiyologlardan veya kardiyoloji eğitimi alan eğitim araştırma hastanelerindeki asistanlardan veya alandaki herhangi bir kardiyoloji uzmanının olduğu merkezlerde göğüs ağrısıyla gelen sizin söylediğiniz sayıdaki hastalarla direkt temas eden klinik bizleriz. Dolayısıyla bu hastaları öncelikle görüp tanıması gereken, tanımadığımız zaman çok kötü sonuçlara giden, sonuçlara ne yazık ki olabilecek yerler de bizleriz. Bence bu yüzden çok over diagnoz gittiğimiz bu şartlarda işte beta anjiyoların artık acillerde bile neredeyse beta anjiyolar çekilebilecek hale geldi. Veya markerların güdümünde gittiğimiz bir yerde bizim için hem farklılık oluşturan hem de en önemli şey olan ki öyle bir tanı var ki unstable angiopectoris diye hiçbir marker veya görüntüleme olmadan sadece hekimlik bilgisi, tecrübesi ve olaya olan şeyiyle, efektivitesiyle tanı koyulacak bir şey. Angina pectoris'i bile tanıyamadan bu konudaki kötü sonuçlara neden olmamamız için bizim bu konuda çok daha dikkatli olmamız lazım. Bu farmakolojik şeylerden önce diye düşünüyorum.
Evet, teşekkür ediyorum. Evet, kısaca yani Yunus Hocam'ın bahsettiği şeyi iki cümlede söylemem gerekirse yani benim anladığım kadarıyla akut koroner sendromlarda etkisinin daha erken başlaması ve komplikasyonların daha az olması nedeniyle şu anda ticagrelor hakikaten önde görünüyor. Zaten çoğu merkezde aynı ajan kullanılıyor. Biz kendimiz de aynı şeyi kullanıyoruz. Eğer başka bir katkı yoksa ben bu oturumu kapatmak istiyorum. Çünkü hemen diğer oturumlara geçeceğiz. Bu arada bir şey duyurmak istiyorum. Biraz önce şurada da yansıdı. ATÜDER borç sınavı, 3. yazılı borç sınavı 12.40'da B salonunda yapılacak. İlgili olan uzman arkadaşlarımızı ve asistan arkadaşlarımızı duyurmak istiyoruz. Yunus Hocam çok teşekkür ediyoruz tekrar.
Ben teşekkür ederim.
Sizlerin de katıldığınız için sizlere de çok teşekkür ediyorum. Çok sağ olun.
just test the sound as well?
Of the end. But it is perhaps the end of the beginning. This is not the end. It is not even the beginning of the end. But it is perhaps the end of the beginning. This is not the end. It is not even the beginning of the end. But it is perhaps the end of the beginning.
something sweet. My daytime dress, your rolled up sleeves. There's something about your slick back hair. I feel the magic in the air. I can show you pretty things, waves on water glistening. Just take a breath. I can show you charm and style. We can go for miles and miles. No, don't forget, it's glamorous, so glamorous. It's glamorous. It's glamorous, so glamorous. It's glamorous. Diamonds in the sky, lovely lullabies. You know how I love to keep it classic. Sunsets on the sea, color change leaves. You know how I love to keep it classic. You know how I love to keep it classic. I can show you pretty things, waves on water glistening. Just take a breath. I can show you charm and style. We can go for miles and miles. No, don't forget, it's glamorous, so glamorous. It's glamorous. It's glamorous, so glamorous.
Welcome everyone to the afternoon session, starting with resuscitation. So we've got an exciting lineup for you today with some great speakers. I'm Paul Pajot from Canada, and this is Dr. Luis Garcia from Spain.
Thank you, Paul, for the introduction. Today we have the pleasure to have a group of speakers that are not only well-known but also friends of us, so it's a pleasure to chair and co-chair this session with two Pauls, I would say. So, to be on time, because we are a few minutes out of schedule, we are going to start with the first speaker, and I have the pleasure to introduce you Paul Kibela. He is the past president of ACEP, a well-known and friend of all of us. So please, Paul, you have the floor.
Well, thank you very much. I was asked to speak today about airway management. And in the United States, I do a lot on risk management and air reduction. And airway is one of the most stressful events that actually happen in the United States in the emergency department. In fact, in the hospital. And we talked a lot with my colleagues here, Luis, about what is value. And in the United States, the value of an intubation has been increased 3 times because of that stress value. And what I'm going to try to do is talk to you a little bit about how I approach a difficult airway and what to do when everything goes wrong. And I think the important thing here is to remember that there's a lot of options and there's not one single option, but you should have a strategy of how you deal with airways. You know, some airways that are going to be challenging when they come in. When you have the little old person that is flexed at the neck looking forward and has severe arthritis, you might want to anticipate a problem. And in the United States, we have a tremendous problem with obesity. And we will have patients come in sometimes that weigh 300 kilos or 400 kilos. And putting an airway in those patients can be extremely difficult. And so I'll talk about some of the strategies there. The other thing that can happen is patients can come in where they might have an airway problem. And there's some violence in Turkey, and this is my wife beating up a Roman gladiator at Aspendos. And so they might come in like this. And you don't know if this is going to be an airway problem or not. But with a broken jaw, with a crushed airway, they can oftentimes have a problem, so you have to suspect it. The other thing that happens, and this happens relatively commonly, unfortunately, as well, it's happened to me 4 or 5 times in my career, is you go into the airway and there's some type of cancer or a foreign body obstructing that airway. And that's when things get a little more scary because you weren't anticipating having a problem. And I'm sure in Turkey and the rest of the world, we all have a tremendous number of intubation assist devices. Pretty much everywhere, even when I go into Asia, they don't have a lot of technology, but they have glide scopes, they have CMAX, they have a lot of different devices. They also have LMAs, they have nasal airways, they have oral airways, and they have different types of stylets. In the US also we have basically flexible bronchoscopy that we now use to intubate as well. And I think the thing here that, again, I want to implore upon you is to really figure out what is easy for you and not to try to master all of these devices. And I think they say, they have an idiom that if you try to master or you try to learn everything, you will be a master of nothing. And you will lead to problems. So my personal favorite is the bougie. Why? Because it's usually always available every place I work. It's inexpensive and it's relatively useful to intubate around a tumor, to intubate, and it's sturdy enough that I can intubate if someone's bleeding blindly. So that's something that is my strategy. And if I that, I will go to a surgical airway, and I'll spend a little bit of time talking about that as well. Still, if you do everything right, everything can still go wrong. And so one of the things that I want to implore upon everyone is, again, to look at whether this is an airflow problem, whether it's a breathing problem, whether the person is oxygenating, and so certainly monitoring is important. If the person is oxygenating and they're exchanging airway and you have a CO2 detector monitor on them, you have much more time than if their pulse ox is dropping quickly or they're accumulating oxygen, or accumulating, carbon dioxide. So that's the panic mode there. If they're oxygenating, the frequent thing that I do is to take time and reposition the patient. I think the main problem that I've seen when I've seen other people have problems intubating, they are not positioned appropriately. What happens oftentimes is their head is off to the side, or if they're obese, their airway is not opened all the way up and they're not dorsiflexed at the neck. So that is one of the problems. The second problem that I've seen is a lot of our patients, if I go to intubate them, guess what? They've been intubated before. And oftentimes from the trauma being intubated before, their airway may be narrowed already. And sometimes we also have now patients that come in. We're at a tertiary care center, and the patients are much older. They often have cancer and sometimes diabetes, and they've even had abscesses in the airway, which is highly problematic. The other issue that we're facing in the United States right now is a lot of our patients are no longer vaccinated. And so we're seeing some of the disease processes, including epiglottitis, that we thought were eliminated many, many years ago. So these things are all coming back to us. One of the things that I've learned particularly, and hopefully you don't have the same amount of problems that we do in the United States, is our patients can be very, very obese. They're very large, and getting an open airway can be a challenge. And oftentimes, if you don't have the right equipment, that can be very, very difficult. And I've been called to the floor one time when the anesthesiologist was unable to intubate the patient. The anesthesiologist actually left as I got there and ran to the operating room to get more equipment. I went in, positioned the patient appropriately, put something underneath their shoulders, got their head dorsiflexed, and I was able to intubate. And by the time the anesthesiologist had came back with the equipment, I already had the patient intubated, and I had left and gone back to the emergency department. So again, I think the important thing here is to make sure that if you position the patient appropriately, you can eliminate a lot of the problems. And if the patient's oxygenating, you have time to do that. As I mentioned, it's certainly helpful to have a monitor on the patient. One of the things that we do is fortunately, we oftentimes have respiratory and other therapy that are able to help us monitor so we know how much time we have. Because I think the important thing here is also not to panic in these situations, even though this can be an extremely stressful situation. So if the patient's still not oxygenating and there's still an airway exchange issue, you can try these various devices. As I mentioned, my favorite is the bougie. I can work that around a lot of tumors, around a hematoma, around an abscess, and that works well for me. And one of the things I try to do every year is, even on a normal patient, I try to practice using that bougie. And I would recommend all of you that if you're going to have a strategy, that you practice it. Because if you don't practice it and then you have to use it, that can be as stressful as having nothing at all. So again, whatever strategy you use, I think it's important to practice that at the same time, even on normal patients, even though you may not need it, because when you need it, you need to be able to feel comfortable using that procedure. Some of the other things that happen, again, is bag valve mask. Oftentimes, I've gotten to patients and they seem to be oxygenating appropriately, and I've been called in to say, do you need to intubate this patient? Well, if their oxygen is okay and their carbon dioxide is okay, the question is, do they really need to be intubated? Oftentimes they do, but sometimes if the patient is actually on medications, sometimes we can forego that. So there may not need to be that necessary. I know a lot of my colleagues actually use LMAs or oral airways just to maintain that until they find out whether the patient actually truly needs to be intubated. Nasal airways, I have to say, I grew up with those. I rarely use them anymore. Why? I think we're all forced to kind of move to a definitive airway. And I can understand that as we have less and less support resources, that oftentimes that's the way we go, or oftentimes we go to CPAP or another type of airway addition. There are some people that use a retrograde airway. And I have to say, I've practiced this before on models and mannequins, but I've never actually done it. And so I'd be very hesitant in an emergency situation to do something that I really haven't done or feel comfortable doing. And certainly the thing that you always need to be ready to do, and this is my go-to, is to go to a surgical airway or a cricothyroidotomy or even a tracheostomy. The issue here with this is when everything fails, the surgical airway, you need to be able to feel comfortable to do it and to do it very, very quickly. You know, certainly the patient that we have that has airway hemorrhage, it's like the patient that had the trauma. When there's a lot of blood back there in the back of the airway, a lot of these fiber optic scopes, a lot of these intubation assist devices are not very helpful. Secondly, when you actually go to open the jaw and the entire face moves, that's also a patient that you want to be very careful. You can sometimes intubate orally, but oftentimes it's a problem. The other thing that rarely happens is we do have patients with facial cancers and laryngeal cancers where their anatomy, you look in there and you don't even know what you're looking at. And that can be further problematic. We also have several patients that will come in with either allergic reactions or genetic problems where they actually can develop edema in their airway. And certainly the thing that I see probably most commonly here as well is unfortunately is tumors and abscesses that honestly I never saw in the first part of my career, but I tend to see more commonly. Some of the problems of not doing these include, young of age. So if there are absolute contraindications, there's anatomy, there's hematomas, and obviously coagulopathies. The other thing is, once you have to decide is if you're going to go to a surgical airway, you have to decide what to do. Classically, as emergency physicians, we're trained to do cricothyroidotomies. And that is an easy airway, relatively speaking. How many have you done a cricothyroidotomy? A number of you have. How many of you done a tracheostomy? And I think the challenge here, not a lot of you have done it, is one of the problems that you have is when you look in the airway, and if you cannot see the cords and something's coming from behind the cords, you're going to have to decide whether you should try a cricothyroidotomy or go to a tracheostomy. Unfortunately, I've had patients before where I looked and I could see the tumor coming from behind the cords towards me. And I knew at that point in time that had I done a cricothyroidotomy, I'd very likely be cutting into a tumor and potentially making the dry airway that's occluded now a bloody occluded airway. And so I think at that point in time, you have to be comfortable not just being able to do a cricothyroidotomy, but also to do a tracheostomy. It's interesting, as I did this lecture, that a tracheotomy was actually described centuries ago, that had been done with airway obstructions and had been done successfully. So this is not a new procedure. This is not a complicated procedure. It does not require a lot of technology. It's really an issue of understanding the anatomy and feeling comfortable doing this. And I think that's the important aspect here. There's a lot of kits out there in the market, and in the United States, it seems like every year there's a new kit in the emergency department that I'm not familiar with because they've changed it since every time someone does one, which is relatively uncommon, there's a new kit. Personally, I've opened up the kits and I didn't even know what was inside half of them. I personally like it if it's very, very simple. I try to use either a tracheostomy tube or a 6-0 ET tube. I try to use an 11-blade scalpel if it's available and a pair of hemostats. A lot of people said, well, there's suture material. Well, heck, if I just get the airway in, we'll figure out how to secure it later. I've used tape, I've used suture, I've used a lot of different things to try to hold it in place. I've had people just hold it in place till the patient got to the operating room. So there's a lot of different options there. So for me personally, I'm a pretty simple person. I like it basic. I wish they just gave me the basics of a scalpel and hemostats and some material to clean the area rather than a complicated kit that I'm not sure what's going to be inside. The steps are also relatively easy, and I think it behooves all of us to understand the anatomy. And some of the problems is sometimes is that if you get an obese person, you're not going to feel any anatomy. So oftentimes when I've done that is I'm feeling it on myself, judge approximately where that is, make a larger suture. If you can feel the cricoid membrane, I've done it with as small as a 2-centimeter vertical incision. But sometimes in a larger person, I've done 5 or almost 7 centimeters to cut down to where the cricothyroid membrane is. And once you visualize it, honestly, maybe I've been pretty lucky. And again, it's positioning the patient in the right manner. I found it relatively simple, and honestly, it looks very, very similar to this when I've found it. The third step that I do is I actually use the scalpel. I make another vertical incision there, and I use the back end of the scalpel. And then what I do is I either insert that tracheostomy tube or I use a set of hemostats, and I then place the tube in there, and making sure always to go caudal towards the person's feet. You want to not make sure you're going up cephalad, because you can actually wound or injure the vocal cords. So if you make sure you're always going down lower, I've never really had any of the bleeding problems that people talk about. But again, I think the important thing here is, again, positioning and stay completely in the midline as always. I'm not sure I'm going to the next slide here. I think I'm frozen. Oops. I was going to have a video here, but I think I'm having some Turkish internet issues here with a link. Here we go. Anyways, the video is very similar to this. It shows the procedure in action, but it can go very, very quickly. And I think, you know, this is how I would do things, and I would be prepared to do this. And if you don't do this every 3 or 4 years, I think the important thing is to actually practice this. Do it on a mannequin. Do it on a cadaver. Have you done cadaver labs, any of you? If you have an opportunity, or if you come to the ACEP meeting, they actually have live cadavers. And to actually see this in person is something that's worth at least looking at every couple of years, just because it's such an infrequent procedure. But again, it can be extremely life-saving. And here, I invite you again. I know a lot of people have invited you to their courses. The American College of Emergency Physicians meeting does have a cadaver lab where they do practice cricothyroidotomies there, and you can actually do one on a cadaver. I'd encourage you to sign up for that early, as that's one of our courses that sells out every year. And again, encourage you also to even consider international membership in ACEP. And I think I have a minute here for questions, or I can hold them for the end. Thank you very much. Takashura Dira.
Thank you, Dr. Kivela, for your clarifying presentation. Is there any question from the audience? If we have some time at the end, we will put all the questions together to save time. So thank you again. Now, our next speaker is Dr. Paul Paquet, the past president of the Canadian Association for Emergency Medicine, that is going to introduce us in the world of extracorporeal cardiopulmonary resuscitation. The floor is yours, Paul.
Thank you. Thank you. So it's an honor to speak here today, and thank you to Dr. Basar Kandar for asking me to come. It's actually it's a topic that was relatively new to me, extracorporeal cardiopulmonary resuscitation and trauma, and the initial title had when to initiate, but I would add also if to initiate. So I'm from Ottawa. It's the capital of Canada. It's a beautiful place. In Canada, we have universal health care, where we have a single payer, which is the government, for all essential health services. So there's often quite a balance between universality and accessibility. We place a high value on, or we value the cost per life saved and the cost of morbidity prevented. This is where I work, at the Ottawa Civic Campus of the Ottawa Hospital. It's a tertiary care facility, level 1 trauma. We have cardiac surgery, we have primary PCI, and we have a cardiac ICU. So coming from that lens, the objectives of the next 20 minutes here is describe how extracorporeal cardiopulmonary resuscitation can be used in severe trauma and traumatic arrest. Identify which trauma patients may benefit from ECPR, and recognize the system resources for ECPR in traumatic arrest. So I do have to oversimplify things, and my apologies to those of you who use ECMO and ECPR already, but essentially ECPR is the use of ECMO as a resuscitation tool. And we all know our major traumas and how chaotic that can be, and we're adding in another complexity to that chaos. Again, to oversimplify, I'm going to talk about the two main types of ECMO that are used in the emergency department. The veno-venous ECMO, which involves a line in the femoral vein and a line in the upper central vein. Basically, it's taking blood from the IVC out through the femoral vein, running it through an oxygenator, and then pumped back into the SVC through a central vein in the upper body. Veno-arterial ECMO is a little bit different. In the emergency department setting, this often involves two lines in the groin. So a line in the femoral vein, which again draws blood from the IVC, runs through a pump, an oxygenator, a gas exchange, and so temperature regulation, and then inserted back in through the femoral artery and deposited in the mid-artery, where through retrograde flow, it perfuses the brain and the vital organs. So one important concept with ECMO and the emergency department is ECMO does not heal, it buys time. And I think we've seen this best with our out-of-hospital cardiac arrest. Although the data is accumulating and not definitive, it does demonstrate that ECMO in the refractory VFib arrest may play a role. It's actually buying some time until you can get a primary PCI for that patient, and there's been some extraordinary results. I would say, though, there are defined patient populations where this works best, and I'd keep that in mind as we think about the traumatic patient. So through a fairly large registry, Debetti et al. From France looked at hundreds of patients and found that there were some indicators of success. And these include less than 10 minutes of no flow state, which is no CPR, and less than 60 minutes of CPR would benefit most. There's also some biochemical parameters, which include a pH of greater than 7 and a lactic acid less than 13. There's another interesting phenomenon that also Debetti talks about is the signs of life. So that's a patient that, while CPR is ongoing, you get some pupillary restriction. You also get perhaps some movement, and I think we've all seen this when we've done CPR. The patient seems to be responding even though they have a non-perfusing rhythm. Or the other indication would be agonal breathing. So all these things together tell us that the patient may have a very good outcome. And in Canada, we deal with severe hypothermia, perhaps more frequently than other places in the world, and ECMO has played a successful role in that as well. So let's turn back to trauma again. So the veno-venous ECMO in trauma. There seems to be the best data, and that's been summarized by Bosarge et al. In 2016, mainly in ARDS, severe pulmonary hemorrhage, transfusion-associated lung injury, and lung contusion. So these are all gas exchange problems that it's been shown benefit. In veno-arterial ECMO in trauma, I think it's very debatable whether it's helpful. Perhaps this plays a role in cardiogenic shock in your trauma patient, refractory shock in your trauma patient, the one you can't get ahead of with your blood products. Perhaps it's a bridge to damage control surgery. One of the issues with ECMO and why it's not been looked at for many years is ECMO does require systemic heparin. And that is probably the last drug I want to give my hemorrhaging trauma patients is systemic heparin. But there's been advances over the years. There's heparin-infused lines in the ECMO circuitry. And there's been some case reports of running ECMO in the severe trauma patient without systemic heparin, and there's been some success. Again, not randomized controlled trials, but some reported success, and Mullenbach summarized that in 2012. So let's talk for a minute about the lethal triad of trauma. We know with poor perfusion and hypovolemia, we get acidosis. From that acidosis and from the other aspects of the trauma, the blood loss, you'll get hypothermia, and that affects your coagulation and you become coagulopathic. Further bleeding, causing poor perfusion, more acidosis, and the cycle goes around. So I want you to think for a minute the concept of taking physiological control of the patient. So controlling some of these factors so that you can change this spiral. The example would be you improve perfusion with a veno-arterial ECMO. In there, you would have less acidosis, you'd have better myocardial perfusion, you can control temperature as well and have less hypothermia and have decreased coagulopathy. So this is Dr. Magnus Larsson from Sweden. He has been championing this idea of taking physiologic control of the patient, and he's seen here with one of his ECMO survivors, by instituting ECMO in the severe trauma patient. But he's only shown most success with rabbits, unfortunately, at the moment. his experiments to this point have involved traumatizing a rabbit, removing half their blood volume, and then waiting for an hour, and then either routine post-rabbit trauma care or routine post-trauma care with ECMO. And he's actually proven that point in animals, that if he takes physiologic control, he'll drastically improve their outcomes. And he summarized that in 2016. So he's now working on human patients. More on that to come in the years, I'm sure. So the next thing I want to consider is traumatic arrest. So imagine for a minute you're penetrating trauma patient, and either just before arriving to your emergency department or as they enter the emergency department, they go into cardiac arrest. No, ATLS guidelines do tell us that we have a systematic approach to these patients, but I would argue that CPR in a low volume state is not very effective, and I'm not sure if anybody else has had success with closed compressions on an empty tank. But I think we still do have this systemic approach to these patients. We're infusing as much blood products as possible in a 1-to-1-to-1 ratio of blood cells, platelets, and plasma. We do bilateral needle decompressions or finger thoracostomy in the 5th intercostal space. We do emergency thoracotomy, usually on the left-hand side. And if we see a cardiac pericardium full of blood, we open that and hopefully release cardiac tamponade. If we see a major cardiac injury that we can repair, we might do that, or potentially a major vessel. From there, internal cardiac massage, cross-clamping the aorta, and potentially internal defibrillation. You may end up at this at the end of your algorithm. Basically, a non-beating heart, an open chest, and you're wondering, that's it, what are we going to do now? And I think you're right, and that's often the endpoint to many of our patients who go through this trauma pathway. But there's some interesting things. This is actually where we get a little bit experimental and perhaps science fiction. There's a concept of suspended animation. So Tischerman in Baltimore is working on a protocol at the moment where he takes these patients and he cools them immediately to 10 degrees, takes them to the OR, damage control surgery to repair and improve hemostasis, and then puts them on pump. So it does sound a little bit unreal, and he's not had data to report yet, but the trial is ongoing. And although they look really friendly, these two gentlemen essentially are operating on cold, dead bodies with the goal of improving outcomes. So I just want to go through their algorithm just to give you a sneak idea of what's coming. It's actually quite fascinating what they're doing, and it's initially funded by the US military. So a patient has a traumatic cardiac arrest. They have an ED thoracotomy. No response from that. It meets their criteria for enrollment, and the team is available. Then the aorta gets cannulized through the open thoracotomy. Immediately flushed with cold saline, and the patient's cooled to 10 degrees. They're transported to the OR. Hemostasis surgery is attempted. And then they're put on cardiopulmonary bypass pump at that point and rewarmed. It sounds a little bit quite astounding that may happen. They are showing some results in animal studies and ongoing recruitment in patients. And these are patients that would be non-salvageable after their open thoracotomy. It requires a huge team. So not only with this protocol, but with all ECMO, you need a coordinated and well-functioning team if you want to use ECMO in the emergency department. And remember, this is a setting that is often can be quite chaotic. You of course need your emergency physician, you need your trauma and cardiac surgeons, perfusionists, trauma anesthetists, and your ED and OR nurses. It's suggested actually that a lot of simulation training is done for providing ECMO in the emergency department, and repeated simulation training, and mapping out what each step is along the way. So, in summary, ECPR is essentially ECMO in the trauma emergency department, or ECMO in the emergency department. In the trauma setting, acute lung injury with refractory hypoxia appears to show the most benefit with the best evidence. However, I look forward to the future where we may see ECMO used more freely in the exsanguinating multi-trauma patient to control that physiological spiral of the lethal triad. And potentially even in the future, we can look at traumatic cardiac arrest and the role of ECMO for these patients. Thank you. And here's some resources for you.
Thank you, Dr. Paquet, for your clarifying presentation and for putting us the view in the future and how can be the treatment of these very specific patients. Is there any question from the floor? Again, at the end of this session, we will have some time to put all the questions together, and if there is anyone. Thank you, Dr. Paquet, again.
All right, now I'm wearing my other hat. So as the next speaker prepares, I'll take a moment to introduce them. So many of you know Dr. Roger Dickerson. He's an emergency physician and intensivist. He's recently relocated to beautiful Cape Town. He's the past president of the College of Emergency Medicine of South Africa. And I'm really looking forward to him answering this question of, is adrenaline falling from grace? Please welcome Dr. Roger Dickerson.
Paul, thank you so much for that very warm welcome. It is an absolute pleasure to be in Antalya once again and to be able to catch up with people who've become fast friends. But let's get going. Just to get a bit into the mood, did anyone find their pulse rate rising a little bit when they heard that music? You could say that's adrenaline. This is my hometown now, and in fact this is my hospital that is based right in the Cape Town waterfront and sits squarely between the Cape Town waterfront and Table Mountain. But what I'm going to be focusing on for the next 45 years or so is whether adrenaline is in fact falling from grace. And it is in fact a difficult question to answer. I don't have anything to disclose other than the fact that I am an emergency doctor, and I come with the requisite warnings that need caffeine in order to maintain function. In the beginning, there was death, and we didn't know what to do. And it created great stress in our lives because we were not able to manage this concept of death, to prevent death, or get people back once they had already in fact died. And this created great stress in our lives. We didn't know what to do. And then came a fantastic moment. And this moment brought together several unique factors. And it was the year 1898. And what in fact we saw was the discovery of radium by Marie Curie. We saw the patenting of cornflakes by William Kellogg's. We saw the proclamation of the city of New York. And we saw the land speed record being set at a blistering 66 kilometers per hour. But it was the same year that adrenaline was first postulated for the use in resuscitation in humans, following successful studies in animals. And we got onto this bandwagon. We said, yes, we want adrenaline. We are going to use adrenaline. And in fact, from the 1960s, adrenaline has become part of every single resuscitation protocol available to us. And we saw this, that we were going to go beyond. We were going to explore. We were going to win over death. And we were excited. We looked up to the heavens and we found that we were able to have an answer to this age-old problem of preventing death. But with all God sends come problems. And the problem is that we didn't really know how and when we should be using adrenaline. And every institution around the world produced, seemingly based on science, produced recommendations on how to use adrenaline. And the difficult part was that each and every one is different. All based in science, apparently. And my country is just the same. We've got 2 different protocols that are in circulation, outside of those coming from the American Heart Association and the European Research Council. And so we didn't know what to do. So we just went. We said, we are going to go, go, go, because that's what adrenaline does. We'll go, go, go. No one is going to stop us now. But maybe the time has come to stop. Not go, go, go, but rather stop. Stop. Stop. Because perhaps we are actually like the plague doctors from medieval times, when people and clinicians in the future will look back at us and go, can you believe that they used to use adrenaline? Would we want to be in that situation? Each year, the International Liaison Committee on Resuscitation brings out recommendations seemingly based in science. And year after year, we read them. We interpolate them into our management. But the more things change, the more they stay the same. And these are the statements that come from all of the major research councils around the world saying, use adrenaline in resuscitation. So we have a problem. And that problem is our world is about to be shattered. Our minds are about to be shattered because everything that we've known to be true and dear regarding the use of adrenaline is about to disappear. And it's really because we have been like those plague doctors from the years gone by who said, use adrenaline in 1898. And I'm wondering, should we give adrenaline? And that question is, should we? Not shall we any longer. And this has really come on the background of some recently published information. Now, the whole difficulty with research around adrenaline has been very similar to the research around parachutes. Do you know that there's never been a randomized controlled trial demonstrating the efficacy of parachutes? Because no one wants to be in the control limb of not having the parachute when you jump out of the aeroplane. And adrenaline and research has been a very similar problem, is that adrenaline is so entrenched in what we do that how would we ever go about not using it? Would you be the one in the control limb who does not get adrenaline? And so we carried on. We've always just used adrenaline, so let's continue using adrenaline. But in August last year, the cat jumped amongst the pigeons. And that was really with the publication by the Paramedic 2 research collaboration, where they looked at a randomized controlled trial regarding the administration of epinephrine or adrenaline in out-of-hospital cardiac arrest. A great trial, large trial, but scary conclusions. Because what the conclusion stated, that while there were an increased number of survivors in the adrenaline group, they had poorer neurological outcome than those who did not receive adrenaline. And so what this trial demonstrated is that adrenaline makes no difference. Now, we've had this before. We get all excited about one research trial and we jump on that bandwagon and say, no, stop, no. Don't use adrenaline. We are never going to use adrenaline before. We use it again. It is bad. We were plague doctors to have done it. But what was quite interesting is that Chris Goff and Jerry Nolan, just prior to the publication of this Paramedic 2 trial, published a meta-analysis looking at the efficacy of adrenaline in resuscitation. Because we were worried, what do we do now? And so they said, keep calm. It's important to keep calm. And no, maybe not that calm, but we do need to take a step back. And it was quite an eloquent publication that Jerry and Chris published in the Journal of Critical Care. And there are two important scatter plots that I'd like to show you. The first in this meta-analysis looked at the achievement of spontaneous circulation. So ROSC was achieved. And you'll notice that through this meta-analysis that it certainly favors the adrenaline group. Great. Phew. we've been doing things right, it's okay. We can give adrenaline in resuscitation. Not so fast. What they also demonstrated was that through this meta-analysis, that you'll notice that if you want a good neurological outcome, do not give adrenaline. And this was prior to the publication of the Paramedic 2 trial, and so it becomes a difficult decision to make. Do you want them to be alive, or do you want them to be functional? Because that is the decision on whether you want adrenaline or no adrenaline. And it's scary. I didn't know what to do. I'm worried. Now, following the publication of Jerry and Chris's editorial and the publication of the Paramedic 2 trial, ILCOR published a statement saying, actually we do realize we've got some knowledge gaps with regards to resuscitation science. And one of the things that they pointed out under the advanced life support limb is that we don't actually know if we should give adrenaline. We don't know what dose we should be giving it, and we don't know at what time frame we should be giving it. Now, I say to you, if I was registering this drug for use now, and I told you I've got no idea if it's of benefit, I don't know the dose, and I don't know when to give it, who here would say, I will give that drug? No one. And that's the difficulty that we face, is that we have no idea regarding the safety, the timing, and the dosage of adrenaline. What they did say, however, is that until we are able to prove that adrenaline is functional, we shouldn't actually be worrying about doing studies that relate to dose, unless it is part of a controlled trial. And again, I don't know what to do now. This is the end of my world. I've been using adrenaline for 30 years. And I've been giving some of it to my patients. Is it the end? Is it the end of adrenaline? I think this man has put it best.
This is not the end. It is not even the beginning of the end. But it is perhaps the end of the beginning.
And so the question that we need to ask is, what do I tell my poor medical officer who is now completely exhausted by the fact that we don't know what to do? And so I wonder what I'm going to tell my staff, because we tend to chase ROSC as the primary outcome, when perhaps what we should be chasing is an appropriate neurological outcome. We need to be experts in resuscitation, that there's no doubt. But we really do not need to be experts in reincarnation, because I have to say, not me, but what am I going to do? Am I going to continue with adrenaline based on the literature that has been published? And it is now amounting to the fact that I should probably not be giving adrenaline? To be honest with you, I don't think I'm that brave. I will still use adrenaline, because whilst we do have poorer neurological outcomes, we do have a higher return of spontaneous circulation. And you're not going to have a chance of a good neurological outcome unless you have some kind of response or return of spontaneous circulation. My question, of course, is that's what I'm going to do. What about you? What will you do? Can I get an idea? Who here uses adrenaline now? Hands up. Interesting. Who here then does not use adrenaline in a cardiac arrest resuscitation? I notice that there's some people who haven't put their hands up in either group. So either we've got a confusion about the question, or it demonstrates that there is such confusion about the literature that we really don't know what to do. And so to wrap up, ladies and gentlemen, my take-home message is critically evaluate the literature that comes out, look at it and see how it is going to change what you do. But I also appeal, do not use a single publication to change what you do. We've seen the dangers of that in the past, and we need to move forward. We do need good data. We cannot any longer regard resuscitation science as something that we've always done. We need to treat it as a science and actually research it, develop it, and perfect it. Because at the end of the day, literature is just smoke and mirrors. You can be the greatest showman, and I can get statistics to show you whatever I want. With that, ladies and gentlemen, I thank you for your time.
Thank you, Dr. Dickerson, for a very thought-provoking talk. Does anybody have a burning question they'd like to ask Dr. Dickerson? Again, we may have time at the end, but thank you so much, Dr. Dickerson. Next up, we have Dr. Luis Garcia, my new friend. And Dr. Garcia is a intensivist and emergency physician and has over 27 years of experience. He's the current president of the European Society of Emergency Medicine and the past director of his hospital in Cantabria, Spain. He's always a forward thinker, and I think coming on the heels of our last talk, it's very timely that he'll be speaking about the future of resuscitation. Thanks, Dr. Garcia.
Thank you very much for your very kind presentation. After this very exciting presentation from Roger, I am a little bit ashamed, and please don't compare his abilities in the stage with me. I always have the misfortune to be the last one, and I have to speak after very good presenters. So this is a problem always for me. So my topic today is to talk a little bit about the future of resuscitation. I have selected this aspect that you see here in the slide. I am going to focus on a very debating approach to the resuscitation, and this is the cardiac arrest centers. And actually, this topic is on debate, and I would like to share with you my ideas and my information regarding this topic. Okay. To introduce my presentation, I would like to go with you through 2 or 3 slides that puts over the table the real situation of the actual problem of the cardiac arrest. Here you see the figures of cardiac arrest, people who is being treated by the emergency medical systems in Europe. Probably figures are bigger than this one, because as you all know, there is a problem of registering all this activity due to the complexity of these problems in the different settings. But the main thing that I want to stress with this slide is that although there is 250,000 of people being attended, only 10% of them they are discharged alive from the hospital. So probably we have to think how to do these things better, and this is what we have to think for the future. The other thing that I would like to go through before I go to my topic is to show you that although there are small differences in the incidence of cardiac arrest in the different continents, the figures are very close one to each other. We can say that if you have a catching area of 100,000 inhabitants, you are going to have in between 30 or 40 cases per year per this catching area. But the survival rate is low in all the countries. Australia is the one who is doing the best, but we can see that the survival rate is really low everywhere. And this is also happening during the last year. You can see in the light blue how many patients were able to return to spontaneous circulation. There has been a slight increase, but you can see that the survival rate of the hospital admission is not increasing so much, from 6.7. Yeah, thank you. From 7 years ago, 6% to the actual 8%, there's a very, very moderated increase. So there is place for improving. And this is the problem. Let us have an ideal situation in which we have to treat 100 patients. Of these 100 patients, if we provide a treatment to them in the pre-hospital setting, we are able to return to spontaneous circulation 40 of them. Of these 40 who are admitted to the hospital, only 10 of them are going to be discharged alive. So you can see that the main loss of lives is not done outside of the hospital, it is done inside of the hospital. So let us focus in that part of the activity of the resuscitation. So we are talking about the last chain of survival, and as you can see in the expanded version of the chains of survival, we are talking about how we are going to move these patients and where. What are we going to do with them on the emergency departments? What are we going to do with them on the intensive care units and on the cath labs? And this is the idea of my presentation today. Focusing on the implementation of cardiac arrest centers. And if you implement a cardiac arrest center, immediately you have to regionalize the transport of the patients. These are two things that go together. So the question is worth to implement cardiac arrest patients? Do we have enough information to answer this question? I have no conflict of interest for the rest of my presentation. So we all know that the guidelines are really helpful for us. So let us go and take a look to what the guidelines say about this. The American Heart Association guidelines, they say that to regionalize an approach to the out-of-the-hospital cardiac arrest resuscitation that includes the use of cardiac resuscitation center may be considered. This is a class 2B. That means that this is a weak recommendation with a level of evidence of CLD, only based on observational or registries and without any randomized clinical trial. So the level of evidence is also very, very low. What the ILCOR says, something similar, and regarding to cardiac arrest centers, it says that it's possible to see differences in the survival rate of different hospitals, so something should be there. And many studies have reported that an association between the survival in the hospital and the discharge is related to the transport of the patients to cardiac centers. So this is what the guidelines tell us. The first thing that I would like to discuss here is what is a cardiac arrest center. I don't know if for you it's clear, but for me it's not clear. This is the description that you can read in the guidelines. A cardiac arrest center has to have a specific intensive care unit with facilities for hypothermia treatments, for mechanical ventilation, have a specific protocol for this type of patients, needs a cath lab open 24/7, needs a radiology department open 24/7, needs to have a protocol to evaluate the neurological situation of the patient based on multimodality and a delayed procedure. And I have had from my side needs a minimum number of cases that are being attended in the center, and needs a structure that regionalize the cardiac arrest patients, recommending the transportation to specific cardiac arrest centers. So this is what the definitions of cardiac arrest are. What is the rationale for creating this center? Why the guidelines tell us that it is possible that the creation of the centers improve the survival rate of this patient? Well, the oldest publication comes from a publication 10 years ago of a huge group of patients coming from the national sample of United States hospitals. And you can see that the survival rate of large hospitals, in this case the mortality of the big hospitals, is lower and significantly lower than the mortality in the small hospitals and mainly in the rural hospitals, because all the comparisons, all the odds ratios here are comparing with local hospitals or rural hospitals. So there is something. If you have a cardiac arrest and you are treated in a large hospital, you have a better chance of survival. Going in the same direction, it's possible to demonstrate that if you go to a hospital in which there are more cases coming with the same problem, in our case the cardiac arrest problems, you are going to have a better survival. And this can be responded with a more recent publication that looks to the return to spontaneous circulated patients who arrive to 150 hospitals in North America, including Canada and the United States. And we can see that the odds of survival increases when the number of patients increases, and increases in a very small number but significant, per 5 patients more per year. So this is a way of saying if you go to a center with more cases, you are going to have better chance to survive. But it's not only the number of the cases. As you can see there are other factors. And of course, if you receive an early treatment in the cath lab, your chance is going to be higher. If they do a reperfusion you in the cath lab, your chance is even higher. And if you have been receiving treatment with hypothermia, your chance is going to be even higher. So this is what is happening in North America. But let us come back to Europe. And we have a study that helps us to see if this is a similar situation here in Europe. And this study has been done in Austria. It has involved 861 patients, including only 7 hospitals. It's not the huge amount of hospitals that we have seen in the previous one. But we see that those hospitals who are receiving more than 100 cases per year, they have an odds ratio of survival 5 times more. This is a really significant number. So it's not only one study, and this is connecting to the previous presenter. We have several studies that are focusing in the same directions. More patients, better survival. And here we can have the same information. If we look to the audit that is done annually in UK regarding the mortality of out of the hospital cardiac arrests in the intensive care units. And you can see that the patients going to the intensive care after a cardiac arrest outside of the hospital, if the number of cases that go to the cardiac arrest is under 20, that is the level of comparison. If you go up to 50, you can reduce in 0.6 odds ratio of mortality. And the same can be seen here in this scatter plot, in which you see the tendency of reducing the mortality when you increase the number. So there is something there. Centers with more cases, you have more chance to survive. But it's not only the number of cases. You have to provide adequate treatment to this type of patients. Here we see in this publication done by STOP and published 4 years ago, that they evaluate the centers depending if they have if they are applying the recommendations of the guidelines for post-cardiac arrest treatment. They include the three main elements: to have the cath lab and have the patient on the cath lab in the first 24 hours, to apply hypothermia to these patients, and to delay the evaluation, the neurological evaluation of the patient 72 hours. If all these three things are done on the hospital, they consider that is a high-performance hospital. If one of them is lack or no one of them are done, they consider that it's a low performer. And you can see the important difference in the survival. The survival in the high performance reaches 35%, while those who are not fulfilling all these elements are only reaching the half of the survival. But if you go to the neurological outcome, you can see the same difference. Those performing properly, doing the three components of the treatment, are having better neurological results. So this is important. We all know that cath lab is really necessary for those patients with ST elevation after outside of the hospital cardiac arrest. But what about those who you cannot identify an ST elevation? Well, this study also helps us in having information that we need to take decisions to send the patients to the cath lab or not. These are 269 patients. The cause of the cardiac arrest was identified as BF or BT. There were patients that returned to spontaneous circulation, and they analyzed the mortality. And they discriminate the patients into two groups: those who receive early cath evaluation and treatment, and those with no early. They do it during a period after the first 24 hours. And you can see that the mortality in those who receive the treatment later is higher. If you compare the early management in the cath lab, reduces the mortality to 34%, and if you compare to the latest cath lab utilization, that has a mortality of 51%. But also, again, looking to the cerebral performance, those who have early cath, they also have better neurological outcome. So it seems that if we do the indications of the guidelines, and if we send the patients to centers in which the amount of patients who they are receiving, so they have more experience, they have protocols more tuned, they are going to have better survival. But that means that we have to move the patients bypassing the closed hospital to the cardiac arrest centers. And we know that in the remote areas, this is going to generate a long transport time. And I have to tell you that in Europe we still live in the rural areas, 30% of the population, and I include myself. And that means that the transport time is going to be increased. Is a long transport time going to increase the mortality? We know that the chance of having another cardiac arrest during the transport is less than 20%, and also this figure is very high. Our publications put it on a figure of 5%. So it seems that there is not a high risk of having a secondary cardiac arrest during the transportation. But luckily, we have this publication from Turnik that tell us that if you take a look, or as he has done, to close to 7,500 patients that have returned to spontaneous circulation, and you see if they have been sent into distant hospitals or closer hospitals, he found, surprisingly, that those who go to distant hospitals, they have better survival. And if you take in consideration the distance, you see that the odds ratio of modifying the survival is not considered at all. It is not significant. So to move the patient longer distance is not going to affect the survival. And then we have the idea that other activities like a stroke, trauma, have received a benefit for centralizing the patients in specific centers. So, fortunately, we have other ways of evaluating our publications, and this is the meta-analysis. And these are two recent meta-analyses that have been dealing with this very crucial problem. Are we going to concentrate all the patients on cardiac arrest centers, or are we going to provide treatment in the first hospital that we can find? This is the Denise meta-analysis. It has been published one year ago, and yes, you can see it from there. In this first slide, you can see the result of the neurological outcome immediately after the discharge from the hospital and 30 days later. And you can see that it's in favor of taking the patients to cardiac arrest centers. But if you take a look to the survival, it is not so clear. It is not so clear. The cardiac arrest center is not improving the survival at 30 days. There are some problems with this meta-analysis. There is a lot of variability in the publication that have been included, but this is the information that actually we have. And the next one and the last publication that I am going to comment here is the last meta-analysis that has appeared this year in Resuscitation, is the young meta-analysis. It has less number of publications. And you can see here that the survival to hospital discharge is favorable if you go to a cardiac arrest center. But when you take a look to the survival at 30 days, you cannot see that effect. So this information put us in a situation that is very similar to what the guidelines say. It seems that it's reasonable to implement cardiac arrest centers, defining a catching area for the cardiac arrest. But we need more information, more orientated design, because actually it is not clear, or we don't have enough evidence to support this decision. To decide to create cardiac arrest centers has also other implications, not only on the EMS generating longer transport times, but also in the hospitals that are going to be deprived from this type of patients. So we need to clarify this. This is important. The other thing that we know is that the transport time is not going to affect negatively the survival rate of these patients. So I thank you for your time. We are out of time now, but I don't want to let the stage without inviting you to our Congress in Prague, and also to invite you to our Southeast European Congress that is going to take place next June, and it's also going to be organized by EPAT and EMAT, so I really encourage you to go there. Thank you very much for your attention. I am ready for your questions.
Thank you, Dr. Garcia. That was a fascinating summary of making a great argument for cardiac arrest centers. Is there any questions for Dr. Garcia? And we can open the floor for any of the past speakers. Any questions? Well, that's great. I don't want to stand between you and your lunch, so we'll sign it off there. And I wanted to thank the speakers for an excellent resuscitation track. Thank you.
Gold standard up until recently. A lot of younger EPs that are really facile with ultrasound find that looking for B lines and pleural effusions on ultrasound may be a lot quicker than waiting for a portable chest X-ray. There's various lab tests that we do, CBC, troponin, electrolytes, urea, creatinine, gases. Whether or not the natriuretic peptides, BNP or pro-BNP, are helpful is really a matter of opinion. In my shop, we don't find BNP very helpful in the acute setting. It takes a while to come back, and most people that have had heart failure, as you know, already have an elevated BNP. What we're interested in is that middle ground where we just don't find it to be helpful in the acute setting, whereas a lot of other places do. And a lot of the guidelines have natriuretic peptides in as a part of their diagnostic criteria. CT scans might be helpful in certain cases, and certainly bedside echoes are helpful. once a patient has been stabilized, to look for left ventricular filling and also valvular heart disease. I personally am not good with bedside echo, but some of my colleagues are actually trained in it, and so it can be useful in the right hands. So heart failure is defined as rapid onset or change in the signs and symptoms of heart failure requiring urgent treatment. And as I mentioned, the symptoms are primarily due to pulmonary congestion due to increased left ventricular filling pressures and low cardiac output with forward failure. And the ejection fraction, as you know, can be either preserved or reduced. So in the emergency department, there's kind of a distribution of what types of patients we see. So most patients in our setting are about 70 to 80% of them already have chronic heart failure, and they come in with an acute exacerbation for a number of different reasons. About 20% of those we see are having their first episode of acute heart failure, and an increasing number we see are palliative and they're basically in the end stage heart failure situation. And of course, this percentage is going to vary from country to country. I've got down 3% are in shock, and that could be higher, up to 8%, depending on what center you're in. But those are the real tricky ones that that are the most difficult to manage. So just to go again into the two different types of acute heart failure syndromes. So the preserved ejection fraction type has a left ventricular ejection fraction of over 50%. Typically, there's normal left ventricular volumes in these people, and it's called diastolic heart failure. Now, there is some cardiologists find that those distinctions are a little bit arbitrary because it's not always black and white, but that's generally accepted classification. So the treatment of this in terms of, not in the acute setting, but in more of the chronic setting, or the treatment of the contributing factors and comorbidities. So things like managing hypertension, lung disease, coronary artery disease, atrial fib, obesity to get the body mass index down, anemia, diabetes, kidney disease, all those things, and even sleep disorder breathing are helpful in reducing acute heart failure incidence in those with preserved ejection fraction. Then there's those with the reduced ejection fraction, and they're generally classified as an ejection fraction of less than 40%. So there is some middle ground in there that is not defined in these two types, between 40 and 50%. And we know that the measurement of ejection fraction is not 100% accurate, so there's a little bit of error between measurements. So this reduced ejection fraction type is also called systolic heart failure. And the management in that case, in terms of chronic disease, the chronic process is to treat the symptoms and essentially slow or reverse the decreased myocardial function, and thus to reduce the mortality. And clinical trials have showed that neurohormonal antagonists such as beta blockers, angiotensin-converting enzymes, ARBs, as well as cardiac resynchronization are effective in reducing the mortality from heart failure with reduced ejection fraction. Yet those same treatments don't particularly help those patients that have a preserved ejection fraction. And this is just a ultrasound showing, an echo showing the measurement of an ejection fraction, how it's calculated. And of course, we don't have the luxury, in most cases, of knowing the patient's ejection fraction when they present to the emergency department. So the other way of looking at heart failure in the emergency is whether they have adequate perfusion or inadequate perfusion, or essentially shock. Sorry. So there are a lot of different causes or precipitants of heart failure, and I like to think of the cardiovascular system in parallel with the water system. So the heart is the pump, the vasculature are the pipes, and the tank is our intravascular volume. And so anything that interferes with the pump can lead to heart failure, such as acute coronary syndromes, arrhythmias, myocardial depression for whatever reason, valvular dysfunction, so acute mitral or aortic regurgitation, any cardiomyopathies or negative inotropes. All those things can precipitate heart failure. Then over on the tank system, there are things that will increase the amount of fluid in the tank. So fluid or salt overload. If there's a problem with the fluid in the tank, such as anemia, so there's a reduced oxygen carrying capacity, that can lead to heart failure. Sepsis could probably be put in any one of these three components, but for the sake of argument, I've put it under the tank side of things with redistribution of fluid. And then there is the pipes. So hypertension can both be a cause of heart failure with increased left ventricular pressures. It can also be a compensatory mechanism to keep the cardiac output going when someone is in a heart failure situation. And then things that block flow through the vascular system, like pulmonary embolism or tension pneumothorax, can also lead to a heart failure type picture. So the management of this type of patient when they come into our department are, the first thing we need to do is to treat the symptoms and primarily restore oxygenation. And then secondarily to look at the precipitating factors to identify them and also address them. So ideally we'll go from this before picture with acute pulmonary edema, and then we end up with this nice situation on the right where the treatment has been successful. Not all patients have pulmonary edema, of course, with heart failure. Sometimes they have just elevated pulmonary wedge pressure and are dyspneic and hypoxic because of that, and you don't actually see it on the X-ray. So there's a number of major society guidelines that have been developed in recent years, and I've listed this on this really busy slide just for a point. These are all on the management of heart failure in general. So none of these apply particularly well to our situation in the emergency department where we need to deal with the acute situation. Some of the guidelines touch on it, but as I said before, there's no real good evidence-based guidelines on all the components of acute heart failure. So the first one is the UK, the NICE guidelines. They did an update on the diagnosis and management of chronic heart failure. Then there's the New Zealand, Australian one. In 2017, the Canadian Cardiovascular Society produced I think it's a 75-page document. None of it really that applies to us. American College of Cardiology, there's the European Primary Care Cardiovascular Society, European Society of Cardiology. All of these have produced detailed guidelines. What I'm going to talk today about is taking all those guidelines into consideration, but a lot of it is expert consensus, and it does vary our treatment from country to country slightly. But we all agree that the objectives of management are to restore oxygenation, resolve dyspnea, resolve pulmonary edema, restore tissue perfusion, and then identify those precipitating factors. So regardless of the ejection fraction, whether it's reduced or preserved, regardless of whether there is shock or not, the first step in treatment is to restore oxygenation to an oxygen saturation of over 90%. Generally, the guidelines are all in agreement that there's no point in giving oxygen if the O2 sat is over 90% because it can cause vasoconstriction and actually have a paradoxically negative effect. So we just want to get it over 90. So stepwise, first with oxygen nasal cannulas, and if that doesn't work, next by face mask. And if the patient is still hypoxic in that situation, then by non-invasive ventilation, so BiPAP. And that is a lifesaver in my experience for treating patients with congestive heart failure. I noticed a couple of the guidelines are not recommending non-invasive ventilation. And of course, as a last-ditch effort, if non-invasive ventilation fails or if it's contraindicated, then endotracheal intubation would be the next step. The person remains hypoxic, or if they have a decreased level of consciousness and cannot tolerate a BiPAP mask, then we would have to go to intubation. But that doesn't happen very often. So in those with heart failure that have adequate perfusion, so a pretty robust blood pressure, first step would be to sit the patient upright. And then if the patient is hypertensive, which happens in most cases that we see, then vasodilators are a very great next step. And nitroglycerin is the best option here unless it's contraindicated. And while the patient comes in and is getting an IV line and everything is getting set up, they can just have sublingual nitroglycerin or a transdermal patch, and to be quite generous with it, followed by a quickly escalating intravenous infusion of nitroglycerin. So 5 to 10 mics per minute to start, but that would rapidly be increased to lower the blood pressure and lower the left ventricular filling pressures, the preload and the afterload. I just put in here two things that are not recommended because they are mentioned in some of the guidelines. So both opiates and nicerotide are not recommended in the guidelines at this point in time. So of course, loop diuretics are our next go-to, and particularly in those patients that are fluid overloaded. For a while, diuretics fell out of favor a bit because they're not as good a venodilator as nitroglycerin. But recently, Matsui et al. Did a study showing that the mortality in patients was reduced substantially from 2.3% from 6% to 2.3% in patients that received diuretics within 6 hours. Now that seems like a long time, but the quicker that they get their loop diuretics in, the better the outcome is for them. So the initial dose would be furosemide, 40 milligrams IV, which would be repeated, and then torsemide or bumetanide are two other options. Of course, this dose would be increased if the patients were already on a loop diuretic or if they have renal failure. So the use of inotropes or vasopressors is reserved only for those patients in that category with hypoperfusion, so those patients with shock. And so firstly, the type with a reduced ejection fraction, an inotrope would be the go-to with dobutamine, the beta agonist, as the inotrope of choice at 0.5 to 1 micrograms per kilogram per minute. Milrinone is mentioned as another one. There's a typo in there. And then these are used as a temporizing measure until mechanical support is made available or some other alternative. So it's not supposed to be long-term therapy. So if the patient is known to have a preserved ejection fraction, you might want to even consider small crystalloid boluses if there is no evidence of fluid overload to try and increase, sort of prime the pump to increase the stroke volume. And then IV vasopressors, particularly norepinephrine, 8 to 12 mics per minute, or phenylephrine would be indicated. And again, temporizing measure followed quickly by an echocardiogram to assess in more detail what's going on with the heart. So in most cases, we don't know what the ejection fraction is, and so in those cases, an inotrope plus or minus a vasodilator, depending on the clinical situation, would be indicated. And at the same time, assessing the need for mechanical support and obtain immediate echo. Those with hypoperfusion, also you would want to be considering whether the renal failure may be the cause, and sometimes we get renal failure patients that come in with heart failure, so dialysis is the go-to, of course, for those patients. Blood transfusion may be necessary if anemia is a significant factor. Rate and rhythm control is important in some cases, unless it's, of course, a compensatory tachycardia that's trying to normalize the patient's physiology. So the pros and cons of rate control have to be carefully considered. And, of course, coronary revascularization if it's a ST elevation MI. So for those unfortunate few who have refractory acute decompensated heart failure, the real big guns would be last in consideration. So for failure of oxygenation, we would think about ECMO. And for persistent shock, we would consider interaortic balloon counterpulsation. And there's a couple of nice studies that describe their use in the situation of shock, which I have referenced here. And again, as I mentioned, all of the precipitating factors need to be considered and treated. A lot of them, hypertension, sepsis, renal failure, drugs, things like acute aortic or mitral insufficiency could be seen on an echo and hopefully on clinical exam if you're good at your murmurs, and aortic dissection in the right clinical situation. Of course, those things would need urgent cardiac surgery consultation. So then our next, once we've got this patient treated, then our next, or last thing that the emergency physician needs to consider is what to do with the patient. So are they safe to be discharged, or do they need to be hospitalized? And of course, that's not going to be evident an hour or two after they present. Generally, they need a period of time in our observation unit, if we're lucky enough to have one, and determine after 12 to 24 hours if they're able to go home or not. And also to identify this group of higher-risk patients who may benefit from CCU admission. So Lai and al. Did a study in 2016 which showed a group of patients in Canada versus the United States. The Canadian were in Ottawa, and the US center was in the Mayo Clinic in Rochester. And the admission rate in the Mayo Clinic was 95%, in Canada was 50%, yet the outcomes were similar. So outcomes were, like the adverse outcomes were relapse to the emergency department, myocardial infarctions, and death within 30 days. So these findings really question the need for admission of patients with heart failure. So just recently, 2016, the European Society of Cardiology did a paper on safe discharge of acute heart failure patients from the emergency department. And this group referenced a couple of Canadian studies, really the only evidence-based information that's out there. So the first is the heart failure risk score that was developed by my colleague, Dr. Ian Steele in Ottawa. And so this group wanted to identify a risk scoring system to identify which patients were at high risk for serious adverse events. And they came up with a number of items with a score of 0 to 15 that could predict which patients would be at higher risk if they were discharged. So they found out that if they had 0 of these factors,
factors, with 95% sensitivity, they would not end up with an adverse event. So these people, they felt were safe to go home. If they had a score of 2, there was 81% likely that they wouldn't have an adverse event, or if they had 2, it was 65%. So then a decision would have to be made on the level of risk that would be acceptable to tolerate for discharge. And the reason why discharge is so important is because of the cost of hospital admission and the burden on the entire healthcare system. So then another group, Doug Lee and all, did another study to try and predict the mortality of heart failure in emergent care. Whoops, sorry. And they looked at absolute 7-day mortality rates and with 95% confidence intervals by something called the EMERGE score, so EHMRG. And there's a couple of graphs. So this is basically the factors for the EMERGE score, Emergency Heart Failure Mortality Risk Guide. And there's a really nice calculator online that you can use, and the link to it is here, where you can input all of these factors about your patient and get the risk of mortality online. And I mean, it's not perfect. It's something to use in conjunction with clinical judgment, but it's something that is ongoing work on this. So basically, if there was 1 to 3 of these factors, the mortality was 0.3%. If there was 4 to 7, it was 3.5, and 8 to 10 is 8.2. So then Raslin, Brown, and all did a study on hemodynamically stable acute heart failure patients requiring a critical care unit admission. So basically, they wondered which patients needed to go to an ICU or a CCU. So these are some of the factors that they found, and I'm not going to go through it in detail. I think all of these presentations are going to be posted if you would like to look it up. But essentially, this is the receiver operating curve for their tool for the baseline and their refined clinical prediction models for their data. And so the refined one used BMP as another factor in determining which patients needed ICU admission. And they found that a very small number of patients actually needed to be admitted to a critical care unit. So in conclusion, acute heart failure syndromes are common, and emergency physicians are key to reducing morbidity and mortality. Early diagnosis and rapid management are key. Oxygenation by escalating measures are loop diuretics for volume overload patients and vasodilators for hypertensive patients, and correcting of precipitating factors are the mainstay of our treatment in the emergency department. And evidence for risk stratification is ongoing toward the development of decision tools to determine patient disposition. So thanks very much for your attention, and I'm happy to answer any questions.
Does anybody have any questions for Dr. McEwen? Sorry. Thank you very much for that wonderful presentation.
So now it's my pleasure and honor to invite Mustafa Sabak to the stage. He will give us a talk about what's new in the COPD guidelines. And I worked really hard to find something in the internet about him, and I found some very interesting thing. On his Twitter account, he presents himself as emergency physician, brain drain, and forever student. So welcome on the stage, Mustafa Sabak.
Thank you so much. Hi everyone, I'm honored to be here and to be joining this distinguished group of participants and speakers. My name is Mustafa Sabak, and I'm an emergency physician in Nizip at Nizip State Hospital, close to the Syrian border, east of Turkey. And I'm very happy to be here today to talk about recent updates in COPD. I have no financial disclosure to report it. The objective is to discuss the new recommendations of the GOLD 2019 GOLD report. This is the shortly called Global Initiative for Chronic Obstructive Lung Disease. This report therapeutic strategy and particularly its impact on diagnosis, management, and assessment of COPD. And this is the current guideline about COPD, which is published in this year, and revision of the GOLD 2017, and has been reported literature in COPD research and case that was published from 2017 and 2018. As you know, it is common and represents an important public health challenge, and that is both preventable and treatable disease, and characterized by persistent respiratory symptoms and airflow limitation that is due to airway and alveolar abnormalities usually caused by significant exposure to noxious gas and particles. And the most common symptoms, dyspnea, cough, and sputum production. COPD may be punctuated by periods of acute worsening of respiratory symptoms, which is called exacerbations. In most patients, COPD is associated with significant concomitant chronic diseases, which increases its morbidity and mortality. As you know, the chronic airflow limitation is caused by a mixture of small airway diseases and parenchymal destruction. The relative contribution of which vary from person to person. These changes do not always occur together, but evolve at different rates over time. And global prevalence roughly 12%, and it's appreciably higher in smokers and ex-smokers compared to non-smokers, and higher in those more than 40 years of age, and higher in men and compared to women. But more recent data from developed countries has reported that the prevalence of COPD is now almost equal in men and women. This is a burden problem because major cause of chronic morbidity and mortality throughout the world, and that induce an economic and social burden. Currently, fourth leading cause of death in the world, and more than 3 million people died of COPD in 2012, accounting for 6% of all deaths globally. And the other important thing is disability adjusted life of year, which is called DALY, for a specific condition are the sum of year lost because of premature mortality and years of life lived with disability. And the other problem is COPD may force at least two individuals to leave workplace, the affected individual and the family member who must stay at home to care their stable relative. Most national data shows that less than 6% of the adult population have been told that they have COPD. Roughly 15 million Americans are underdiagnosed. So there has to be a national action plan to create awareness. I don't know how many Turkish people are underdiagnosed, but unfortunately there is a cigarette culture in here. And if you are in depressed, someone can offer to light up a cigarette. The main risk factor, tobacco smoking, environmental exposure such as BMS, indoor or outdoor pollution, and besides exposures, host factors predispose individuals to develop COPD. For heavy smokers, fewer than 50% develop COPD during lifetime. So lots of different factors such as genetic, age, gender, and that there is a growing evidence that indoor biomass exposure, specifically for the women, that may predispose women to develop COPD in many developing countries. Poverty and low socioeconomic status are associated with an increased risk of development COPD. And the other thing, for the infection, HIV patients are at risk of COPD. And it should be considered in many patients who has dyspnea, chronic cough, and sputum production. If there is a history of exposure to risk factors such as smoking, pollution, as I mentioned about early, host factors, family history, because multiple K indicators increases the probability of diagnosis of COPD, and spirometry is required to make the diagnosis. How it works, the presence of post-bronchodilator FEV1, FVC ratio less than 0 point confirms the presence of persistent airflow limitation. And after diagnosis, why do we need to assess COPD? That's because to determine the level of airflow limitation, the impact of disease on the patient's health status, the risk of future events, and in order to guide the therapy. In the presence of the low FEV1, FVC, the percent of predicted FEV1 is used to determine the severity of airflow limitation, but there is only a weak correlation between FEV1 symptoms and impairment of patient's health status. For this reason, formal symptomatic assessment is required, and there are different types of assessment tools, but CAT and MMRC are most widely used among these. The CAT is short, brief, simple questionnaire for assessing and monitoring COPD. It is an 8-item unidimensional measure of patient's health status impairment in COPD. And MMRC is a simple measurement of breathlessness and relates well to other measures of health status and predicts future mortality risk. However, it is now recognized that COPD impacts beyond just dyspnea. For this reason, a comprehensive assessment of symptoms is recommended rather than just a measure of breathlessness. Exacerbation are defined as acute worsening of respiratory symptoms that results in additional therapy. These events are classified in three groups: mild, moderate, and severe. But the different things, blood eosinophil count may also predict exacerbation rates for the future. But the best predictor of having frequent exacerbation is a history of earlier treated events. FEV1 by itself lack of sufficient precision. We all know the COPD is systemic disorder. Patients with COPD often have important concomitant chronic illnesses at the time of diagnosis. But the presence of comorbidities should not alter COPD treatment and management. Comorbidities should be treated by usual standard regardless of the presence of COPD. And lung cancer is frequently seen, and a main cause of that. Cardiovascular diseases are common and important. There are lots of different kinds of diseases, but osteoporosis, anxiety, and depression we can see. Therefore, comorbidities should be looked for routinely and treated appropriately in any patient with COPD. In the revised assessment scheme, patients should undergo spirometry to determine the severity of airflow limitation, and then they should also undergo assessment of either dyspnea using MMRC or CAT. Finally, their history of moderate severe exacerbation should be recorded. If we give an example, consider two patients, both patients with FEV1 less than 30%, which is group GOLD 4, both with CAT score of 18, but one with 0 exacerbation in the past year, the other one 3 exacerbation in the past year. The subject with 3 exacerbation in the past year would be grade 4. The other patient would be classified as group B. This is important. Furthermore, in some circumstances, such as urgent presentation to emergency department, the ability to assess patients based on symptoms and exacerbation history independent of spirometry value, because Lots of emergency departments don't have spirometry. This is important for us. Allows clinicians to initiate a treatment plan based on revised ABCD scheme alone. If we look at the clinical course, during exacerbation, the peripheral airway limitation progressively traps gas during expiration, resulting in hyperinflation and leads to increased dyspnea and limitation of exercise capacity and disconditioning. As a result, the patient's quality of life is affected because of these reasons. I would like to talk about the treatment models that is suggested by the guideline. Smoking cessation is a key. The effectiveness and safety of e-cigarettes is very common, but it's not uncertain at present. Inhaler technique needs to be assessed regularly. Vaccination is really important, especially influenza and pneumococcal vaccination decreases lower respiratory tract infections. Pulmonary rehabilitation, we don't know enough information about that, but improves symptoms and quality of life. Usually pulmonologists care about that. In patients with severe resting chronic hypoxemia, long-term oxygen therapy improves the life, survive. And patients with severe chronic hypercapnia and history of hospitalization for acute respiratory failure, long-term non-invasive ventilation may decrease mortality. And in selected patients with advanced emphysema refractory to the optimized therapy, surgical interventions can be considered. Palliative approach is effective for the symptoms. If we look at the pharmacology therapy, we aim to reduce symptoms and frequency severity of exacerbations, but at the same time improve health status and exercise tolerance. But each treatment regime needs to be individualized as the relation between severity of symptoms and airflow limitation. The choice within each class depends on availability and cost of medication and favorable clinical response balanced against side effects. This shows you the current therapy that we have pharmacologically. Beta-2 agonists and anticholinergic, which are bronchodilators, short-acting and long-acting, methylxanthines, double combination and triple combination, and the phosphodiesterase 4 inhibitors, which is anti-inflammatory drug, mucolytic agents. Bronchodilators, especially they recommended long-acting beta agonist and long-acting anti-muscarinic agents are preferred over short-acting agents, except for patients with only occasional dyspnea. Inhaled bronchodilators are recommended over oral bronchodilators because some of the physicians usually use oral bronchodilators. Specifically in our department, some of the pediatrics use it for the kids. Theophylline is not recommended because of the side effects. Long-term monotherapy with inhaled corticosteroids not recommended, but if a patient with long-acting beta-2 agonist for patients with a history of exacerbations, you can use it inhaled corticosteroids. Long-term therapy with oral corticosteroid is not recommended. In former smokers with exacerbation, despite appropriate therapy, macrolides, specifically azithromycin, can be considered. Statin therapy is not recommended. Antioxidant mucolyt are recommended only in selected patients. Antitussive cannot be recommended, and low-dose, long-acting oral or parenteral opioids we can't prescribe in the emergency room. So maybe consider it for the improve the patient's breathlessness. This chart is very important because we can decide initial therapy for this ABCD assessment tool. If the patient in group A should be offered bronchodilator treatments based on its effect on breathlessness. For B group, initial therapy should consist of long-term acting bronchodilators. In group C, long-acting anti-muscarinic agent was superior to long-acting beta-2 agonist regarding exacerbation prevention. In group D, long-acting agents as initial treatment should be guided by level of symptoms. You know, some of COPD patients are particularly susceptible of frequent exacerbations, and these patients have been shown to have worse health status and morbidity. The exact reason for an individual's increased susceptibility to exacerbations symptoms remains largely unknown, but the strongest predictor is the number of exacerbations they have had in prior years. Most common reason triggered by respiratory viral infection, which is rhinovirus, although bacterial infection and environmental factors such as pollution can affect patients. The goal to minimize the negative impact of the current exacerbation and to prevent subsequent events. When the patient with exacerbation comes to ER, they should be provided by supplementing oxygen, and we can decide this is life-threatening condition or not. Do patients need invasive ventilation or not? So if so, healthcare providers should consider admission to the respiratory or intensive care units of the hospital. First of all, we have to support respiratory. First of all, oxygen therapy is a key component of hospital treatment of an exacerbation. We can use oxygen by ventral mask or high flow oxygen therapy by nasal cannula, but high flow oxygen cannula reduce the need of intubation and mortality, hypercapnia, but still there is a need for well-designed randomized multi-center trial to study for its effect. If the patient has a persistent respiratory alstosis and hypoxemia and severe dyspnea with clinical signs suggestive of respiratory muscle fatigue, increased work of breath, we should consider non-invasive mechanical ventilation. When do we need to weaning from non-invasive ventilation? If the patient's clinical status improve and tolerate at least 4 hours of unassisted breathing, then can be directly discontinued without any need for weaning period. This is the for need to intubation, invasive mechanical ventilation. If the patient unable to tolerate non-invasive ventilation or non-invasive ventilation failure, and the patient in status post cardiac arrest, diminished consciousness, and there is a risk factor of massive aspiration, and there's a severe life-threatening arrhythmias and life-threatening hypoxemia in patients unable to tolerate non-invasive ventilation, then you can concern about the invasive mechanical ventilation. How to manage of exacerbation with pharmacotherapy? As you know, bronchodilators, corticosteroid, and antibiotics are most commonly used for exacerbation. Short-acting inhaled beta-2 agonists with short-acting anticholinergic or not are recommended as initial bronchodilators to treat the exacerbation. Maintenance therapy with LABA is important. Specifically, should be initiated as soon as possible before hospital discharge. Systemic corticosteroids can improve lung function, oxygenation, and shorten recovery time and hospitalization duration, but should be 40 milligrams per day and during 5 days. The use of antibiotic exacerbation remains controversial, but if the patient's symptoms increase in dyspnea, sputum volume, and sputum purulence, then you're concerned about antibiotics. There is no clear evidence to guide CRP and procalcitonin for the ER, so we can decide for the patient's clinical status. Methylzanides are not recommended due to increased side effects. Non-invasive mechanical ventilation is very important because it improves gas exchange, reduce work of breathing, and the need for intubation, decrease hospitalization during, and improve survival. some of the factors that impact the patient's outcome, if the patient's older age and lower body mass index, previous hospitalization for exacerbation, and after discharge need for long-term oxygen therapy, that means patient's mortality is high. The problem is not only exacerbation. Frequent exacerbation is very important than the only one exacerbation because it's effective the disease progression. The patients decrease quality of life and increase inflammation, faster disease progression, increase hospitalization, and the risk of recurrent exacerbation and increased mortality rate. So we need to decrease frequent exacerbation, that's why. The intervention is important to reduce the frequency of it. Those are bronchodilators, corticosteroid-containing regimes, double and triple regimes, anti-inflammatory drugs, anti-infectives such as vaccinations and long-term macrolides for the smokers, regulators, and smoking cessation program, rehabilitation, and some surgical procedures. Depending on severity on exacerbation and the severity of underlying disease, an exacerbation can be managed either the outpatient or inpatient setting. More than 80% of exacerbation are managed on outpatient basis with pharmacological therapies, including bronchodilators, corticosteroid, and antibiotics, but local resources need to be considered for that. This is the indications for the ICU admission. If the patient has severe dyspnea that responds inadequately to initial emergency therapy, patients change in mental status such as confusion and coma, persistence of worsening hypoxemia, respiratory acidosis, and despite the supplemental oxygen and non-invasive mechanical ventilation, hemodynamic instability and the patient need for vasopressor and fluids, patient need to immediate admission to the intensive care unit. And at the same time, local resources need to be considered for that. The cause, severity, impact, treatment, and time of course of exacerbations varies from patient to patient, and facilities in the community and the healthcare system differ from country. Accordingly, there are no standards that can be applied to timing and nature of the discharge. These measures all seem sensible. There is insufficient data that they influence either readmission rates or short-term or mortality, and there is little evidence of cost-effectiveness. But early follow-up following discharge should be undertaken when possible and has been related to less exacerbation-related readmissions. Thank you so much.
Thank you very much indeed, Mr. Dr. Sabak, for your impressive presentation. So I think we all have a good overview now. And are there any questions in the auditorium? Yes, please. Bejek.
Thank you very much, Dr. Mustafa, for your talk. I'm sorry, while you were preparing for your presentation, did you read anything in paper about the dilatation of the tracheal tract or using of stent for the patient who have really tracheal constriction?
Tracheal construction?
Tracheal, stent, using stent to tracheal tract.
Oh, I didn't read anything about that on the guideline. I'm sorry about that.
Thank you.
Yeah.
Yes, there's another question here over there.
Mr. Sabak, thank you for your presentation. I want to ask you, do you know anything or do you talk about any scoring system that can standardize the determination of the outcome of the patients who presented to ED with COPD exacerbation, like PCI and pneumonia?
For pneumonia?
No. For COPD exacerbation, a scoring system that, according to that, we can determine the outcome,
there is no
admittance or discharge of the patient.
I didn't read anything about scoring system, but the important thing to deciding the antibiotics for the pneumonia, for the exacerbation, we should decide for the clinical status, such as increased dyspnea and coughing and sputum production. It doesn't work any CRP or procalcitonin, just only need to determine the patient's status.
Okay, thank you.
There's no any scoring system.
Thanks a lot.
I didn't read it, I'm sorry about that. Yeah. That's it.
I have one more question for you.
Please.
In the United States, this is one of the top 5 causes of hospital readmission within 30 days. Do you track hospital readmissions for people discharged with COPD in Turkey?
Yeah, we can discharge because the local resources is not enough. And most of the time we decided by laboratory results and the patient status, some of them are not good enough for the discharge, but try to keep them care. I'm really sorry, but we don't have enough opportunity to admit hospital or ICU. Yeah, unfortunately.
So thank you very much, Dr. Sabak, and we would give you a big applause again.
Thank you. Thanks so much.
Now we are looking forward to the presentation about traditional Chinese medicine from Professor Wang Zhong. He will be kindly replaced by Professor Mai Ji, Vice President of the Chinese International Exchange and Promotion Association for Medical and Healthcare of Emergency Medicine. So welcome, Professor Mai Ji.
So, dear Chairman, ladies and gentlemen, I'm Dr. Wei Jie from China. I'm also an emergency physician. On the behalf of my President, Dr. Wang Zhong, now he's sitting downstairs, so later maybe you can ask a question for him. And I'm going to speak up of something about Chinese traditional medicine, which we call TCM. And first of all, I would like to say thanks for President Basa Kandar's invitation. We come here, and also I would like to say sorry for last year situation. According to some reason, we failed to come. Anyway, this time we are here in this room together with all of you. And my topic is about traditional Chinese medicine. But speaking about traditional Chinese medicine is really a huge project. For me, I don't have enough time to explain everything in details. So I will try my best to give all of you a very brief introduction about TCM. Okay, here you can see this is the map of China, and this star is Beijing, and Beijing is the heart of China, is the capital, and another star is my city. My city is just in the middle of China. It called Wuhan. Okay, this picture is showed Wuhan, the view. You can see the river go across the city. The river is the Yangtze River. It's the longest one in China and one of the longest all over the world. And the bridge go across the river. The bridge we have in the city, we have over 10 bridges go across the river. So the river called the bridge river, or the river city. And the building is yellow-green tower. That's the symbol of the city. If you see the 3 parts together, the river, bridge, and the building, the tower, you will be in Wuhan. So welcome in Wuhan. This is my university, Wuhan University. People say the campus of the university is the most beautiful China. I really appreciated of this. Here you can see this is my hospital. My hospital has 2 branches together, and this one is the largest one. I work over here. My ER is just in the first building, and I do have a general ICU in another building. I'm in charge of ER and also general ICU in my department, in my hospital. Okay, what's traditional traditional Chinese medicine. Here we have a sentence. The sentence from a traditional Chinese medicine textbook in China. It says, the system, TCM system, based on Chinese medicine theory and clinical practice experience. The system study human health and life activities and the disease transformation. Then to do prevention and to do diagnosis, to practice treatment, even rehabilitated and multi-health care. Okay, this is the concept. The concept is a little more abstract even for me, so we need something more in details. Yes, TCM has long time history. More than 2,000 years ago came out Huangdi, classic medicine. Huangdi is a name of ancient traditional Chinese physician. He did his practice and also wrote some medical books. It gives complete and systemic exposition to the subject not following. The relationship between human and natural, that's important. Human physiology and pathology, the diagnosis, treatment, and prevention of the disease. It also uses its own theories that very important for the system of yin and yang. You all know yin and yang, I know. And 5 elements system to deal with the principle of treatment, which we call the TDS, and according to the climate and seasonal conditions, even geographic location and individual constitution. Taking the human body as an organ whole and taking the human body with the surroundings and the environment as well. Okay, TCM has its own theories. We can see some. The red parts of the theory is we often use even now in China. So I just try my best to explain, even this is not so easy for me because I'm not a TCM physician. So first of all, yin and yang. So yin and yang theory permeates all aspects of the theoretical system of TCM. The theory is used to explain the organ structure, physiological function, and pathological changes of the human body. It also serves as a principle of a guide clinic diagnosis. For example, every organ, the whole body and every organ has 2 parts, yin and yang, to balance. When yin and yang get balanced together, everything, the function of the body could be normal and stable. For example, according to the system of cardiovascular system, and if yin is less, yang is too much. So hypertension comes from. On the other hand, in some situation, for example, infection or sepsis, the yin is very, very strong. That means the blood pressure could be very low, maybe shock comes out. So we need to give some medicines or some other methods to treat patients to get the 2 parts to be balanced together and to make the function to be normal. So this is the yin and yang. Also the 5 elements theory. This is a little more difficult for me to explain in English language. According to the theory, the traditional theory, they have elements referred to wood, fire, earth, mental, water, and their motions together. So the theory results from ancient Chinese observation and study during their lives and working together, since the 5 elements are basic substance to constitute the universe. So they are also indispensable for life as well. Why not? So the third theory is about acupuncture. You know now acupuncture, this is the therapy for TCM, but the therapy has the basic idea that is meritings. When we're doing acupuncture, we need to find the point. We cute acupoint. We put the acupoint to get some result by using this method. When we linked every point together, that is meritings. So this is a meriting map. In China, if you go to office of TCM physician, you can see everywhere this map. The TCM, in the past, the physician wrote some books and to explain something, even some basic idea. For example, 黄帝内经, this one is the oldest one. So refer these old books to the modern theory. They could be this. Autonomy and this, even difficulty cases sharing. So we can contact everything happened in the past and with the modern society system right here. And also, this is a philosophy of traditional Chinese medicine. There are 3 sentences now is common used even outside of China. It says, 上医医未病治病. That means if you are the doctor, but in the top level, you can treat a patient who is not really sick. So that means you can hold back the sick happen. So you are very clever. That means you need a smart mind, you need a sharp vision, you need very good experience in the past. So that's the top level doctors. But if you are a doctor, but in the middle level, you treat the patient who's going to sick. You cannot hold the program back, but you can get ready, waiting for the program. The last one, the third level of doctor only treat patient who has already get sick. So this is our philosophy. I do think this is very useful for the modern system, for the young doctors to do something. Okay, we have the theory, and then how do we do? Just follow the theory. How do you do? When you're doing medical practice, diagnosis first. Yes, TCM, we also need to make the diagnosis first. How do we do? We just follow the four steps sequence to do diagnosis. First is one. One means to look. To do, not just look, to realize something by looking. So that's observation. The second is wen. Wen means to listen, to listen and to smell. And by listening and smell, you will realize something. And the third one is a question to make the history of the program and to know the cause and the reason. And finally, that's very important, very useful, very unique in the TCM, just by touch the puzzle to realize something, and finally make the diagnosis. This is the need very serious training. Even I couldn't do this. And after the diagnosis, we have to do the treatment, of course. We have 3 parts to do traditional Chinese medicine treatment. First of all is physical therapy. The second, by using some medicine. And third one is traditional Chinese medicine, surgical. And I just want to explain the 2 parts of this, because I really don't know the theory and practice of surgical part of this system. So the therapy, the physical therapy, we have a lot of ways: acupuncture and moxibustion. and this is the whole one, and file copying, message, and scrapping. The last one now is very, we use very little time just in the countryside or home care. So here we can have a picture of acupuncture. So acupuncture just put the needle in the acupoint and remain for some time. Sometimes we twist the end of the needle. If we use the, we smell the end of the needle with the herbal stick. That is moist position, and this. File capping, some countryside clinical house, they use this, and this massage, massage right here, they can relieve some pain, acute pain, get the muscle to be relaxed, something like this. Also, here, another way to do treatment is by using Chinese traditional medicine. Here you can see that the top one, the picture is a traditional pharmacy. So we keep every medicine, every Chinese traditional medicine in the single boxes. And this one is a typical Chinese prescription by physician writing. So the patient hold this prescription to the pharmacy, and the staff will, according to this prescription, to choose the medicine and to weight how much and make them together to be mixed one. So here you can see this is the medicine. This is how much. This is the medicine, how much, medicine, how much. So they choose everyone together to make a mixed one to put this medicine into, sorry. Sorry, is anyone can help me to move the slides? Some problem. Put the medicine into a container, add some water to boil it for hours, and then the medical soap we called decoction comes out. And take certain dose of the soap, 1 or 2 times a day. That's normal treat. That's normal treat. Okay. Okay, I can now move it, please. Okay, this is a decoction. Take it 1 or 2 times a day. So now in the past, we do use this kind of ways to deal with this type of problem. For example, emergency pain, conversion, even fever. The paper is published in a Chinese traditional magazine, traditional medicine magazine. It says to stop asthma by using acupuncture around the ear. So that's very, very useful. But now we are doing modern medicine. So what we are doing now, this is the idea of our mind. TCM is a part of Chinese culture. General medicine education also involves in TCM. For example, when I was a medical student in the college, I took about 60 in China, 60 hours to study traditional Chinese medicine, even to play Tai Chi, because they do believe that Tai Chi could make persons to be inner pins together. Many people trust only TCM in the country, for example, especially in the countryside. And almost every city has a TCM hospital. My city has 2, and almost every general hospital has a TCM department. My hospital has 1. In China, we have 16 Chinese medicine university. So in Beijing, Chengdu, the city, the last one is my region. In my region, we have what this picture shows the greeting from Beijing Chinese Medicine University. So this is a principle. When we use the Chinese medicine, this is a principle. Just combine Chinese and the Western medicine together, first of all, and deal with the emergency syndrome first, and then with the basic course later. This is the philosophy for us as me as well. Get instant result and step by step. And 立竿见影, 立竿见影, it's a Chinese idiom. It goes when you put a bamboo stick under the sun, under the sunshine, you will get the shadow immediately. So that means if the situation of the patient is more serious, so you need to make the situation to be stable immediately. So you need to use maybe Western medicine, not just the Chinese one. Okay, these are some mental prescription. Even now we are using in ER or ED. The red one is we are often used. So especially the sinful injection, yes, in China we have some manufacturers, some pharmacy manufacturers, they do make the medicine to be an injection, This one is a famous one and common use in emergency department. Of course, TCM physicians, they do some research. There are fundamental researches published outside of China. The last one is a clinical research. So, and sinful 注射液 also, the sinful injection also has this multi-center clinical study. They just want to treat heart failure using when doing CPR, also using in the shock patient ACS, even in MI. So they are doing and we are waiting for. Of course, the system has some questions as well, just like modern medicine. Yeah, we also have some questions, some programs as well. The security, effective, even quality control. They are very normal. And this one, this is the conclusion of my speech. TCM is a great treasure. Of course, it's a treasure of China. The biggest characteristic of TCM is regarding the human body itself as an organ whole. It was developing and organizing for us, not just now, but future. There still leave over some questions that cannot be fully explained among the field. Even the system is really effective when using. What we need to do in the future is finding the material basic of TCM in different ways and different aspects. Due to some historical reason, TCM really has its own limitation. We should prove the good, the safe, and effective aspect of TCM with the aid of modern research platform and remove its risks, taking its essence. Take the advantage of it. And combine, this is what I wrote, combine Chinese traditional medicine and Western medicine together may be the best way to make TCM to be moderation. Okay, that's my speech. Thanks for.
Do we have any questions for Dr. Wenxi? Quite a few questions.
Really, thank you very much for your interesting talk, Dr. Wei. I have a few questions, possible? Not just one, okay? First, your university is already an historical, it is a world historical university. I am wondering if, are you doing this training as professional? I mean, is it possible to getting this job by PhD program, by doctorate program in China? And does your community obey this traditional treatment? And is it possible? Are you giving this traditional therapy to your medical faculty as lectures? Do we do it? And does China accept patient from outside the China for this treatment? And is it paid by the government, by the health system, while we are writing on prescription? Thank you very much.
Oh, okay. I catch your meaning. So you ask if the student go to the traditional Chinese university, they will pay or the government pay for them. Yeah, they pay by themselves. Of course, this is common use. It's a common the education system. It's not a special one. And also in the college, they have degree courses. Even in some, not all, in some, they have PhD. We have a lot of students go over outside of China. For example, Germany, something like this.
Another question over there, please. This gentleman.
Hi there. My name is Dr. Alwi. I'm from Malaysia. My question is, in Malaysia we have a lot of traditional Chinese medicine and it's a lot of followers. I just like to ask this question. In China, when you do kidney transplant, is there a role of Chinese medicine management as part of recovery process? Thank you.
Sorry, your question is to be a TCM physician, you need to get a license, right?
My question is there a role in a recovery process after a kidney transplant and the role of Chinese medicine application?
Yeah, not just one case. For me, I cannot write this prescription. Only TCM physician, they can write, they can make it. Only them. Yes, it's a not rule but principle.
Is there another question here in the front?
I am an acupuncture practitioner here in Turkey, and also I am an emergency physician, and I do in my practice in emergency acupuncture therapies too. But
really?
I want to ask you, how do your practice in a real emergency case? Also, when a case needs an operation, do you give them an emergency traditional medicine or the acupuncture too behind the other process, or give you this patient only to the surgeons?
Go back 20 years ago, we did in this way. At that time, I'm very young, but now we never. In the past, we had, actually, but now we don't have, because the modern medicine is very effective, more quickly. Thanks for the question.
I think we'll move the questions to the end. I know, Dr. Kandar, did you want to say something? Okay, thank you very much. And I thought we'd have a presentation here. Please.
Okay.
Sorry, we try for this time 2 years. We waiting for you 2 years. I want to give something from Turkey because you couldn't come last night. And
So sorry.
President Wang Zong, please. Wang Zong? Okay, thank you.
Thank you, everybody. I know there's going to be a short break here, and they'll come back in about 10 minutes for another set of presentations. Thank you again, everyone. You've been a great audience, and thank you again for our wonderful speakers.
The environment, and even in case of terrorist attack. You have to be aware that air pollution is unfortunately a serious worldwide issue resulting in inhalation intoxications, and the 5 major pollutants are carbon monoxide, sulfur dioxide, nitrogen dioxide, particulate matters, and ozone. The air we breathe always contains different particles, droplets, and gases, sometimes from natural sources and sometimes from man-made sources. One important concern is that toxicity will be related for particles with their size. And you see here clearly on this slide that the largest particles will mainly result in toxicity in the upper airways, while the smallest particles in toxicity in the alveoli. And of course, with gases, it will be possible to reach the alveoli and to result in local but also systemic toxicity. Daily, at the workplace, there are several industrial toxicants that may produce respiratory disease, either acute but also chronic. One important issue is to prevent and control these possible toxicities, wearing appropriate personal protective equipments, ensuring adequate ventilation, suitable environment for dispersing, and of course allowing gas detection using adapted monitors. Ensuring emergency procedures is also important in the workplace to allow reduce the risk. Now let's consider the mechanisms by which inhalation toxicant may produce their toxicity. We can classify agents in 3 categories. The irritant agents, they will be responsible for local toxicity, and their effects will mainly depend on their aqueous solubility. High soluble gases may affect the eyes and the upper airway, like chlorine, while low soluble gases will affect mostly deep pulmonary structures, since they may diffuse till alveoli, and this is the case of phosgene, for instance. Some of the cases, and we'll discuss it, hydrogen sulfide may have local and general toxicity. The second category is asphyxiant agents. They may just act by reducing the FeO2. This is the case, for instance, for alkanes like methanes and butane. And also in some cases they may reduce and alter oxygen transport and extraction by tissue like carbon monoxide or hydrogen cyanide. And finally, some agents may have systemic activity different from that of asphyxia, like arsen. Toxicity of these compounds is determined by the dose, their inherent chemical properties, their water solubilities, and their warming properties. One important rule when discussing gas toxicity is Haber's rule. And this is in relation to the relationship between the concentration of the poisonous gas and how long the gas must be breathed to produce its toxic effects. And you see that the relationship is a constant depending on the properties of the compound. And that means if you increase the concentration, then you need a shorter delay to obtain toxicity, while if you decrease the concentration, you will require prolonged delay to obtain the toxicity. And the relationship is always a constant, so that the relation between the concentration and the time is linear on a log-log scale, as shown with these two examples of chlorine toxicity in mice and rats. What are the principles of inhalation poisoning management? Of course, generally there may be different and several persons intoxicated, and you have to make a triage distinguishing between exposition and intoxication. You have, of course, rapidly to identify the life-threatening presentations, to determine and investigate the circumstances of exposure. Then you have to rely for diagnosis on the physical examination, the readily available biomarkers if possible, and immediately to indicate the therapeutic means, including supportive care, decontamination, elimination techniques, and antidotes if existing. You see, toxicological analysis will only come afterwards and only confirm your first hypothesis. So we'll take 3 examples and discuss management. 3 examples taken from different situations that may result in a consultant in the emergency department. First, smoke inhalation in the fire scene. Smoke inhalation may result from fire, and fire may expose to 3 dangers: thermal, traumatic, and chemical risks. About 80% of deaths at the fire scene are related to toxic smoke inhalation, and 80 of them will occur immediately, usually immediately on the scene, while 20% of them may occur lately in the hospital. Of course, smokes contain different compounds, thousands of compounds. Some are responsible for direct cellular anoxic toxicity, like carbon monoxide and hydrogen cyanide, and others are responsible for irritant toxicity, like soot. Of course, the relative production of carbon monoxide and cyanide depend on the environment. The presence of cyanide was suspected in the 70s when comparing the deaths resulting in fire victims at the upper side of the slide and CO poisoning. And you see here that in case of smoke inhalation victims, there is a risk of death, whatever the carboxyhemoglobin is, while in case of pure CO poisoning, only deaths are observed with elevated carboxyhemoglobin of more than 50%. Carbon monoxide, of course, will alter the capacity of hemoglobin to fix oxygen and result in a leftward shift into the oxyhemoglobin dissociation curve, while cyanide will attach directly to some ferric forms of vital enzymes like cytochrome oxidase in the mitochondria, resulting in anaerobic glycolysis. How to make the diagnosis immediately? There are two fundamental signs with elevated negative predictive values. First, the presence of soot in the airways, and second, the presence of neurological impairment. In the absence of both signs, there is no smoke inhalation toxicity. In pure carbon monoxide, you should know that vital signs, except Glasgow Coma Score, are generally strictly normal, including lactates, which are generally very mildly elevated. Whatever, as you see on this slide, the severity of carbon monoxide poisoning is, and whatever the neurological impairment is. However, in smoke inhalation, in the presence of cardiovascular impairment, abnormal respiratory pattern, or huge elevation of lactate concentration, you will suspect, with a relatively good predictive value, the presence of cyanide poisoning. You see here that lactate is a good biomarker for cyanide poisoning, and there is a relatively good relationship between the elevation in lactate concentration and the elevation of cyanide concentration, even though lactate is not so specific even in these circumstances. These slides show you some differences between cyanide and carbon monoxide poisoning related symptoms. And you see that headaches, dizziness, gastrointestinal symptoms, loss of consciousness are more related to carbon monoxide, while coma, dilated pupils, abnormal respiratory pattern, and hypotension are related to cyanide poisoning. The second kind of toxicants that will be inhaled are those who will result in irritations. They will irritate the eyes and the respiratory airways. In the eyes, you may have red eyes, burns of cornea, conjunctivitis, and those are predictive of associated respiratory injuries. Respiratory symptoms will vary according to the localization of the injury. You may have obstructive laryngitis, bronchospasm, and of course, chemical bronchopneumonia. The presence and the emergency department admission of dysphonia or rhonchi are associated with a longer hospital stay. The tracheal and the tracheobronchial injuries will involve complicated pathways. Chemicals will activate epithelial cells, chemokine release, alveolar macrophage, resulting in the production of superoxide species and increasing the exudative injury and the bronchoconstriction. On the scene, immediately, you will be able to determine the possibility of carbon monoxide exposition by using pulse carbon oxide oximetry or even atmospheric measurement. Pulse oximetry, the usual pulse oximetry, will fail in distinguishing between carboxy hemoglobin and oxyhemoglobin. You will also require to sample bloods for carbon monoxide measurement and further cyanide concentration determination, and of course arterial blood gases. When admitted to the hospital, chest X-rays will be obtained. However, they are low, with low specificity and predictive values. Initially normal X-rays does not preclude further complications. In the ICU, microbiology of sputum may be interesting because, of course, bacterial aspiration is the first cause of complication. And bronchoscopy in burnt patient may have some predictive value. Rapidly, you have to decide the treatments. Of course, oxygen is immediate, and hyperbaric oxygen may be required in some cases, including consciousness loss, coma, neurological deficiency in children and pregnant women. Although you know that meta-analysis failed to demonstrate any benefit for hyperbaric oxygen to reverse and reduce neurological sequelae. In case of suspicion of cyanide, because this is based only on suspicion, you have to administer an antidote immediately at the scene or immediately after hospital admission. As you understood, neurological symptoms can be related to CO and CN, while the onset of any respiratory abnormality, any cardiovascular abnormality, a significant increase in lactate concentration are always related to cyanide. Thus, in these cases, you will suspect cyanide poisoning and administer an antidote. There are several possible antidotes. Sodium thiosulfate is probably the more natural one. It is efficient, safe, but with delayed activity, so not useful. Methemoglobin-forming agents are potent, but impairing oxygen delivery, so not useful. Cobalt EDTA are very potent, is very potent, immediately active, effective also if lately administered, but it has numerous side effects, especially if administered in the patient who is not poisoned with cyanide. Thus, to my opinion, hydroxycobalamin remains the first-line antidote to administer. 50 gram will bind 1 gram of cyanide in stoichiometric relationship, and you can infuse 5 gram repeated till 10 in case of cardiac arrest with low expected side effects, except reddish discoloration of skin and urines. This is now thus the first-line antidote confirmed by USEM guidelines in 2012, and you see that administration is recommended in case of Glasgow Coma Score of less than 9, or in case of Glasgow Coma Score between 10 and 13 with an abnormal ABC. Rapidly, when admitted to the ICU, some non-specific but also some investigational treatments will be administered to the patient to reduce the injuries to the lungs. We'll use, of course, oxygen, humidified oxygen, protective mechanical ventilation, bronchodilatators, mucolytic expectorants. We will limit the fluid therapies to reduce the risk of pulmonary edema and rapidly give some antibiotics. Corticosteroids are not recommended, and several investigational drugs are currently used, including aerosolized heparin, Exoserv as surfactant inactivation, exogenous antiprotease, and of course VV-ECMO ECMO is probably one supportive important therapy today for these most severely intoxicated patients. You have also to consider the toxicity of additional compounds in the smoke, like volatile organic compounds. And you see at least 3 of them, benzene, nitromethane, and ethyl acetate, were remarkably found, detected in the blood of patients associated with high incidence and highly correlated with CO in these patients. All these injuries may result in complications, of course, immediate bacterial infections and hospital-acquired infections, but also late complications, including bronchiectasis, chronic bronchitis, and pulmonary fibrosis. Don't miss the risk of post-interval syndrome, which is a well-known cause of brain injury following carbon monoxide inhalation. The second situation we'll discuss rapidly is the workplace. Hydrogen sulfide is a circumstance of poisoning, may be responsible for poisoning at the workplace. It's a colorless explosive gas, usually characterized by rotten egg odor, although the sense of smell usually fatigues in seconds after exposure. It is naturally produced by putrefaction of different organic substances, and it is responsible for irritant and asphyxiant toxicity. And you see that symptoms will be in relation to knockdown effects, pulmonary, cardiovascular, neurological, and metabolic complications. More recently, in France, in the Caribbean islands, Sargassum seaweed was responsible of mass poisoning with hydrogen sulfide, and you see even those seaweed were responsible for subchronic symptoms, including conjunctiva, upper airway irritation, memory loss, and modification of learning abilities. Management is mainly supportive, based on oxygen, irrigation of exposed skin and eyes, ventilatory support. Specific treatment is only discussed in case of persistent acidosis, coma, severe arrhythmias, with methemoglobin-inducing agents mainly. The third situation could be related to possible terrorist attack, with, of course, the risk of chemical warfare agents, and several episodes in the history illustrate this risk. Of course, probably one of the most scaring agents are organophosphorus compounds, and you know that they will act by inhibiting acetylcholinesterase, accumulating acetylcholine, and disturbing cholinergic functions, leading to bronchoconstriction, central respiratory arrest, paralysis, and inhalation. Clinical diagnosis is generally relatively easy, and to date, several readily available techniques could be used to allow immediate confirmation based on the measurement of cholinesterase activity in the plasma, or even the detection of the presence of organophosphorus compounds. Of course, you have to administer treatments, and one important issue is the administration of oxime, because as you know, the organophosphorus compound will immediately interact with acetylcholine esterase, and according to the organophosphorus phosphorus compounds leading to a covalent link with an aging enzyme, and thus a non-active oxime. Thus, the treatment relies on atropine administration to reverse muscarinic syndrome, benzodiazepines to prevent seizures, and of course, oximes that are required to reactivate the inhibited cholinesterase. And of course, as you see with the chemical warfare, probably prolonged oxime treatment is expected to be mandatory in the most patients. Of course, supportive care is also essential with oxygen, mechanical ventilation, and self-protection of the caregivers to allow secondary contamination. So, in conclusion, gas and inhalation toxicants may be responsible for acute, life-threatening systemic and irritant respiratory toxicity. They are also sometimes responsible for chronic disease resulting in respiratory and neurological disabilities. Smoke inhalation is probably one of the most important situations that an emergent physician could face. It's a polyintoxication. Cyanide plays an important role. While not uniformly present, it may often contribute to toxicity and lethality. Volatile organic compounds also should be considered, although to date their role is not really well known. Hydroxycobalamin is the first-line recommended antidote due to its safety and its efficiency in complement to oxygen and supportive care. And of course, many various gases and toxicants could be involved in inhalation toxicity, mainly at the workplace. Probably one important mechanism of action is just the reduction in FaO2, and management in these cases is mainly supportive. Thus, prevention and detection are mandatory. So before ending, if you're interested, and I'm sure about that, in toxicology, I would like to invite you to our EAPCCT Congress, the Congress of the European Association of Poison Centers and Clinical Toxicologists, that will be held soon in Naples, in Italy, during May. Thank you very much.
What do you think about contraindication of hyperbaric oxygenation treatment for carbon monoxide poisoning? Thank you.
The indications of hyperbaric oxygen, as in France at least, the number of centers able to provide hyperbaric oxygen is decreasing with time. Probably this is reflecting the fact that to date toxicologists do not believe anymore in the usefulness of this technique. I will not say that you don't have to do it. Probably you send patients, those who are most intoxicated with neurological symptoms and probably loss of consciousness. The risk of post-interval complications is related to the importance of carbon monoxide. It is never observed with carbon monoxide of less than 20 to 25%. So at least the patients will present a loss of consciousness. But to date, we have to observe that there is no definitive evidence to support its usefulness to reduce the risk of neurological sequelae.
Thank you.
Thank you very much. More questions? Yes, please.
Thank you. Welcome again. I'm just wondering, in your practice, how often do you face with carbon monoxide inhalation?
In my practice, I'm an intensivist. I work in the intensive care unit. Unfortunately, our hospital has no possibility to deliver hyperbaric oxygen. So patients generally are not referred to our ICU. But this problem is now decreasing in France because of prevention. Although it remains relatively elevated, but it is decreasing. To my opinion, I would say in France there is about 5,000 poisoning per year in France.
Thank you.
Because now, for instance, the use of an alarm in private homes is mandatory for insurance purposes in all the homes in France.
Thank you very much. I guess we have more questions. No?
Thank you.
Thank you, Professor Margaben, for such comprehensive overview. And our next speaker is Professor Vimal Krishnan from India. Who will talk to us about psychiatric consultation. When and for whom and for all whom.
Yeah. No, thank you. Am I audible? Am I audible? In the back? Yeah. Thank you, sir, for the introduction. I'd like to thank the organizers. I'd like to thank EPAD, especially Professor Bausa, for having us here. The topic that has been allotted is psychiatric consultation for who, whom, and when. I think it's a very soft topic. When you look into the other topics that you've heard all through the day, we've had riboas and open thoracotomies in the ER and ARDS and all those sexy topics have been taken on. So I guess what's left is the softness of certain topics which require a lot of decision making from our side as acute care clinicians. Show of hands, how many emergency medicine clinicians here, emergency clinicians here on the floor? Right. So the rest of you guys are critical care, is it? All right, we've got a mixed population here. I'm Dr. Vimal. I represent Emergency Medicine Association India, which is the largest association for Government of India approved emergency medicine specialists in our country. I come from a mission hospital. I work in a 2,000-bedded mission hospital in India. We cater to around 100,000 cases of 100,000 emergencies cases per year on an annual basis, an annual intake of 300 to around 500 cases per day. We do get quite a lot of infective cases in snake bites and inhalation injuries. CO, carbon monoxide poisoning is pretty common at our place. Right. With regards to the topic, I'd say dissecting psychiatric consultations in the ER requires a lot of effort from the acute clinician's side because we tend to negate that they aren't a true emergency. You tend to feel that your emergency is run with trauma, with chest pain, with pediatric emergencies, with seizures, with pregnancy. You tend to overlook the fact that psychiatric patients need care too. Those patients who come to the ER, present to you in front of you, they need to be looked after in a different sense. But then we don't have that mindset, do we? We have a different mindset. Are we ready to tackle those in the ER? That's a big challenge. The question is this topic worth talking about? Is it a topic worth pondering on, psychiatric consultations in the ER? Is it hot topic? Is it hot property? I'd say yes. I'd say yes because literature supports it. If you look into literature, the waiting time of patients in the ER, it's 3.2 times that for the psychiatric patient. It's not because the psychiatric patient is denied care. It's because of a mindset for all the healthcare professionals working in the ER to claim that these guys will need care only later on. Let's look after all the other cases and then come back to them. So it's a mindset problem. What happens when a patient stays 3.2 times longer? The boarding time in the ER is protracted. And what happens when your time is protracted? When there's a lot of time in the ER, there's a lot of trouble in the ER. That's what I face. And that's what most of the senior clinicians over here would agree with. When the patient stays in the ER for a longer time, we've got bigger problems. US, this is what they say. They've got around 7 to 11 hours in the ER alone. And if you're transferring that patient to a different facility, he stays over for around 24 hours. Would you believe it? And if you look into numbers from India, it's very smaller with regards to the data which is mined out. But I'd say we'd be pretty better off, but I'd still say we'd have our priorities in the lower list for a psychiatric patient. Now, look into this. 90% of patients, physicians who were asked about what they do with psychiatric patients said this. We've got violent behavior from psychiatric patients. We've got issues with stress amongst the healthcare professionals who are looking after psychiatric patients. We've got the whole flow pattern in the ED disrupted because of psychiatric patients. So we're not very happy dealing with psychiatric patients. The decision making takes a toll on the healthcare professional. They're not happy taking decisions on the flow. Now, they consume the scarce ED resources. Everybody here would agree with me that our resources are always scarce. With the emergency department, we want more every year. We get more patients every year. The need for the patients also increase on a yearly basis. We study new things. We get new tools. We try to implement newer tricks of the trade for the patient who's dying on us. But then we also tend to realize that time is the biggest commodity that we have. And we're losing out time when you look in not looking after that patient. And if you look into the time frame that you spent with the patient, which is around 3.2 times the delay, that patient stays for a longer time in the ER, and that ends up taking up a bigger chunk of time of your clinical work. What does it lead to? It leads to this. It leads to delayed attention to undifferentiated, chaotic patients who are waiting for you, who are really sick. Do you realize that there are patients who present to us as generalists in the emergency department? They're basically undifferentiated. They basically do come at 3 a.m. in the morning, very chaotic, in a chaotic environment. When the world is sleeping, we're working. It's tough taking decisions then. So patients with undifferentiated medical issues would be denied timely care because our focus is elsewhere. Our focus has been distorted due to the problems in the ER, the stress in the ER. Now, I've established the fact that this is important. We need to take into consideration the patient in the ER. Now, I'll start with a case scenario. Case scenario is pretty simple. The case scenario that would come to you any time of the day. An 80-year-old male who's a known schizophrenic who comes to you with acutely altered sensorium. And the biggest problem that we face, vague historians. The patient doesn't give you a good history. The caregiver doesn't give you a good history. The only strong part is that he's hemodynamically stable. So you're comfortable. Oh, I'm comfortable. He's a hemodynamically stable patient, but he's schizophrenic. Now what happens next? You see the patient, and he looks like this. What next? So you'd say, let him wait there. I'll look after all the other cases, and I'll come back and take a look at him. But remember, any case that presents to the ER wouldn't be like this. Wouldn't be like the Mad Hatter from Alice in Wonderland. It's a very different game because patients don't present in black or white. Patients don't present with either being totally crazy or being completely actively good in the ER. They present in a chaotic sense. What do they present with? They present in the gray zone. They present as patients who are not either really good nor really bad. What do you deal with? You deal with triage in the ER. Is it a good tool? We've known earlier itself. In the hospital, there's no ideal tool. Professor Alvi has told about that yesterday too. It's not an ideal tool in the ER. What do you do next? You believe on your subjective feel. Okay, I don't feel that patient is good. Your head nurse comes and tells you, Doc, I don't feel that patient is good. You need to take a look at him again. That's when you realize that most of the patients who present to you aren't black or white. They're in shades of gray. And it is your job as the acute care clinician to figure it out where you are. Now, if you look into patients presenting to the ER with a psychiatric illness, they complicate things more because you've got 4 patients in the back of your head with trauma. You've got 1 coded patient going on. I've got 2 kids who are crying with trauma, needs suturing in the background. Oh, I've been called for an intubation in between. My resident calls me because he's got a crash in the ED ICU. In between, I've got a patient who's crazy. What do? I am more confused. My mind doesn't think alike. What do I look into? I look into the vortex of death. I talk about the vortex of death when you're dealing with specifically hard topics, like right ventricular failure in the ER. What do? You don't treat them like left ventricular failure. Right ventricular failure, if you treat them like left ventricular failure, they're going to end up with death. If you're going to intubate a guy with acute right ventricular failure in the ER, and you use your rapid sequence intubation sequence, that patient's going to die on you the moment you place a scope. That is what's going to happen. So what do you do next? You think of putting them in domains. You think of taking the whole psychiatry domain, breaking them into bits, and then specifically putting the patient there. I'll break them up very quickly. Thought disorders, people with schizophrenia, they've got thought problems, they're deluded. Most of the patients who come with acute delirium could have a medical issue. But remember, it might not always be a medical issue. Medical mimics do need to be cleared prior to tagging them that they've got a problem which is medical emergent or could be supracortical as a term, which is a very bad terminology. Mood disorders, people would come in with depression. It's on the rise. If you look into WHO, if you look into literature, you could read that the world is becoming more and more depressed, right? Or the other end of the spectrum, people could be bipolar and agitated. He'd come around shouting in the ER. He'd stress everybody in the ER. Right? Every healthcare professional in the ER would be stressed with him. A person would come down who is suicidal. Do you remember that any person who comes down with deliberate self-harm, he's taken something he's taken some poison, he's allegedly consumed something. You look at him with a different perspective. You look at him as a patient who's consumed a toxicological thing, and you look at the effect that the toxicological stuff has on him. But you take a step back and also remember that he's a human being who's been pushed to the limit to commit this. So there's a problem there. You need to call in their psychiatric consultants to help you out there. Anxiety disorder, with the world, with the brink of disasters and trauma on a big scale, post-traumatic stress disorders, post-disaster issues. We've had a tremendously great talk on disaster, a big session on disaster yesterday. Is it just physical? No. There are things which would hurt you mentally too. How do you do a triage for a person who's come down post-disasters, who's physically all right? You don't do the SALT or the STAR triage. What do? You do the PSY triage. You do the PSY STAR triage, PSY START triage. It's a tool that you use to figure out how good he is in his spectrum, how he's faring with regards to his acumen post the event. And I'd add these two domains too, somatoform disorders and malingering. It's a very thin red line between the two. The somatoform guy doesn't know that he's got a problem, while the malingerer knows that I've got a problem. I'm going to fool the whole scenario to gain out of it. The somatoform guy doesn't know that he himself is getting fooled, right? So if you could get them in either of these 7 domains, you're good to go forward. Now with this, I'd come to the heart of the story. It's always important to medically clear a patient who's come out with acute delusion or delirium, I'd say. But it's not easy. The psychiatrist, the psychiatric consultant at the other end would say, you just clear the patient medically and then admit under us. The internist or the general medicine guy would say, oh God, you need to get a clearance from the psychiatry side prior to you pushing the patient here. And then the neuro department would say, I think this guy needs to be evaluated medically first, right? It's like the Thanos snap. We are supposed to clear out everything with limited information in limited periods of time. That is what they push us to do. What do? We deal with rules of thumb. I'll give you some rules of thumb. This is a general consensus. A patient who's really old, a patient who's got multiple comorbidities, and he's severely agitated with abnormal vital signs. Now these guys with acute comorbidities and co-ingestion of some toxical agents need to be evaluated medically prior to being pushed to the psychiatry section. Yes, we'd get a call from them later, but not now emergently. So anybody with abnormal vital signs, advancing age, severe agitation, on any acutely, if he's ingested anything acutely, he needs to be evaluated medically prior to being pushed to the psychiatry side. What about labs? How many of you guys use point-of-care stat lab in the ER? Point-of-care labs? Point-of-care labs? Yeah, you do your ABGs, you do your troponins, you do your biomarkers in the emergency department itself. We tend to do that. So there's an inclination for an acute care clinician to do a battery of tests for these guys. A battery of tests, right? A blanket of tests for any person who comes with altered sensorium. Oh, I got to do this. It shouldn't be that way. It shouldn't be that way because literature tells you that it's always better to be patient-specific and to have that intuitiveness on the clinician side to understand, okay, this patient doesn't need that blanket of tests. This patient needs these tests, but doesn't require that test, right? It requires your intuition, and it also requires patient specificity. Now, guidelines have come into this that routine labs are not warranted. It might lead to more confusion rather than more clarity. Now, psychiatry more than medical. You need to get them to the psychiatry more than medical when the patient's actively suicidal. You just can't keep them with you because you might end up on the wrong side of the boat. When the patient is actively suicidal, when the patient's dangerous to others, when the patient's got a psychotic event for the first time and you've cleared all the medical issues, or when the patient's so bad that he can't take care of himself, it precludes him for self-care. These are patients who need to be evaluated by the psychiatrist initially itself, not later on. You got to get him through the pathway, through the chain into the psychiatric pathway so that he'd get optimal care rather than just being pulled into the medical side. It's not working. Right. Now, if you just objectivity. We as acute care clinicians, we tend to be more objective. I've got pain in the ankle. I'll do the Ottawa angle rule and then think whether I need to do an X-ray, right? We got a patient post-trauma with altered sensory, we try to do a GCS. We got a small child with head injury, we try to do a Pecan rule to make sure whether you need to do a CT in this child or not, right? We tend to risk stratify them, we tend to objectify them. Now, DSM-5 criteria, it gives that objectivity that you need when you're looking after patients who are coming from the psychiatry realm, who've got acutely delirious, who've got a history of psychiatric issues. You need to do the DSM-5 criteria. You need to, for suicidal ideation, for patients with suicidal ideation, you think of using scoring systems. Again, there are different universities with different scoring systems. Columbia is one of the scoring systems that you can use. The safety triage system, which is suicide assessment and 5-step evaluation method. It's an excellent tool which universities do use to risk stratify guys with suicidal tendencies. So they do end up with the psychiatry department only after these tools are used, and they're stratified that these guys need to go into the pathway with psychiatry friends rather than with the internist in the department. To summarize, when and whom would you call for a psychiatric consultation? I'd say a person with substance abuse definitely needs to be evaluated by the psychiatrist, a combative patient after he's medically stable, a patient with deliberate self-harm who's got suicidal ideation, a person post-disaster who's traumatized post a disaster or traumatized post a traumatic incident needs to be evaluated by the psychiatrist. But I'd say it's not just them. What about us? We're always talking about the patient. I think there's a lot of focus on wellness today. There's a lot of focus on the clinician who's taking care of them. We've seen yesterday fantastic lectures from Dr. Alvi, Dr. Casio. We've got stalwarts in the field of disaster medicine coming and telling us that we've been there all around the globe helping people in disasters. But when we come back, a part of us stays there. We come back as a different person. So, like he reiterated in his lecture, we need to talk to the right person, to make us feel whole again. Healthcare professionals, nurses, doctors, paramedics, technicians, people who are there in the forefront at war zones, they need to have that sort of connection with the psychologist to just extract what's burning them from inside. Let's not push healthcare professionals to burnout. So stress and the impaired healthcare professional needs to have an evaluation from the psychology side, which again comes under the bigger umbrella of a psychiatry department. Beyond the medical issue, or summarizing why we need consultation, why do we need it? My first 2 slides focused on the literature review on why we need decision-making in the ER for psychiatric patients. System problems, EM systems, overholding the emergency department, staying too much in the department, leading to more of morbidity, mortality in the department, too much stress for the healthcare professional in the department. It all adds up. You need an optimal disposition plan for a patient with psychiatric ailment, and beyond the realm of medicine, you're going into the realm of psychiatry. So it's always optimal for that patient to walk into your clinic or your ER, find out whether he's got a medically relevant problem which has pushed him to this, and then get a clearance from your side and move towards the realm of psychiatry. The future, I don't know, I don't think so that anybody can predict the future. There aren't any Nostradamuses around. It's very difficult to predict the future. But what we'd say is we'd extrapolate the little information that we have today to draw lines on what could happen in the future. So if you ask me, there is no pill that can be given that can tell you that you could take this pathway and that's going to happen in the future, or that pathway and that could happen in the future. It is never going to happen that way. It's more complex than that, and science is evolving at a different pace. What I can tell you is, we have telemedicine. We had a fantastic take on digitalization in the emergency room by Dr. Barbara Hogan. And she spoke on how telemedicine could help us. Telepsychiatry. There are umpteen articles which are coming up on telepsychiatry, how that could help, overcome the problems of psychiatric patients holding in the emergency room, how overcome the problems of not having psychiatric support in my institute, if there isn't any. So you could have that. Observation units are taking the world by storm. There's a lot of controversy to observation medicine. There are people who claim that, insurance guys do save a lot of money, but then it's not that good for the patient. It adds a whole lot of load for the emergency department, about the staffing in the emergency department. So OUs, psychiatric OUs, it's been studied now that POUs, or psychiatric observation units, do help decompress the pressure which is there in the emergency room. Push the back pressure for not admitting these patients and those patients holding up in the ER could be relieved by having psychiatric observation units. And I'd say the most important part would be risk stratification tools and algorithms. We're not coming together and developing consensus guidelines on risk stratification tools for the psychiatric patient, because that is not hot property. You talk about chest pain, we've got consensus statements. You talk about traumatic brain injury, we've got consensus statements. You've got pediatric seizures, consensus statement. Pulmonary embolism in pregnancy, consensus statement. What about psychiatric patients? What about disposition plans for psychiatric patients? So we need to have different associations coming together and forming psychiatric patient, forming a guideline for the psychiatric patient. The case scenario, the 80-year-old male, schizophrenic, altered sensorium, vague historian, hemodynamically stable. I still know that it's not easy. I still know that that patient would look like this wolf hiding behind the herd of cattle. It still isn't easy. But then it is your intuition as a clinician, it is your duty as a person who could integrate multi-department and could facilitate dialogue to form a protocol which could help you to take a better decision in your institute. You could be the end of the puzzle. You could be that piece which could help fit in a complete plaque for the betterment of patient care. And I'd say our role is to integrate between different specialties. We are interfacing with the public, we are interfacing with the psychiatrist, we are interfacing with the intensivist, with the surgeon, with the hospital administrator, with the police force. We are interfacing with almost everyone. So I guess we have a role like this, the guy in the center. And I'd end my talk with this quote by Napoleon. Because Napoleon once said, the world is suffering a lot, and it is not due to the violence of bad people. It's due to the fact that we are more silent, the silence of good people. Let's keep on talking. Let's initiate dialogue. Let's get more people in the room and form consensus statement for the betterment of patient care. Thank you, ladies and gentlemen. These are my references. I'd like to invite you to the national conference which is happening in India. It is happening at the end of July, beginning of August. We're having it in the beautiful capital, New Delhi. So you could fly down during this time. We'd be happy to host you guys for a national conference. I'd also invite you, because I'm the board member for the World Academic Congress in Dubai. I'm part of the board for the World Academic Council. We've got multiple leaders here from the World Academic Council. So the World Academic Congress for Emergency Medicine specifically focuses on a TED Talk format pattern with speakers from all around the globe in Dubai this year. So do come for that. That's coming up in October, and it's going to be a fantastic time. We're going to have a fantastic time there. Thank you for your patient listening.
Thank you very much, Professor Vinam. So please, your questions. If I may, I have a question. So in ideal situation, in the end of the day, for your opinion, what should be first, the primary psychiatrist background for this kind of patient, or primarily ER background?
The ER. What we've done is we've had written statements in collaboration with the psychiatry department and the internal medicine department. The internist in the hospital, the psychiatrist, and the emergency medicine guys, they sit down, they troubleshoot, brainstorm, and form a guideline on what we should do with a patient who's got a mood disorder, what we should do with a patient who's got a thought disorder, what we should do with a somatoform disorder. So we get a guideline which is down, and then we stick to that. We revise that guideline every time with a morbidity audit that we have in the emergency room. So I think the way forward would be integrating those basic sciences together, and to regularly do audits so that you could correct and evolve at a better pace.
Thank you.
Thank you.
Thank you very much. And dear participants, our final presenter for this session is Professor Polat Durukan from Kayseri, Turkey, which will highlight us the topics which patients should be in ICU.
Dear
Professor Durukan.
Yeah. Dear moderators and audiences, I think this will be the last talk in this session. And I will talk about which patients should be in intensive care units. We all know that we have very limited and expensive resources for the intensive care units. The cost of critical care in the United States was estimated to range between 121 to 263 billion in 2008. Crowded intensive care units, delayed admissions of critical ER patients, care delays, and other delivery inefficiencies are also problematic issues. These concerns forced the medical community to act smarter and evidence-based on this matter. Thus, in 1999, the Society of Critical Care Medicine published guidelines for the intensive care unit admissions, discharge, and triage. Given the fact that medical expenses are not getting smaller and emergency rooms are still and intensive care units are not getting emptier, the topic is still a current challenge for both intensive and emergency caregivers. It's also a big problem, I mean the number of ICU beds in Turkey. So which patients should be admitted to emergency ICUs is a very important question. It's reasonable to develop policies to meet specific population needs, such as trauma, burns, neurological pathologies, sepsis, and take into consideration the institutional limitations, such as ICU size and therapeutic capabilities or number of medical staff. To optimize resource use while improving outcomes, hospitals should give ICU admissions on the basis of a combination of various parameters. These parameters are specific patient needs that can be addressed only in ICU environments, such as life-supportive therapies, available clinical expertise, prioritization according to patient's condition, diagnosis, bed availability, objective parameters at the time of referral, and potential for the patient to benefit from interventions. Prognosis is also important. We can discuss three models for guiding admissions of the patients to ICUs. These are prioritization model, diagnosis model, and objective parameters model. Deciding priority is very important. Patients are categorized in the prioritization model. Patients are categorized by 4 priority levels based on how likely they are to benefit from admission to ICU. In the priority 1 level, critically ill patients who require life support for organ failure, intensive monitoring, and therapies only provided in ICU environment. In the level priority level 2, we have patients, as described above, with significantly lower probability of recovery and who would like to receive intensive care therapies, but not cardiopulmonary resuscitation in case of cardiac arrest. In level 3, patients with organ dysfunction who require intensive monitoring and or therapies. And at the level 4, patients, as described above, with lower probability of recovery. These patients, for example, with underlying metastatic diseases. And for palliative care, at the level of priority 5, terminal or moribund patients with no possibility of recovery, such patients are in general not appropriate for ICU admissions. In the diagnosis model, a list of specific conditions and diseases is offered for deciding which patients should be admitted to ICU. For example, some cardiac system abnormalities like acute myocardial infarction with complications, cardiogenic shock, some pulmonary system diseases, acute respiratory failure requiring ventilatory support, pulmonary embolia with hemodynamic instability, some endocrine disorders, some neurological disorders, acute stroke with altered mental status or coma, maybe examples. Some endocrine disorders, for example, diabetic ketoacidosis, some life-threatening gastrointestinal bleedings may cause ICU admission, or drug ingestion or drug overdose may cause ICU admission. Some postoperative patients requiring hemodynamic monitoring or ventilator support they also may need ICU. And we have some miscellaneous causes, for example, septic shock with hemodynamic instability, clinical conditions requiring ICU level nursing care. They may also need ICU admission. In the objective parameters model, the last model, the specific vital signs, laboratory values, imaging or electrocardiogram findings, and physical findings are offered for deciding which patients should be admitted. But unfortunately, all these models have limitations and none have been properly validated. If we look at the literature about the admissions, in a study, they suggest that admissions to the ICU should be based on functional impairment rather than just severity of illness. They showed that functional impairment at the time of intensivist evaluation was the determining factor influencing ICU acceptance. Patients were less likely to be admitted if their functional status was poor or they had a do not resuscitate order. In another study, their data, after studying a program in which abnormal vital signs were used as criteria to trigger patients to be admitted to ICU until their conditions improved or stabilized. Another study here, you see, they suggest that respiratory rate alone should be a major determinant for ICU admissions, but there is not a reliable list of objective indicators or their respective specific thresholds for identifying candidates for ICU admissions. On the other hand, in another study, we see that they showed that the sensitivity and specificity of abnormal vital signs to predict death or ICU admission at triage were only 73% and 50% respectively. In another study, we see that they investigated the feasibility of using a triage score to assist in deciding about ICU admissions. The score is incorporated with age, diagnosis, vital signs of the patients, was a procedure use, or operative status, chronic disorders. These are all related issues. What about QSOFA? In 2016, a task force have described an assessment score for patients outside the intensive care unit as a way to facilitate the identifications of patients potentially at risk of dying from sepsis. This score is a modified version of sequential organ failure assessment score called QSOFA or QSOFA. A score 2 or more than 2 is associated with poor outcome due to sepsis. QSOFA score score is easy to calculate since it only has 3 components. You see, we have respiratory rate, altered mental status, and systolic blood pressure. In 1999, a group of experts appointed by the Department of Health in the UK suggested that patients in hospital should be assigned a level of care based on an assessment of their clinical needs, regardless of their care locations. In their review of critical care services published in 2000, they described these levels as Level 0, regular hospitalized patients with no intensive monitoring or care requirements. Level 1, patients requiring additional monitoring such as continuous electrocardiographic monitoring. At level 2, patients requiring more frequent monitoring and interventions such as those with single organ dysfunction, which cannot be provided in previous level. Level 3 patients, these are requiring life-supportive therapies such as those with single or multi-organ failure, which can only be provided in the ICU. In Turkey, we also use this leveling process. It is used by Ministry of Health for the assessment of intensive care units in Turkey. So we need some guidelines. Recently, Society of Critical Care Medicine published guidelines which also questioned ICU admission criteria. These guidelines are, for example, avoiding admitting patients to a specialized ICU dose primary diagnosis is not associated with that specialty. We should admit neurocritically ill patients to neuro-ICU, especially those with a diagnosis of intracerebral hemorrhage or head trauma. Each institute should develop individual methods for prioritizing and triaging patients. Triage decisions should be made explicitly and without bias. Ethnic origin, race, sex, social status, sexual preference, or financial status should never be considered in triage decisions. Under ideal conditions, patients should be admitted or discharged strictly on their potential to benefit from ICU care. So these patients, in general, patients admitted to the ICU should meet one or more of the following criteria. For example, patients requiring care involving specialized competence of ICU staff that is not widely available elsewhere in the hospital, and patients having clinical instability, and patients being at high risk of imminent decline, they should be admitted to ICUs. Who should make the decision? It is reasonable to have a designated person or service with control over resources and active involvement to be responsible for making ICU triage decisions during normal or emergency conditions. What about terminal cancer patients? In particular, cancer patients with advanced disease, it is reasonable to discuss care options with the patient next of kin, legal representative, or power of attorney. Oncologist or hematologist opinion regarding life expectancy and palliative solutions should be taken into consideration. ICU triage in epidemics, it's an important issue. Non-traditional settings should be considered and utilized for the care of critically ill patients. Using routine laboratory studies or scoring systems alone in determining the nature of illness during an epidemic might be misguiding. All hospitals and regional areas should develop a coordinated triage plan for the epidemics. And in mass casualty events, the disaster response team should identify all patients in need of intensive care unit care and those already hospitalized who could be discharged. Then triage and transfer incoming patients to the most appropriate settings as soon as possible. Thank you for your attention.
Thank you very much, Professor Polat. So we still have time for questions. Please. So no questions. Nevertheless, thank you very much again for a fantastic presentation. Thank you. So dear ladies and gentlemen, the agenda is over for this session. We have been delighted to hear so during this session, the highlights of the management of inhalation intoxications, the tricks in psychiatric consultations, and very comprehensive overview about the patients who should be in the ICU. So thank you very much and enjoy your evening.
So clear to me, it's where I need to be.
Değerli arkadaşlar, bu 4 günlük 9 salonda olan, gece 9'a 10'a kadar süren, her anını değerlendirmeye çalıştığımız kongreyi hep birlikte başardık. Son ana kadar yanımızda kaldığınız için, son ana kadar bizimle birlikte olduğunuz için çok teşekkür ediyorum. Biz büyük bir enerjiyle bunu yapıyoruz. Bakın dün gece Zeynep Hanım'la gece 1'e doğru kongrenin çalışmalarını planlamaya başladık. Çünkü yönetim kurulu toplantımız 12.30'da bitti gece. Sadece yönetim kurulu değil, dergi toplanıyor bir tarafa, yeterlilik kurulu bir tarafta toplanıyor. Dolayısıyla bu kadar yoğun bir tempoda geçirdik kongreyi ve biz hedeflerimize ulaştık. Yapmak istediğimiz şeyleri gerçekleştirdik. Ama biz hep daha yukarıya gitmeye çalışıyoruz. Bir sonraki kongrede bu yüksek atlama. Hep çıtayı daha yükseğe, rekoru daha yukarıya taşımaya çalışıyoruz. Bir aile gibi olduk. Özellikle International aile. Roger Dickerson sürekli yanımızda. Eric Revel sürekli yanımızda. Şimdi bunlara Meksika'dan Carlos eklendi. Kanada'dan Jim McEwen hep yanımızda. Biz büyük bir global aile haline gelmeye devam ediyoruz. Burada yaptığımız her işlem uluslararası arenada ses getiriyor. Biz sadece lokal bir organizasyon yapmıyoruz. Kıtalar arası bir yapıya bürünmüş durumdayız. Yıl boyunca 300'ü aşkın aktivasyonumuz var. Gerçekten bunu birçok kişi duyduğunda bunun ne kadar yani inanılamayacak bir şey olduğunu söylüyor. Şimdi sizden beklentimiz şu, lütfen bu dev yapının altına girerek siz de omuzlarınıza alın. Herkes o bir şey alıyor, daha fazla girin. Biz de yükün altına ne kadar çok girerse o kadar çok değerlisin. Ve bu çalışmalarımızın karşılığını hayatınıza mutlaka bir şekilde alacaksınız. Bu kadar büyük çalışmaları daha büyük ekiplerle yapmak gerekiyor. Dolayısıyla bu kongrede biz buna çok dikkat ediyoruz. Ve geleceğe taşımak istediğimiz veya geleceğe beraber yürüyeceğimiz kişileri bu kongrede belirliyoruz. Keşfetmeye çalışıyoruz. Biz bu kongrenin başlangıcında başlığı ne atmıştık? Bir hatırla. Afşin sen önündesin değil mi? Başlığı hatırlıyor musun? Ön sözün başlığı. Dikkat ölçüyoruz. Geleceğe yürüyüş. Geleceğe yürüyüş. Biz hep birlikte acil tıbbın geleceğine birlikte yürüyeceğiz. İnşallah. Onun için de hepinizden alacağımız güce, enerjiye ihtiyacımız var. Ya beni hoca aramıyor, ya ben burada etkili değilim, ya ben burada... Böyle bir şey yok. İkincisi biz sağ bek istemiyoruz arkadaşlar. Sağ bek istemiyoruz. Biz orta saha oyuncusu istiyoruz. Ya da forvet istiyoruz. Sağ bek nedir? Ya bunu yakala, görevini yap. Ya görev değil ya, tamam ben sana söyleyeceğim, o görevi yap. Bu adamı oradan geçirme, onu istemiyoruz. Sen oyun kur, oyun. Bana oyun kuracak eleman lazım. Ben sağ beki ne yapayım? Sağ bek dünyada bir sürü var. Ama oyun kurucu bulamıyoruz. Alex gitti, sonra ne oldu Fener'in hali görüyorsunuz yani. Oyun kurucu yok yani. Oyun kuruculara ihtiyacımız var. Sağ beklerimizi her yerlerde bulabiliriz. Onun için sizden ricam, oyun kurun, oyun kuracak, tabi bunu yanlış manada anlamayın yani, oyun kuracak elemanlara ihtiyacımız var. Dergilerimiz, televizyonumuz, gazetemiz, hepsi sizi bekliyor. Lütfen sadece basit bir dernek mentalitesiyle bu işi düşünmeyin. Dev, vizyonu büyük, örnek, lider bir kuruluş olarak düşünün bizim yapımızı. Ve bu bir lider yapıda ne kadar çok görev almak isterseniz o kadar çok önünüzü açacağımızı bilin. Son ana kadar bizimle berabersiniz, yola gideceksiniz. Yola gitmeden önce adet üzere baskın seçim yapıyoruz. Espri yapıyoruz. Yani soruyorlar seçim var mı ya? Seçim yok, seçimin bir zamanı var. Zamanı gelince de açıklayacağız. Dolayısıyla sormayın. Genel toplantımızda korkmayın. Ama ibra istiyoruz. Bizi ibra ediyor musunuz? Yani ibra, yani güven oyu veriyor musunuz? Bak güzel yaptınız bu kongreyi diyor musunuz? Biz hep birlikte bu kongreyi çok güzel yaptık. Hepinize çok teşekkür ediyorum ama şunu istiyorum. Lütfen şöyle bak biz burada diyorum ya gece başladık. Ben şimdi eve gideceğim belki yarın. Bilmiyorum. Dönüş uçağımı daha onu bile ayarlayamadım ama şey var. Cuma günü yoğun bakım kursumuz var. Ankara Şehir Hastanesi'nde. Oraya gideceğiz. Cuma, cumartesi. Yani bizim 3 gün dinlenme, 4 gün boş kalma gibi bir şeyimiz yok. Şansımız yok. Burada şunu da söylemek istiyorum. Özellikle yabancı dinleyici arkadaşlarımız da var. Biz uluslararası üye de kabul ediyoruz. ERİK'in son dersini kaçırmayacaktınız. Atüder'e yaptığı çok güzel bir jest vardı değil mi? Atüder görenler oldu. Sosyal medyada göreceksiniz. Yani bu kadar bizim içimizden biri olmuş artık konuşmacılarımız. ERİK'e de bu yüzden özellikle bir alkış rica ediyorum. Gelecek yılın sekreteri. Biz for ERİK. And Roger Dickerson. Biliyorsunuz en renkli sunum herhalde Roger Dickerson'ı da bu yüzden alkışlayalım. Arkadaşlar, hepinize başarılı, güzel bir gelecek, uzun, başarılı, sağlıklı bir ömür dilerim. Yolunuz açık olsun. Dışarıdan geçerken kitap alabilirsiniz. Kitap almayanlar kitap alsınlar. Bu büyük ailenin fertleri olarak hepimiz daha ileriye birlikte yürümeye devam edeceğiz. Saati şimdi mi vermiştik? Niye geliyorsun? Yok devam edin. Arkadaşlar buyurun hepiniz gelenler oldu da onun için söylüyorum. Ben bitirmek üzereyim. Hepinize iyi yolculuklar diliyorum. Bana her zaman ulaşabilirsiniz. Yönetim kurulumuza her zaman ulaşabilirsiniz. Büyük bir ailenin ferdi olmaktan, sizinle birlikte çalışmaktan, sizinle aldığımız bu enerjiyi büyük bir hizmete dönüştürmekten çok mutluyuz. Hepinize iyi günler, ve emanet olun.
If I wasn't presenting, most probably I would either be on bed or having my breakfast right now. So good thing, I think they record the talks and people can view it later on. So that's completely fine. Also want to thank Professor Bassar and Professor Badgett and all the organizing and scientific committee for allowing me to come for the fourth time in this wonderful gathering. So my talk today should be nice, short, and fun at the same time. I was giving the topic of the utility of brain MRI in the emergency department. So the way I view it, it's more of an operational, I think, topic to talk about. It's not how good is an MRI as important as how feasible is to have an MRI and how effective and how practical is to have an MRI in the emergency department. I don't think anyone would doubt that the MRI is in a great way of image. So what I'm going to talk about, first I have nothing to disclose, so I'm just going to take it off the list. So I'm going to talk about one slide of physics so I don't bore you guys, and some justifications for MRI, as well as definition and types of MRI, utility in the ED, and some brief, quick take-home messages to take from my talk. So physics, what you need to know about MRI, just like you have three elements for an MRI machine. You need a strong magnetic field, you need a radio waves, and you need a good computer system to be able to generate the images. Don't worry about what I'm having here, just look at the picture. So if you look at the picture, really, they're all targets. The hydrogen proton that you have, it's a single proton, and you activate the magnetic field, then you kind of give an impulse of radio wave, then you stop those radio waves, then the organization of the proton pumps happens again, then the computer will be able to generate the image. This is what you need to know about the MRI machine, really nothing more than that. So, justification, as I mentioned in the beginning, choosing the right modality imaging in the ED is very challenging, and we always fight with our colleagues in the radiology department. When we order a CT, they give us a hard time sometimes. Why are you ordering this CT? Why are you ordering CT with angio? Imagine we're going to tell them, okay, now we want to order MRI directly from the ED. So we really have to have a good justification why we're ordering the MRI. So that's on the shoulder and burden on ER physicians. We should understand why we're ordering MRI, when to order MRI, and the utility of MRI. And we should ask ourselves, is the MRI going to change my management in the acute setting, in the emergency department, or it can be postponed and be done later on the admission phase or on the second day? So do we have to bring the technician from home, open the MRI, or no? Also, when we think of MRI, we should think of the cost. Many think MRI at least costs us twice as CAT scan plus an extra $100, it depends on the place. However, sometimes it is the most appropriate test, then it's okay, it's fine, it's justifiable to do this. Availability of MRI, most places don't have it, most places I would say in the US don't have MRI 24/7 with technician. I think the shortage of technician is an issue. Also, availability of radiologists who can read the MRI in 24/7 basis is challenging. So before asking yourself the question, should I start MRI in the emergency department? Do you have enough manpower to read those images? You don't want to do an MRI and wait 7-8 hours for the radiologist to read it. So this kind of contradict the whole idea. You need an MRI to make a fast, quick decision. If you're going to read it the next day, then why bother even with getting an MRI in the ED? Caution and contraindications, we're going to speak about them of MRI, also impact your flow and your operational value of getting an MRI. So, funny enough, my colleague, he's a radiologist, he's the head of the department. He sent me an image on WhatsApp yesterday. So I thought it was hilarious. He didn't know what I'm talking about. So you should start with seeing the patient, then obtain some history, then get some physical examination, then order a CAT scan. But like, they make fun of us and emergency doctors, which just go ahead and give the CAT scan. And I think one of our colleagues today is going to speak about history and physical examination. Should we quit doing history and physical examination? So imagine if I showed this and send it back to my friend, adding, okay, don't even bother with CAT scan. We're just going to start with our eye and our patients. So that's going to be kind of, this is going to give them stroke if we do it. So, common ER MRI indications. So I was asked to speak about brain MRI only, but common, like usually most of the time it's used in the neuroimaging. You can scan the brain, the spinal cord, arterial dissection for infectious processes, also for pregnant patients, basically for the abdomen, also children, and MSK, especially orthopedic sports related injury, all the athletic know that that's the best way of modalities. Whenever ordering an MRI, even if you think it's practical and useful, you should take an account and consider what are the precautions, what are the contraindications of getting an MRI. As I mentioned, cost, claustrophobia, inability to patient stay still, and I need devices or metals implanted on these patients. And let's be practical. If you ask the patient through the screening list, do you have any metals? They can say yes, but do you know if this metal is compatible with the MRI machine or not? You will take a couple of minutes, sometimes it will take 30 minutes or an hour to identify if this metal or object is compatible with an MRI machine. This will add to the operational problem you have to start with. It will delay getting the MRI and will delay the whole benefit of the whole thing. You need a quick decision to make. So this just kind of point out for you the different types of MRI and what are you looking for. So in the first, I don't think this is working. So the first part is like looking at the parenchyma. So the MRI you want to get a diffusional weight MRI. Its benefits, it's very sensitive to early ischemic changes. It starts in minutes and can get it out. Challenges, as I mentioned before, usually availability. If you want to assist the vasculature, always think of MRA, magnetic resonance angiography. It gives you full details and it does not require any contrast to do an MRA. Tissue perfusion, CT perfusion or MR perfusion, and it gives you wonderful resolution. Again, all of them, the challenges would be availability and time value. And this just give you the differences between the diffusion and the non-diffusion CT, and you can see the different clearance of the image. And when we talk about diffusion, perfusion, and the mismatch to identify the penumbra, and this is what you get, and this is how neurologists assist the need for mechanical intervention or any thrombolytics. So, a couple of important points about brain MRI. There is no standard imaging protocol for any acute stroke or TIA, except everyone agrees you have to start with a non-cone CT. After that, it's completely institutional dependent. It depends on your institution, it depends on your infrastructure, and what materials you can bring to it. What is the goal of neuroimaging? You want to provide rapid information to the physician. You want to increase the provider decision making with regards to reperfusion therapy without causing harm from delay. So again, if the MRI is going to delay your decision making, there is no point of doing the MRI in the ED, then it's not the best test for you. We all agree, and evidence agree, MRI has significantly greater detection rate for acute ischemic infarction. CT scan have 73 to 88% in the first 12 hours. MRI sensitivity is 93 to 100% in the first few minutes. So you can't really compare them. Not all acute stroke requires intervention, so MRI might not be indicated emergently if you think your patient will not benefit from an intervention. So there is no point of getting the MRI for this patient. Just to show you some recommendation on what people are recommending, the American College of Neuroradiology and the American College of Radiology and the Society of Neurointerventional Surgery have made a joint statement regarding TIA and stroke. They say non-contrast CT with digital angiography or non-con with CTA, MRI with MRA, or equivalent options for clinician. So which one you should use? They said we recommend to use the CT-CTA since it's available for everyone, easily obtainable, and the turnaround time is very fast. If you're able to make your MRI and MRA as good as CT and CTA in terms of the turnaround time, so you do it, you're able to read it, you're able to make a decision, then yes, go for MRI. It's much better choice. I like there is no much evidence to say emergency department MRI. I only found like 1 or 2 papers, and this one is really kind of nice paper, but it doesn't talk about acute emergency department. They wanted to assess the MRI utilization and ED observation unit. So those patients came to the emergency department, they made a decision to admit them, but they don't want to admit them to the medicine floor, just to the ED observation unit. So this was a single trial, retrospective, 2013 to 15. They had around 25 or 24,000 patients. 19% had at least one MR. 62% of these MRs were brain MRI. 31 were spine. So as you can see, the neuroimaging agrees with what we mentioned before. It was like around 93% of the MRI is used for neuroimaging. So they did not find any significant difference between the median length of stay for patients who had an MR or patients who didn't have an MR. This again goes with the point I mentioned in the beginning. It is more of an operational question than a clinical question, the utility of the MRI in the emergency department. The limitation of this study was a retrospective single. They did not assess for the chief complaint, nor the reason for order, nor for the outcome of the patients. So I love the studies or the papers when they have, the capsule for the readers, and they ask you 4 questions, what you're adding and how you're going to change the practice. So this is what they say, well, how does this improve the population health? MRI are regularly performed in observation unit, and we should focus on determining which MRI are appropriate and which can be done as an outpatient test, and also consider the cost. This is a wonderful paper. You can take a picture of it, you can read it. It talks about all the MRI modalities in the emergency departments, the pros and cons for every single modality. I'm just going to mention a little bit about what they mentioned about the MRI of the brain. So the 2018 guidelines for an early management of patient with acute ischemic stroke, CT, or diffusion-weighted MRI with perfusion, both recommended and considered equal in patients with selected for mechanical intervention. This guideline was also promoted by the American Heart Association, American Stroke Association, and endorsed by the Society of Academic of Emergency Medicine and many other societies as well. So I like this paper. It was done in Nevada and Phoenix in the United States. Introduction of dedicated emergency department MR machine to see if it's going to facilitate their work. They have a full neuro centers. So they looked at how it's going to reduce the number of CTs. So their conclusion were, can I significantly reduce the number of CTs in the ED by providing what? Diagnostically superior and safer imaging alternative to the CAT scan. This was achieved by a couple of points they had to do to reach this result. They alternate their MRI imaging workflow. They alternate the existing protocol of the scans. Both emphasize the efficiency and the patient throughput. Again, this tells you it's an operational question. Increased confidence in clinical decision making for the ED physicians. And MR imaging technologists and neurosurgery residents were the only people in the study kind of didn't like, when they did a survey, they didn't like the option of having an MRI. Basically, neurosurgery resident, because MRI is very sensitive, so they were called more frequently to assist patient, even though it was like non-significant finding, and the technologist, they has to stay and work more hours to be able to do the new protocols. Then they really did not address, or they didn't have enough evidence to address any improvement in the patient outcomes. This just tells you the protocols that they created. The whole idea, have a protocol so you make it easier for the emergency physician when he wants to do a specific study. He doesn't have to think or order, then reorder, then call the radiologist or the neurologist to pick the right protocol for the specific problem. And this is how they changed the flow. It's wonderful. See the time that was taking to send the patient from the emergency department to the 4th floor to do the MRI. And then when they reinstitute the whole process and had the MRI in the last lower picture inside the emergency department, they were able to save a significant amount of time in getting the MRI. This another protocol I found promoted by many institutions. Just have protocol for your physicians. Brain MRI, reason for the exam, what is the best modality of MRI? We assume that emergency physicians do know all the MRI modalities for the specific pathology. That's not true. That's not true. We should make it easier for you to order which kind of MRI with gadolinium or without contrast for which pathology, based on a protocol agreed upon by neurologist, neurosurgeon, and emergency department, and radiologist at the same time. So, as promised, I'm not going to take more than 15 minutes. My big home message, it is an operational question more than a clinical question. And the use of MRI by emergency physicians has been increasing. We can't stop that or deny it. It's critically important for emergency physician to understand the basic of the imaging modality, indication for MRI, limitation and obstacles for MRI, and know your cautions and contraindications before you obtain an MRI. All these may increase the time, turnaround time for your MRI. Well, with that, I conclude my talk and will be happy to receive any questions. Thank you very much.
Thank you very much for this excellent talk, Dr. Canlı. Is there any question or any collaboration? Please.
Thank you for a good presentation. Sir,
do you have any idea more than 2 Tesla MRI effect of body, long-term effect on body?
So that's a wonderful question. I put slide in the beginning. There is no evidence that says it causes harm so far. Even they did it in a pregnant lady. They had 2 big, large group, I don't recall the number, around 2,000. They couldn't find any long-term effect. However, the problem is usually with the contrast, the gadolinium. So the gadolinium does cause some nephrotoxicity, but now they're using different modality of the contrast that really doesn't cause much harm. So that is that evidence-proven problem with the MR. But the MRI per se by itself, even for pediatrics or for pregnancy, there is no any evidence until now that I'm aware of that says. If you have any ideas, I'll be more than happy to hear from you.
Thank you.
Thank you, Dr. Gentile, please.
Hello everyone, now I'm using a different hat and becoming a moderator. So it's my pleasure to introduce the next speaker, Dr. and Professor Kumar. He's a consultant and head of Department of Emergency Medicine, Deputy Head of Clinical Operations, Dr. Mehta's Multi-Specialty Hospital, and he's a National Joint Secretary of the Society of Emergency Medicine in India. He's course director of multiple programs. He's a member of the Royal College of Emergency Medicine and Masters in Emergency Medicine. So please welcome him to the board. He will be talking about double-edged knife contrast medium in the emergency department. Thank you, Doctor.
Thank you very much, dear chairpersons, and it's my pleasure to be here. This is my 6th visit to Turkey, and it's always wonderful to come and meet all great friends here. And my talk for today is going to be on contrast medium, and when Dr. Errol gave me this topic, I clearly know what he wanted me to speak on. He wanted me to speak on, forget about all the other investigations, speak on an ultrasound, right, because that's his passion. Anyway, so let's go ahead and see contrast medium use in ER. I'm sure all of you sitting here and all of us sitting here use a lot of contrast every day in and day out. Before we go on to the main talk, let's slightly understand what is this contrast medium, what does it actually mean. Contrast mediums, and then the use of contrast mediums in an emergency department, and then let's see what are the risks involved by using contrast mediums in an emergency department, some of the complications associated with contrast mediums, and how do you mitigate those complications. This is going to be our agenda for today. Right, so what is a contrast medium? The first sentence or the definition of a contrast medium is very important for us to understand. These are used to supplement the capabilities of various imaging modalities. Whenever we use this word supplement, that always means there is an alternative available. So this is very important for us to understand that whenever possible, try to avoid a supplement which is a contrast. I'll tell you why in the forthcoming slides. Basically, there is oral contrast, IV contrast. For the sake of today's presentation, we will only stick to IV contrast. These contrasts are basically iodine based. They could be ionic and non-ionic, either high, low or iso-osmolar. This osmolarity is very important because most of the trouble because of this contrast medium is because of the osmolarity. So we will come to that later in our forthcoming slides. And the recent ones, we use a lot of non-ionic, iso or low osmolar. These are the recent contrast mediums which we use to reduce complications. And MRI scans, there was a question to the previous speaker on MRI use. They're currently with MRI, we use a lot of gadolinium-based contrast. So this helps in reducing the complications associated with the contrast medium. Right. So what are the indications of use of contrast medium? There's a lot of controversies in use of contrast medium, whether we should use contrast in an emergency department or whether we should pick up a different kind of imaging modality or a higher imaging modality. There are a lot of papers supporting and opposing. So usually we prefer IV and oral in abdominal CT. In case of an uncomplicated appendicitis, diverticulosis, nephrolithiasis, mesenteric ischemia, portal vein thrombosis, any brain CAs, bowel obstructions, and these are some of the indications which we use contrast media in emergency department, which most of us know. And for contrast in CT, brain basically to delineate tumors, CVT, carotid and vertebral artery dissections, and any aneurysmal bleeds. And there are contrast-enhanced ultrasonographies. I'm not sure how many of you still use it. This is basically used for solenoid injuries, bleeding hematomas, and abdominal aortic aneurysms. So these are some of the common indications which we use contrast in an emergency department. But there are a lot of controversies surrounding it, whether we should be really using a contrast medium to diagnose all this, or shall we use a simpler medium like, say, an ultrasound, or whether you should go for an MRI. So, but that's not the context of our study. What is the problem of using a contrast medium in an emergency department? What are we worried about? Basically, when you look at an emergency department, what are the types of patients who walk in? This is a new patient who walks into an emergency department. Basically, he needs a radiological investigation with a contrast. You have no idea about this patient before. You want to assess whether is it risk for him to develop any kind of a reaction to the contrast. So basically, you do a risk assessment for some. If somebody falls into the risk category, you need to decide what are the types of investigations you're going to do before you subject him to any kind of a contrast exposure. This is two. You will also have a set of patients who will come and tell you they have had an history of allergic reactions or complications to contrast before, but unfortunately you still have to do a contrast for them for various reasons. So this is the third group. So you've got a new patient who's coming, you've got to assess whether is he risky, is he in the risk group for developing any kind of an issues. You have a group which comes in and says, yes, I have a problem with contrast media before, but unfortunately you need to do a scan for him. And the third group is clearly somebody who has got high risk. So I'll talk about that a little later. So what is the problem with the contrast medium when we're talking about? Any contrast medium, we basically talk about only two things. One is a hypersensitivity to the contrast itself, which is very difficult to predict. And then everybody knows there is a renal injury which is associated with any contrast medium. The renal injury could be acute or this could be delayed. So let's talk about that a little more. And there are some non-renal complications, some of the important complications which we will talk about, but as I told you, these are iodine based. So whenever I talk about iodine, clearly there is a thyroid involvement here as well. So let's talk about that a little more in detail. Right. Who are these patients at risk? In other terms, who are the patients who walk into an emergency department who really need a creatinine levels before going in for a CT? So this is a common practice where we keep them all waiting to get their creatinine levels before you subject them for CT. Right? But do really everybody need a creatinine level before you subject them for a CT scan? That's what we need to think about. Right? Who are those people who are really at risk? That's why the history is very, very important. Anybody gives you a previous history of allergy, not just to allergy to contrast medium, but anybody who has got more allergy-prone tendency, frequently comes in with an allergy for anything, be it for a footstep, be it for hay fever, for example, they are at high risk for developing a contrast allergy as well. Anybody who has got an atopic tendency. Somebody who is severely dehydrated, they are more prone for renal injury, so you need to hydrate them well. Extremes of age, somebody who is less than 5 years of old or more than 60 years are clearly at high risk group, so clearly these are the populations where you need to screen their creats. Somebody who has got a serious illness and chronic debilitating, any kind of nephropathies, diabetic nephropathy for example, these are the people who are at very high risk. Those with anemia, anybody with co-medications, for example metformin, which usually impairs your renal excretion, and anybody with malignancies. Typically this is your high risk group, and this is exactly what you need to elicit from the history to see whether this patient needs a creat or not. A young healthy patient, say a 25-33-year-old walks into the emergency department, you want to do a contrast for him, he doesn't fall into the risk group, do you really have to keep him waiting for a creat? That's a big question mark. There is no indications for him to actually get a creatinine before you subject him for a contrast CT. All you have to do is take some precautions. Right. So who are those people who are going to get creatinine pre-screening? These are the indications clearly. Those who have got history of anatomical variations in the kidney, like horseshoe kidney. Those who have undergone renal surgeries before. Those who are in renal endangering medications, like be it NSAIDs. Those who are nephropathy prior, like diabetic nephropathy, hypertensive nephropathy. Those who are in prior renal dialysis or malignancies, nephropathy-associated chronic diseases, and drug interfering with renal excretions like metformin. So these are the people clearly you have to get a creatinine levels before you subject them for a contrast exposure. Right. Alright, so here is a patient who needs an urgent CT. He has got a known history of allergic reactions. Right. We're talking about adult patients here, not pediatrics. What is the best way to manage a contrast reaction? The best way is to avoid contrast in the first place. Look at an alternative options if available, either an MRI or an ultrasound scan which can give you an equal sensitivity and specificity. On those diagnoses, try to prefer that. Try to avoid contrast medium. But unfortunately, if you cannot, these are the medications which you will prefer before subjecting him for CT scan. Before subjecting them for contrast exposure, be it MRI or CT, where usually you give steroids, hydrocortisone 50 mg IV every 4th hour until the procedure is complete, plus diphenhydramine 50 mg per oral or 25 mg IV 1 hour prior to the procedure. If allergy or contraindication to steroids, it's still possible because these are the people who have atopic tendencies. Pre-medicate with diphenhydramine 50 mg per oral or 25 mg IV 30 to 60 minutes prior to the procedure. So these are the people who needs pre-medication before subjected to CT. Right? What is the problem with contrast media? Why are we worried about renal injuries? What is the mechanism behind this renal injury? What is the problem statement? This is the osmolarity, as I briefed you some time back. There is an ionized contrast media was postulated to cause this extracellular fluid shift in the renal cells, leading to the cell dehydration, and there is increased intracellular fluid viscosity, which precipitates the cellular dysfunction. This is exactly the mechanism behind renal injuries in use of contrast. So, because of the high osmolarity of the contrast media. So how do we mitigate this? So ensure that the patient is well hydrated. I'm not talking about somebody who's already in a renal failure. This is about a normal patient who's at high risk group. Clearly make sure you hydrate them well, the urine output is adequate. And you can also give them soda bicarb infusion. I know there's a lot of practice of giving soda bicarb, NAC, theophylline, statins, diuretics to mitigate this. Clearly there is no studies which shows benefit over each other. As long as you hydrate the patient well and maintain good adequate urine output, you don't require any of the other agents like soda bicarb or NAC to prevent renal injuries. Right? So when you come to the non-renal injuries, so what are the possible complications you might get? You might get mild, moderate and severe symptoms. Like mild symptoms might range anywhere from anxiety, chills, cough, dizziness, flushing, headache, itching, nasal stuffiness. The moderate symptoms, the bronchospasm, wheezing, hypotension, dyspnea, laryngeal edema, severe anaphylaxis, and the severe symptoms includes convulsion, arrhythmias, and profound laryngeal edema as well. So how do you manage any mild symptoms which originate with the use of contrast media? Clearly, you use diphenhydramine 25 milligrams either as per oral, IM or IV route, and you might repeat or increase the dose up to 50 milligram. And hydrocortisone steroids, usually 100 milligrams IV push over a minute, and adrenaline in case you think the patient is landing up in severe anaphylaxis and IM. That's a standard treatment for any anaphylaxis as such. Right? If it's a moderate symptoms, remember the patient might exhibit both sympathetic as well as parasympathetic symptoms as well. If there is a vagal involvement, clearly the patient might show bradycardia. So in these patients, you actually require atropine, and anybody with hypotension and tachycardia, so clearly it's an anaphylactic kind of reaction. So put them on adrenaline IM. And anybody with a respiratory distress, clearly beta-2 agonist, and as well as anybody can even develop seizures. So lorazepam is the standard treatment of choice. So there is a possibility of rebound for any of these patients to develop allergic or atopic reactions after the use of contrast media. Usually happens about 6 to 12 hours later. So how do you mitigate that? Usually we use steroids, either hydrocortisone or methylprednisolone, 50 milligram 1 to 2 minutes every 6 hours, or methylprednisolone 40 milligram every 1 to 2 minutes for next 6 hours. So this is how to prevent rebound. So what are the renal immediate injuries, which is contrast-induced acute kidney injury? We call it as the recent terminology CIAKA. So this is abrupt deterioration in kidney function manifested by an increase in serum creatinine level with or without a reduced urine output. So it clearly states that you don't have to have a reduced urine output. Your creatinine levels is a single identification factor for the involvement of kidney damage in case of a contrast. And any contrast which is used intra-arterially clearly has got more risk than compared to an intravenous contrast to develop renal injuries or acute kidney injuries. Right, so how do you measure that? So there's a diagnostic criteria for contrast media induced acute kidney injury. When the absolute serum creatinine increase is greater than or equal to 3 milligram per deciliter, it's clearly because of the contrast, and increasing the percentage of creatinine before and after the study is more than 50%, clearly this is because of the contrast. And if the urine output reduced to less than or equal to 0.5 ml per kg for at least 6 hours, you can think about contrast-induced acute kidney injury. And as I briefed you earlier, clearly urine output is not a clear indicator for contrast-induced nephropathy. Always think about the first, which is in creatinine. So always a creatinine value more than 3 or more than 50% increase from the previous value. If you could remember these two, that would be great. Right. So there are certain delayed renal complications as well, which not many of us think about or deal with this as this is beyond the scope of EM. clearly there is a nephrogenic systemic fibrosis which happens, especially with gadolinium-based scans. Right? This is extremely fatal, and the most complicated issue in this is you cannot identify it through any of the scans or any of the investigations. So clearly these are the patients who undergo contrast scans, and after 2 or 3 days or about 4 days, you clearly see them deteriorating and in a cardiac arrest, and you are sometimes attributing that to the primary illness, but there is a reason, which is nephrogenic systemic fibrosis, which is a result of a contrast-induced nephropathy, so which might kill the patient as well. So you may think about this condition. Not many of these come across regularly. So when I talk about delayed complications of a contrast media, there are clearly non-renal complications, because most of your renal complications are immediate. It will manifest within 6 hours. And there are some delayed complications like thyroid complications, which may happen to 1 week post use of contrast. Iodine-provoked thyroid functions, auto-regulation, so hyperthyroid kind of symptoms, high risk of hyperthyroid status patients. So that we need to understand. So in general, our take-home message is, how do you have safe renal practices? Anybody with patients with a serum creatinine more than 2 grams is clearly at risk. Try to look at an alternate treatment modality for these patients. Ensure that they get adequately hydrated before you put them onto the contrast. So anybody who has got a creatinine borderline, hydrate them. Even before hydrating them, think about any alternative modalities, and if you cannot, then you subject them for contrast medium. Don't put them on contrast directly. Somebody who has got a renal disease, but you still produce urine, consider alternative. Do not put them on contrast directly. If you don't have any other alternative, use the lowest possible dose of contrast as possible. Use intermediate or low or smaller and or low risk gadolinium-based contrast media. Clearly nowadays there is non-ionic and low or smaller contrast mediums available, so your radiologist will suggest you that. So try to use those, and that's followed by a prompt dialysis. In case if the patient is already an end-stage renal disease patient who makes no urine on full-time dialysis, you really don't have to worry because there's no renal tissue for you to damage further, so you can think about using the full dose of contrast. So these are the 3. So this is my take-home message for today, and I'm happy to take any questions. Thank you.
Thank you, Dr. Saravana, for this excellent speech. I will take your questions for you because you will leave early today. And is there any question for this topic? Or any input? No question. Thank you.
Thank you so
very
much.
much. Have a nice day. Now, as a third speaker, I want to introduce Dr. Mustafa Kesap from Antalya Research and Training Hospital, and he will talk about the perspectives of abdominal computerized tomography.
Good morning, everyone. My name is Mustafa Kesap, living and working in Antalya City Center, Training and Research Hospital. My speech is about abdominality today, the personal pitfalls and advantage and disadvantage. Also, I want to speak about why we are using. I will give you some epidemiological features of the CT and what is the indications, advantage and disadvantage, my objectives, and end of the presentation I will speak about the future of the abdominal CT and some of the special groups I want to explain to you today. And there are some numbers on the presentation, as you see that approximately 20 years the CT or total CT is growing almost 10 times, but at this period, for 20 years, just the patient flow is approximately 5 times is growing. So that's why we are using abdominal CT in our department so spread. And in Turkey, just 11 million people, 11 million CT scans in all of our hospitals we are using also in Turkey. These of them, the CTs, when you look to the abdominal CT is 10 times more, according to the others. The other is thorax CT is 5 times much more. And 25% CT is, we are evaluating our emergency department. So we are using spread also. And there was a meta-analysis also here. We are using approximately for adult people 17% around of, for children 5% around of, and for the older people almost 1 over the 4 older people we are using CT in any way. That was huge numbers also. And which indications we are using, especially first of all lower quadrant pain, first of all. The second one is flank pain. The third one is abdominal, non-specific abdominal pain. And the fourth one, we are using left side of the abdominal pain. We are using in our departments, my friends. Why is the increasing of the CT? Because CT is available everywhere, in almost residential room. When you go to any hospital in Turkey, in all over the world, machine was so spread, machine was so located, all of the hospitals almost. And in Turkey, for example, if you are working outside of the centers, you can find easily much more than ultrasound or the other modalities. I mean, you are taking to the CT, you are sending with telemedicine Ankara or Istanbul center. There was a radiologist on the table and he getting the comments, so sent you to back 1 hour, 2 hours later. It's so easy for the clinician, so especially general practitioner in our rural area in Turkey. So we are reaching to the cities much more easy to other modalities. And then another one is for Turkey, for example. We are so crowded emergency departments. We are so many patients flow we have. So we are getting to the, we are afraid of the, all of us, afraid of the malpractice. So sometimes we have to make defensive medical decisions. And what was the, so we have also some procedural advantage. We have what was it on it? First of all, non-dependent to the person on the same as ultrasound, and the second one, abdominal gases or adipose tissue, sometimes not connected to image quality. And especially in trauma patients, we have visualization of the retroperitoneal area, so excellent. So some of the new technologies is improve our image quality. Multiplanar reconstruction also transfers sagittal coronal and multi-vector machines available all over the world. So as on the picture, as you see, we are using, and especially life-threatening indications, we are using these modalities. I mean, abdominal aortic aneurysm, thoracoabdominal dissection, intraabdominal hemorrhagia, penetrant abdominal trauma, mesenteric ischemia, blah, blah, blah. And then the others, mostly, especially in children, for diagnosis, for differential diagnosis, appendicitis, renal stones, especially adult people, hernia, we are using these indications of the abdominal CT on ED. American College of Radiology suggested that 4 different variations of the abdominal CT using in ED. First of all, one of them is abdominal pain plus fever, abdominal pain plus fever plus no surgery or yes surgery, and the other one, abdominal pain plus neutropenia. All of them is appropriate modalities of the evaluation, it says to the American College of Radiology. And also, maybe the most important one is the fourth variant, non-localized abdominal pain, and none other, any specialty. I mean, most of the people, same as like this position, and it suggests to us CT abdominal pelvis with IV contrast, usually appropriate. CT abdominal pelvis without IV contrast, usually appropriate also, and also suggests to us MRI modalities. And also, my friends, how was diagnostic efficiency? Why we love so much abdominal CT for evaluation of our people? Because it changed our management of the patients. I mean, approximately 50% to admitting rates, to changing our diagnosis. So we are loving. You see some of the papers here, approximately 50% changing to the diagnosis, 25% changing to the surgical plans. Also, there was a review article also, you saw that there was a changed modalities also. You see that here, at this column, you saw that almost 40% to 60% changing our management of the patients. So we are using so much, so we are loving abdominal CT in our departments. And also, we are using penetrant abdominal trauma. Also, it says to us, FAST plus selective cases of the abdominal CT is gold standard also. Especially trauma people, it suggests to us also gold standard. Also from Turkey, a paper, CT guided tractography also. We evaluate some of the penetrant abdominal trauma, much more easy, much more excellent type of the management. And on the summary of the abdominal CT, it provides more accurate diagnosis to us, cost-effective, non-personal dependent, fast and most of the gold standard modality. And then what was the disadvantage of the abdominality? First, radiation exposure. Approximately 10 millisievert, according to your machines, approximately 10 millisievert radiation exposure is one of after the one of abdominality. I am speaking about the adult people and speak later on children. And then 10 millisievert, what it means, I will try to explain to you. And if you get 100 millisievert effective radiation dose, 100,000 people, one of them is getting triggering to the solid cancer. So, especially if you are using on brain, you are approximately, especially in children, 2 or 3 times leukemia and glioblastoma, you are triggering also. So, for example, in 1945, after the Second World War, who survived to Japan, they get approximately 50 or 60 millisievert who survived. So, if you get 5 or 6 abdominal CT on your life, you are getting to your survival of the Second World War equal to your radiation exposure. Also, this picture is, I think, maybe on your brain today because of risk is almost small. As you see here, we speak about 10 millisievert, but after around of 0.2 to 0.3 around of the percent, we coming to the malignancy of the abdominality. But if you are getting 100 and maybe 150 millisievert radiations, you are getting to the much more radiation also, my friend. And let me continue. Some of the mechanisms, some of the recommendation to reduce to the effect of the radiation, as mostly is speaking on it, to reduce to the dose of CT. I mean, most of the CT machine is using 120 kilowatt energy level of the radiation. So if you reduce this energy 100